close. Good morning, everybody. I am Dr. Kanhu'S Radiology. I am a radiation oncologist practicing in Visakhapatnam. Teaching is one of my hobby. So, when I was a student, that time we struggled a lot. That time no Google was there. So, we have a struggle a lot to understand the radiology, understand the radiotherapy. Apart from that, when you are coming to the contouring guideline, the radiology is the major important things. Today, without much introduction, I am going to teach you the radiologists for the oncologists. Whatever the things we want to know, what is CT MRI correlation, what is the target delineation correlation, target delineation correlation, and identifying the structures, what are the things required in the day-to-day practice. Apart from that, basic principles of the investigations we have to understand. I have 6 modules. You can interrupt any time, ask any questions, but you have to go by this disclaimer. Okay. So, but you can ask whatever I answer. If I am not able to answer, I will take forward to in future presentations. One thing. Second thing, I have basic presentations on the what are the normal radiological investigations required in the oncology practice. Second, CNS, then skull base, then abdomen, thorax, and head and neck. Head and neck is a major chunk that will take more time. So, I am keeping the head and neck at last, but I will finish all these things. So, you can if it is there, if people are interested, I can have another chapter also called CNS radiology for the stereotactic treatments. So, it is your option. I will not, I will try my best to explain you. So, see how we can go forward. You can bring this so that it will be comfortable to her. Please come. So, if possible, I will finish 4 chapters in the morning session and possible 2 chapters in the afternoon session. I am the whole day with you people, do not worry, we will go slowly as you like. If you want to finish early, I can go, I will finish early also, but it is up to you. So, coming to the first presentation in my today topic, it is the normal radiological investigations what we are going to practice day by day. So, I will present you X-ray, CT scan, barium studies, mammogram, ultrasound, image storage and transfer, MRI, PET-CT, bone scan. So, in radiation exposure, if you see the X-ray, mammogram, CT scan, fluoroscopy, nuclear imaging, PET, bone scan and others are radiation things, but MRI, PET-CT, MRI, Doppler and ultrasound, there is no radiation exposure at all. If you see the energy, if you see the X-ray energy of the, if you see the evolving the energy, you see the in airport security how much X-ray we are getting exposed comparing to the CT and mammogram and the. So, this is the good table, you can see it is available in Wikipedia. You can go through this and see the how much energy we see from the simple X-ray. X-ray is 10 keV, mammogram is 100. Medical CT is 100, that airport security is 100. So, this is the energy and these are the diagnostic, we are not using in the therapeutic. So, again you can see what are the dose exposure as a radiation oncologist, you can see the how much millisievert is we are from dental X-ray to gallium scan. So, if one chest X-ray is how many CT scans you understood? Sorry, one CT scan is how many chest X-rays? So we write, as a radiation oncologist, we write left, right, CT scan, CT scan, CT scan. You can analyze one CT scan is how many X-rays. So in describing the tissues and organs, ultrasound is, as you know, hypoechoic, hyperechoic, and isoechoic. Like that, CT scan is the isodense, hyperdense, isodense. In MRI, it is isointense, hyperintense, and hypointense. So let's start with X-ray. He is the person who from Germany, as you know, 1895, Konrad Röntgen, he described the, he discovered the X-ray, and he is the first X-ray of his wife. When his wife came to give the lunchbox to the institute, he asked to put the in X-ray. That is the engagement ring, what our wedding ring you can see here. So X-ray production is a sudden deceleration of electron from when they collide, interact with the target anode. So from cathode, it is electrons are emerging, and in sudden deceleration in the anode, they will get the X-ray. Very simple, as you know, 1% of energy is converted to X-ray. So this is the thing, you know, this is the cathode. The electrons are moving, and X-ray, we get the X-rays. So this is the X-ray things you can see here. This is the how they take X-rays. Mostly chest X as a common practice, you see chest X-ray, PA view is the common practice you do. In a common practice in oncology, you ask for chest X-ray mostly. Apart from that, spine, epilateral, erect abdomen, and skeletal surveys. When you ask for the suspecting the multiple myeloma, in skeletal survey you will get a questions if you are a PG student, what are the skeletal surveys X-rays are like skull, spine, pelvis, extremities, and PNS and mandible. So why epilateral is very important, you understand this picture. So always when you are asking for the spine as well as the shoulder and arm, always ask for the epilateral. So fluoroscopy, another is a X-ray based mechanism where you can see the movement of the inside organ with using a contrast. It is also involves the X-ray. So if you see, this is the fluoroscoping machine. Two things I will tell you, when people are using in the orthopedics departments, and when we are students, when that time CT based brachy and MRI based brachy was not there, we used to very comfortable to do the fluoroscopic C-arm. And conventional simulators we have in your institution or old conventional simulators, this is the main X-ray production. So this is the fluoroscopic mechanism where you can see your swallowing structures and everything in this where it is used. Conventional simulator, as I told, the conventional simulator is the same as a machine without any treatment. Your couch movement, your coordinates, your gantry, your couch, your collimator, everything is there. Only to take the help of when there is a CT based planning, MRI based planning was not there, it is the most useful tool for the conventional 2D planning and 2D plannings. Let's start with the various barium studies. What is barium studies? Barium studies is nothing. We are giving a barium, either liquid is a thin liquid mixing with barium, it is inert substance. After that, we ask the patient to swallow, and you take as a fluoroscopic or X-ray as per your requirement. So there are types of barium studies. You are a barium swallow, barium meal, barium follow through, barium small bowel enema, and barium enema. So why are not using now? So these are the most structural, mucosa, malignancy, and also you can see easily when the people, your teachers, your parents, when they studied in your institution, when that time nothing CT scan was not there, this is the very useful method they use it to study. But why I am telling today? Because when you are going for the head and neck radiation, you ask for a swallowing test. In swallowing test, how patient is swallowing, how you can see the strictures, everything you can analyze it through a barium study. Malignancy, you should do the carcinoma, ulcer, growth, strictures. In benign also you can do that. But now it is not useful. It is mostly replaced by the endoscopy, colonoscopy, CT scan, all the things. So, imaging X-ray, AP, PA, lateral, oblique, supine, prone, serial. After giving barium, take n number with fluoroscopic examination. You can, if interest also, you can plan for the fluoroscopic method. So, fluoroscopy is nothing, as I told, you give the barium and there is a moving X-ray, it will take your the X-ray pictures. You no need to write anything, just listen. I will give you the presentations, take and study at home. Nothing to worry, nothing to hide. Okay, just listen. So, this is the fluoroscopic mechanism where you can see the swallowing structures, how it is moving and everything you can understand from the picture. After radiation also, the patient comes to for the follow-up. When they are studying, you can ask for the swallowing test. You cannot every time, poor people, they cannot go for endoscopy. It is a very, it is easily available in your institution. So, what is the double contrast? When you keep some gas or air, inert air, apart with barium, it will go inside, it will lining the mucosa and everything. You can study the mucosa very nicely if you use the double contrast. What is the positive contrast? When you put barium or a barium like substance, negative contrast is the air. This is called double contrast. So, this is the barium sulfate where they use, and thin liquid they use, how it is insoluble and odorless. Sometimes when there is obstruction, patient is not able to swallow, you may get aspiration type of these things and you may put in trouble. So, aspiration and constipation, anaphylaxis and impaction, these are the main issues when you have to keep in mind. Contraindications, if you don't have hypersensitivity, obstruction, perforation and fistula is there, don't do that. When tracheoesophageal fistula is there, you don't try it. Barium swallow, nothing. When you are understanding the barium, how the oropharyngeal structures are there, just ask give the barium and ask to swallow, either you take and X-ray or fluoroscopy. So, as you know, this is the fluoroscopic mechanism. In your PG examinations, they will put this picture as they will ask those two conical structures in the upper and two conical structures down. That is, the upper structure is vallecula and down structure is the piriform fossa. So, this is the picture they will ask in your PG examinations. Barium meal, nothing, just going forward to the lower GI tract. You just give the barium. After putting the barium inside, they will see the esophagus, stomach and duodenum, and before that you need some laxative and empty stomach. So, you can study the stomach wall, duodenum and some part of the jejunum. You can see where the pylorus is there, where is the, how is the mucosa, how is the these things you can. It is also helpful when suppose a patient is there, CS stomach, there is some irregularity in the upper stomach mucosa, you cannot appreciate in the CT scan. So, you can put some barium and you can see the mucosal wall, where is the disease or not. Even oral contrast is sufficient also during CT scan, you can see like this. Double contrast, if you put, you can air with contrast, you can see the mucosa so nicely seeing here. You can see the mucosa very nicely. Sodium ball follow through, after you can want to see the follow through, you want to see the motility of the small bowel and motility of the intestine. You can put these structures more after GI fluoroscopic study, you can grossly you can evaluate the motility of the bowel. So, this is the small bowel follow through. You can see how the things are there. Another thing, you can see barium meal follow through. If you put in erect position, you can see everything in so nicely, stomach, body, antrum, pylorus, duodenal cave, all things you can see so nicely. Sodium ball barium enema, here they what they will put, they put the Ryle's tube to the jejunum and they push the barium. So, you can see the some strictures how they analyze the jejunum, ileum, all structures. Then barium enema, nothing, same procedure, you give the enema barium towards the through rectum, and after that you take the serial X-rays and to understand the so they will give barium enema, and after some time they will see, you can see the all rectum, anal canal, rectum, sigmoid, descending colon, transverse colons, ascending colon and cecum. So, this is the usual procedure. But how it is obsolete nowadays? Because of CT colonography, endoscopy. So, why I taught you today? Because in the future when you do not know something, you may have some confusion when you are correlating your structures. After procedure, patient may have a drink plenty of fluids, abdominal bloating, and patient might have a whitish stool. This is all about the barium studies. Any questions? Okay. Another thing, when we are doing oophorectomy, we are giving chemo, we are giving radiation. After this all things, our bone density goes down and down. Though it is not much practiced, if you go to the medical oncology people, they ask for the DEXA scan so frequently. What DEXA scan tells you? DEXA scan tells you about the bone density of the person, so that prophylactically you can give vitamin D and calcium, so that to prevent all things. So, what is the DEXA scan? DEXA scan in full form is dual energy X-ray absorptiometry. So, this is the bone density study. If you see, when they go for the DEXA scan, they will ask, this is a different instrument itself. So, they will ask the patient to lie down and then flex position. So, they will take X-ray of both pelvis, both hip and lumbosacral spine. So, this is the thing, what is the thing. So, they will measure by two methods, one is T-score and Z-score. How to understand the T-score and Z-score? It is not your headache, but you should understand what is T-score and Z-score. So, this is the formula of T-score and Z-score. Do not put your head, just remember it is a T-score and Z-score. But how to interpret? If your T-score is 0, 1, it is normal. If it is -1, it is osteopenia, and -2 to -4, it is a severe osteoporosis. If you do not give some calcium supplementation or bone strengthening agent like bisphosphonates, patient may go through the fractures. Then understood? Then basics of CT scan. CT scan, simple, it is a like rapid arc, it is a X-ray arc. So, like CT scan means computed tomography scan, it is a use X-ray images. He is the person who received Nobel Prize, and he introduced the device by 1972. So, if you see, this is the set of lasers, this is the couch, this is the control panel. So, this is when all things are taken care, it is called CT console. This is the circular X-ray, the X-ray was absorbed by body and it reflects. After reflection, it is a detection. In detection, which reflects more, some tissue reflects more, some tissue reflects less, some tissue speedy reflection. So, to understand all these things, they produce the images. So, this is the X-ray source here, this is the detector, and this is the couch. So, when patient goes in moving, country moves. Previously, first generation CT, second generation CT scans, only couch moves one circle and move. So, now helical spiral CTs 128, 256 slides also there. So, this is the spiral CT. So, how it happens? After the scanning, the image reconstruction, they send the digital image. After digital image, they convert to the analog image. So, to understand better, they give the contrast injection. In contrast injection, there are ionic contrast and non-ionic contrast. Ionic contrast, chances of anaphylaxis is more. Non-ionic contrast, so it is a good, and that is a people mostly using the non-ionic contrast. And if always, even if you are doing the CT scan in your institution, always put the anaphylaxis kit by the side, so that it will not be a problem when there is a anaphylaxis. Preparation, as you know, 4-hour fasting is required. There should be no renal issues. Take a consent and give the anaphylaxis kit in your console. So, two things people will ask in your exam, what is bore and what is the FOB. Bore, it is the diameter of the opening, CT opening, there is a diameter, and this is the total. So, 70 centimeter is required in the normal diagnostic CTs. For the radiation plannings, we need more than 80, 85. So, FOB is the diameter of image. bore is the diameter of the opening of the CT. So, this is called FOB. So, red cone is the bigger FOB and yellow cone is the small FOB. So, if you take small FOB, suppose you are studying the spine, if you want to take the whole abdomen, you may not get proper image and proper resolution. So, when you are suspecting some lesion, you call for the small FOBs. Density, as you know, brain is the reference. If it is looks like brain, it is called isodense. If it is more than darker, it is the hypodense, and if more brighter is the hyperdense. And how to analyze the CT number, otherwise the Hounsfield unit. So, different to different tissue related to the composition of tissue. So, what are the things looks darker? The looks darker is the air, spinal fluid, ischemic infarct, edema and white matter. Remember, white matter looks darker in the CT. Same thing, radiodense structure, hyperdense are bone, metal, calcium, blood and grey matter. Grey matter looks whiter in the CT. So, this is the like pH you studied in your group. So, water is the 0 and minus the 1000 is the air and plus 1000 is the bone, that is called windowing. So, I will tell you what. So, according to Hounsfield, so they are giving the Hounsfield units, air is minus 1000, water is the 0 and bone is the 1000. So, if you drag your mouse, click the Hounsfield unit, put in your the various structure, you can see the various Hounsfield units here. So, this is the air, it will be in the minus 758. If it is bone, it is 275, 278. Like that, various structures you can. Why it is important? Again, in a radiation practice, suppose there is a lesion in the chest, it may be a solid lesion or it may be a cystic lesion, which is water or a pleural effusion. You just drag your mouse, click there Hounsfield unit. If it is the water value, it will take as some cystic fluid. If it is a solid, it take as a solid mass. So, window width, window level. So, how can I change the window width and window level to improve the resolution, to improve the quality of the picture, to understand the picture, the brightness and contrast. If you go to the PowerPoint presentation, there is a two icons called brightness and contrast. Okay. In this, like this, CT scan also the brightness and contrast. Brightness is the changing of the whole image brightness. Contrast is the changing the brightness inside the image. So, if you see the left side, right side of the image, you see the brightness, whole image looks bright, but here the face is looking brighter. So, it is a contrast changed, this is a brightness changed. How to change this, how to handle this manually things in these situations. So, this is as you know, this is the soft tissue window, this is the lung window, this is the bone window. So, these are the mediastinal window, this is the one is the called contrast and width or window level, window width. So, if you see, if you drag, put your mouse, click the window, drag horizontally. If you drag horizontally, window width will change. If you drag vertically, the brightness will change. If you drag diagonally, that will your brightness and darkness both will change. So, you go, if you have a system in your PAX system, you can see and you can do this practice to understand the window width and the window level. So, this is the typical window width, window levels of various like head and neck, brain, these are there. You can get it very easily in the Wikipedia or Google. No need to remember all things, but very few things you have to remember, like bone window, lung window, skin window, liver window. These 3-4 things you can remember. It is for the mainly for the radiologists. Then is the slicing, either may be axial, coronal and sagittal. Axial from skin from top to bottom, coronal is the anterior to posterior, sagittal from the side to side. So, this is the sagittal picture, this is the coronal picture and this is the axial picture. So, there is no problem. Hope you remember all these things. Then coordinates, this important, x, y, z coordinates are very important, as well as the imaging, as well as the radiation planning. So these are the coordinate system. Sometimes we get some artifacts, actually image got distorted, that a distorted image is called the artifact. It may be due to the ring artifact due to the machinery issues, it may be the motion artifact if patient moves during treatment scanning, or it is a contrast agent or the dental artifact, if there is a dental material is inside. Then we will go for the mammogram. Any doubt? Shall I go ahead? Mammogram. Mammogram, again it is a study to understand the breast density and breast lesions. So this is X-ray picture of the breast, low dose X-rays, breast to understand the breast disease in the woman. Procedure, it is nothing, in the inside they will compress the breast in two plates. In these two plates they will take craniocaudal view and oblique view X-rays, and they will understand. So this is the how they you just go to your institution, go to the mammogram radiology department, see the mammogram how they are doing. It is also a clinical experience. Why it is important? When you are planning for the radiation boost to the breast lumpectomy cavities and everything, you can see how it is important, this thing. So this is the conventional mammogram. In this conventional mammogram, it looks very hazy. Where with evolving of the mammogram machine, we have a digital mammogram, and that converts X-ray into mammographic picture. It stores inside the system, and resolution will be better. So digital mammogram, either digital mammogram or something, whatever may be, the pressure and the discomfort to the mammogram to the patient is the same. So this is the with the digital mammogram, you can see the some muscles, some density, good resolution with the contrast resolution you can see here. Like that, slowly they developed a 3D mammogram and tomosynthesis. Like that, where X-ray is rotating around this thing, you get a CT scan. They rotate the X-ray around the breast. They will take as a arc and they will form the tomosynthesis. So this is a reconstructed image and higher doses than the normal mammogram, and discomfort is the same. So this is called, why it is so important? You will get a very good resolution. You will get you can go track mammogram tracking biopsy. So this is also one concept. This is the mammogram tracking biopsy with a clear image and a greater accuracy. So now this is the 3D digital technique. You can see the axillary nodes here also, and this is it is in the mesh tomosynthesis. So when you know X-ray, when your teacher is asking, how can you tell me what is the mammography picture? Always use the magnifying glass, either in form of software or the normal X-ray. If you don't use the mammography, this thing, they understand that you don't know mammogram. So always you have to handle the X-ray reading with a by magnifying glass. So as you know, BIRADS, breast imaging reporting and data system, where you will study the reporting the grade 0 to grade 5. As you know, A, B, C, D also there. You can go and study like BIRADS, lung, liver, lyrads, oriads, ovary, pyrads, tyrads. When you just request your radiologist, when they are giving the reporting, please mention the which this group and BIRAD systems. Then computer aided detection, artificial intelligence slowly coming into the system. Okay, then I will go to the soon. Yes, sir. C norm. Sonogram. No, sir, I don't know idea. Okay, I will find it. Then ultrasound, nothing. It is a no radiation at all. If there is a, you can want to diagnose the understand the diagnose. You can possible with ultrasound. So go with ultrasound where there is no radiation is exposed. So usually the hearing is a normal hearing frequency is between 20 to 20,000 kilohertz, 20 kilohertz. But this ultrasound uses 2 to 18 megahertz. So, animals they can hear this sound, that sound is used for the ultrasound study. So, again as I told, it may be hyperechoic or hypoechoic or isoechoic. So, this image comes up, they have to going through a transducer, they will palpate with a transducer with some liquid agent, and this is called when you can what is the useful. So, in our practice, because C cervix is very common, when you are finding some lesion or something, even transvaginal ultrasound, transrectal, when there is a vaginal stenosis after radiation, you can ask for the transrectal ultrasound, you can study, and transesophageal ultrasounds, endoscopic ultrasounds, these are very useful techniques to understand the procedures. This is the transducer or a probe, this is the transvaginal ultrasound, this is the transesophageal ultrasound, and it is used, this is the another is the Doppler ultrasound. Why it is important? In the Doppler ultrasound, it is always important to understand the blood flow, either vein, either vessel or heart. When heart, it is called 2D-echo. When there is a deep veins and the arteries, you can see when the patient present with the C cervix, he presents with the DVT. This is the common practice to ask for the color Doppler ultrasound, Doppler of vein bilateral limb. It is so you can see the presence of deep vein thrombosis. You can so this is how they do, how the vessels looks like. So this is all about basics of the ultrasound. Then we will go for the MRI. MRI, as you know, there is also no radiation, and that is known as magnetic resonance imaging. So parts of MRI, it is a magnetic field, gradient coil, radio frequency coil, and computer system. He is the MRI invention, Raymond Demodian. He died in this August. So he is the legend who invented the MRI, 1977, and before that the nuclear magnetic resonance, the spinning of the molecule inside the magnetic field known as NMR is given by Isaac Rabi. So both have received the Nobel Prize. So as a patient going to the MRI, so there will be magnetic field and gradient coil, and that is a radio frequency. So and this is the radio frequency coil. So this is the computer system. So this is the radio frequency transmitter, the gradient power supply. So when you give radio frequency transmission and gradient power supply, there will be magnetic change, and we withdraw the radio frequency transmission. Automatically, some transmission happens, that is called Fourier transmission. We no need to understand all these things because we are not radiologists. Just understand basic. So that Fourier transmission gives the image and receives you will get an image. Let's see again another way. Sequence of events in MRI: patient, then application of magnetic field, application of radio frequency, withdrawal of radio frequency, release of energy, Fourier transmission, and conversion of analog to digital image. So this is the image. So release of energy, like in CT, release of X-rays, in ultrasound, release of sound. So as per the density of the bone, soft tissue, you will get various softness and hardness of the tissue, you will get the image. There are two things, TR, TE, TF. So based on this TR, TE and EF, you will get various sequences, T1, T2, all these things. So this is the physics of MRI, you can study. So what happens really? Our body contains 70% of water. So in hydrogen atom is a magnet. So you can see two hydrogen atoms, all particles contain a hydrogen atom. So they are randomly arranged. This is called Larmor frequency. No need to remember. But when you apply the magnetic field, it becomes alignment. This alignment called parallel or anti-parallel arrangement. When you give radio frequency, it will go to the 90 degree. Again, if frequency, it will be 180 degree. So really stop the radio frequency, it will come to the same position. So after same position, some energy will be transmitted. It is called Fourier transmission, and this transmission is going to store in your giving rise to conversion to image. So quickness of release, very stage per tissue gives the differential image. So, you may get structural image, got functional image. The sequence, what is the sequence? T sequence, T2. The variance events happens in MRI is called the sequence. So, playing with the TR, TE and this, they will play with these three systems to get various sequences in the. Thank you, sir. Yeah. So, as you know, hypointense black, hyperintense bright, isointense is the gray. So, this is the all basics of MRI. Then we will go further understanding the bone scan. In bone scan, what is a bone scan? It is a scintigraphy scan or a radio tracer scan of axial skeleton whole body scan. It can help the diagnose a number of bone conditions either from benign or normal or malignant. So, we have to use one radiopharmaceutical agent. Then what is a radiopharmaceutical agent? Radioactive agent plus pharmaceutical agent is together known as a radiopharmaceutical agent. So, it is a radioactivity and vector molecule, it will go to the target. So, these are the various radionuclide scans in day to day practice. Some are available, some are not available in every vicinity. You will thyroid, as you know, iodine scan, cardiac, MOGA scan, brain, BB scan, neuroendocrine endotoxin scan. So, n number of table is there, you can see here. Like radionuclide therapy, same thing, you can go for the thyroid iodine therapy, bone for samarium therapy, lutetium therapy, prostate lutetium, neuroendocrine lutetium, DOTATOC therapy, medullary MIBs therapy. No need to write, presentations I will give you. So, this how they happen? So, this is a radionuclide production, there is a hot, that is radioactive precursor or hot precursor, this is the pharmaceutical agent, they combine together, they give the injection, this is radiopharmaceutical agent will go to the specific tissue, then you take the image. So, scintigraphy also known as a gamma scan, 3D form is known as a SPECT scan. So, he is the radio tracer who invented, is the he received the Nobel Prize George Hapsey, and who is to understand the receive the gamma emitting is by a detector is known as a gamma camera. He is the Hall Langer, he also received the Nobel Prize for the gamma camera. So, this is the bone scan machine, patient has to lie down inside the bone scan machine, and this is a radiopharmaceutical agent, they will give injection by technetium 99 and they will take a picture. So, how in indications like malignant, unexplained bone pain, suspicion bone mets, primary tumors, benign osteomyelitis, osteoarthritis, trauma, metabolic bone disorders. So, procedure after giving the injection, they will ask to wait for 4 hours and you have to more hydration and go for the evacuation repeatedly, they will take anterior posterior scan. So, how to they explaining the patient giving 20 millicurie of technetium 99 MDB injection, frequent voiding and hydration, scan after 3 to 4 hours of gamma with a gamma camera. So, no preparation required, hydration voiding is required. After procedure, stay away from the children and pregnant lady, at least twice flush after toilet. Technetium has a half life of 6 hours, so 1 day precaution is required. So, this will after injection, they will put for the frequent voiding and hydration, then they will take the scan, they will take the planar images, APPA. So, you may get osteoblastic lesions like this, extensive bone mets, and what is super scan? Super scan is nothing, because of extensive bone mets, the all precursors are, all tracers are occupied by the body, there is nothing to excrete. So, in the kidney, so you can kidney cannot be visualized. So, this is called a super scan. If you see the old picture, so this picture you can see the visualize the kidney here, but in extensive bone mets you can extensive bone you will not able to see. You will not able to see the kidney. So, this is called a super scan. Then normal optics you have to understand properly joints, trauma areas and growth hands, and diagnostic correlation when there is in doubt you do the SPECT CT, PET CT, MRI, CT correlation. So, this is all about the CT scan. Then we will go to the positron emission tomography. Positron emission tomography, as you know, it is the agent emits a positron. So, positive electron. So, it is again using of a radiopharmaceutical agent, we can use most commonly use the F18 FDG. Again radio tracer agent, radiopharmaceutical agent, you have to give injection attached to the specific organ, it emits gamma, there is a detector and that detector converts to the digital image. So, this is the usual procedure. So, as I told, so you are giving a positron, it collides the electron, it will produce 5112 gamma energies, and this energy is detected by the detector and it will convert to the digital image. So, as you know, you can see here, this is the so this is the procedure after giving the injection, this collides with electron and this is the 2 energy, these are the detectors. So, and after detection you will have a various PET image, and if fuse with the CT image you will get the PET CT. Even now the PET MR is the new concept, new machine. So, how it is a PET CT, if you compare it to the CT, PET CT is a dual gantry. So, this is the PET CT, then you will do the PET CT fusion. So, front gantry is the CT, back side gantry is the PET, these are the detectors. So, if there is a so you have to after CT scan they will take the PET CT and they will fuse it. So, there are so this you will get the PET CT scan. So, these are the various tracers used in the like fluorodioxin carcinomas, lymphomas, gallium scan PSMA for the prostate and brain, gallium DOTATOC is the neuroendocrine tumors and meningioma, methionine is the brain, sodium fluoride for bone mets, thyroid tumor hypoxia if you want to study the misonidazole, and like n number of tracers are there and n number of tracers are under evaluation. So, this is the PET. So, when we are studying at a Tata Memorial Hospital, that time there is one unit and like that they will give the images. So, you can always we just find out okay, this the lesion may be in the lung or maybe bone or something. That time CT was not there, then slowly PET CT came. So, you will go to the better resolution, this is the PET CT. So, why it happens? This is the again he is the received the Nobel Prize, what is called a Warburg effect, where malignant cells have increased glucose utilization. Once in the tumor cells, FDG converted to the FDG 6-phosphate metabolically trapped in the tumor cell, and you will increase the FDG uptake in the tumors and you will see the uptake. So, for the uptake, FDG uptake, FDG preparation and all things, you need a cyclotron. It requires more investment as well as a big area. So, every place it is not possible. So, they what they do importing it is through air travel, they brought the some curie of injection and they do in the institution. So, there are like Hyderabad, Bangalore, Delhi, Bombay, the same particular centers are there, though through air travel they will give that, but gallium chambers are there where they can produce, they do PSMA, DOTATOC scan, no need for the cyclotron. This is the FDG molecule, I am not going to detail. Then before studying, you have to study these are the normal uptakes in myocardium, brain, brown tissue, adipose tissue, alimentary tract, genital tract, bone marrow. So, these are the main uptakes, normal uptakes. Before understanding the abnormal uptake, you have to understand the normal uptake. How to understand the standard uptake value? So, how to study, there is a unit is known as a standard uptake value. SUV is the activity region of interest by injected activity. So, they will. So, why it is important? Before chemotherapy, after follow-ups. So, this is a prognostic importance and diagnostic importance. In oncology, benign from malignant, staging, radiation planning, prognostication, you can identify the necrosis and residue. 1, 2, 3 slides about the tear and test, where tear if they are mostly used in the liver study. So, liver HCG treatment, they will give radioactive tracers inside your feeding vessel. So, how it will go? So, it will they will find out where is the tumor, where is the feeding vessel, they will push the yttrium labeled embolization radio tracer, they will block the artery and that radiation emitting it will go on. So, tumor will lies. This is called tear. In TACE, transarterial chemoembolization, where they will push inside the feeding artery with chemo and they embolize. Then it automatically it will block the tumor feeding vessel, and chemo also will kill the tumor tissue. If you want to go on understudy econtour.org, you might be knowing all this site. It is very easy case by case study. It is given, it is freely available. You understand the econtour.org. Then how to the images transfer to your department, to the CT scan, to the MRI scan, to the your planning system. This is called DICOM, digital imaging communication in medicine, that known as a DICOM images. When you are sending, please send the DICOM images you are right to the your CT scan or MRI people. So this is the system. Without DICOM, you cannot do the plannings. This is another system where the storage system happens. You are doing lots of CT scans, MRI in your department. You can, somebody brought the CD from the outside, you can store. This is called picture archiving communication system, or called PACS. This is economical storage of all the data, all the slices, and for the future. So the image is, format of the image is DICOM, storage transfer is the PACS. So this is called PACS and DICOM system, how it works in your department. Then if you have a heavy file, some of your person is here, he wants to take a opinion in the US MD Anderson MSKCC. So you have to send all files, so much data. There is a system called wetransfer.com. This is free. You upload your all images there, they can download and see. Thank you. This is my chapter 1. Another 5 chapters are there. Hope you understand. Anything you can ask, no problem. Feel free to ask. All presentations are there. I will give you at the end of the day. Hope I cleared most of the diagnostic investigation. Anything? Any criticisms, comments? I will not mind. Please tell me. Okay, just 5 minutes. Relax. If you want to take a cup of tea, by another 5 minutes, I will start the CNS imaging. It's very important in these things. So another 5 minutes, I will start the CNS imaging. So in our second chapter, we will study the CNS sequences, how to ask for the MRI in a radiation oncology department, what is the how to understand what is T1, what is T2, what is the ADC, what is the DWI, all these things we will study. So in this flow, I will tell about the basics, identification, meninges, baselets, etc. till the plaques. So what are the basics? As a radiation oncologist, as you know, where is the target? If you give some extra tissue, you will have a toxicity. If you take less adjacent tissue, you may have a high chance of getting the recurrence. So it is the very important where is the target and what is the OUR, and good. That's why we need a good resolution. So MRI is the good resolution. So what immunizations you have? CT, we have a plain contrast, cysternography, angiography. MRI, we have a plain contrast, MRI cysternography, MR angio, MRS, other functional sequences and nuclear imaging, and digital subtraction angiogram. So remember T1, this is a T1. Why T1 is important? You understand the normal anatomy. So if you want to see white matter, white looks white inside and gray matter looks black or hypointense. So this is the normal T1 sequence to understand the normal anatomy. Then if you give injection, you can see the vessels, some meninges that will enhance. Then T2 sequence is there are two T2 sequences are there. One is the T2 plane and a T2 flare. In a T2 plane, you will see the images, all white fluids, it will be dark, white, brighter. You see the all fluids are brighter. So this is a T2 sequence. And even aqueous humor, vitreous humor, eyeball looks brighter. but vessels looks black. Okay. How to understand the T2 player image? T2 player image is nothing, it is the inversion of T2 image, where you can study the pathological fluid or this is called pathological fluid looks brighter. So, you can differentiate, if everything all fluid looks black, it is T1, if all fluid looks brighter, it is T2. If you are going to see ventricular oozing, you can see the ventricular oozing here, this looks brighter, this is called player sequence, and any pathological fluid you will see the bright. So, this is the T2 where ventricles and pathological fluids looks brighter, but if you want to see where you can differentiate between the pathological fluid and ventricle, you can take a player image, you can see the ventricle looks black or darker and pathological fluid looks brighter. So, identify now, this is the T1 where all fluids looks darker, nothing to worry, blindly see the fluid. If you understand the fluid, that is sufficient to identify the MRI. So, all fluids looks black is T1, all fluids look white T2, ventricular oozing, you see the ventricular oozing here, you see the ventricular oozing, you will not ventricular oozing anywhere. So, this ventricular oozing, ventricular wall oozing, it is a player, very simple, no need of the Einstein mind is required to understand these three images. T1 all fluid black, T2 all fluid brighter, T2 player is the ventricular oozing. Then one image is called ghost image, that is called diffusion weighted image. In ghost image what happens? The image looks like a ghost. What is that meaning? If you understand the fluid movement inside the brain parenchyma, you have to understand the diffusion image, that is called apparent diffusion coefficient. So, if you see diffusion weighted image, if it is a malignant, there is a hypercellularity. So, water flow is not proper. If water flow is not proper, it looks bright in the diffusion weighted image. If it is a ghost image, so if you see there is a fluid restriction and the fluids looks, so that area, if there is more malignant in diffusion weighted image, more brighter. Understood? More brighter, more malignant. Corresponding MRI image is called ADC map. So, how much restriction is there? How we will understand? To understand how much restriction is there, you have to study the ADC map, apparent diffusion coefficient map, which is dark, brighter here, it becomes darker here, but it is a T2. You can see all fluids are white. Nothing. ADC map is a brighter of T2. Sorry, brighter of DWI. So, these things to required. This is the ADC map. So, if you see the ADC values, if ADC value is good, it is a good for us. If ADC value is low, it is a more malignant. You see the WHO grade 1 tumors having ADC values are 2.5, but WHO grade 4 it is 0.66. Like that, craniopharyngeal benign lesions, this is the things, malignant lymphoma less. So, if it is a good ADC value, it is a good for us. If more ADC, less ADC and more brighter under diffusion weighted image, it is more malignant. So, when you are sending a patient for the brain tumor to planning MR, so how to understand the planning MR, how to see, you can send, they will take n number of scans, that they will take n number of images, which is not in, can somebody close the door? I guess, sorry. So, if you ask, this is the protocol you have to send. So, this is called MRI brain, you have to write there. It should be contrast if it is a glioma. If it is a metastatic lesion, if you are finding out, you have to ask for the delayed contrast, double and triple dose of contrast. If you give double and triple dose, you will able to find the small lesions also in the brain. You are doing, if you are planning for a SRS, single lesion, but if you are planning for a SRS, ask for a double or triple contrast, what will happen? You will find your resolution, your size, number, all will increase. Ask you one, take a try once. Then you have to ask for T1, T2, flare, 3D FSPGR, there should not be gap, no tilt. ऐसे टिल्ट हो जाएगा, you cannot fuse with CT and MR. Neutral neck, 1 mm slice and 5:1 to 5:1 matrix. These things has to be done. There is a sequence called 3D FS-PCR sequence. In 3D FS-PCR sequence, you can identify optic chiasm and optic apparatus so nicely. But the worst thing in the MRI is every company have a different name. Same sequence, every company have a different name. So 3D FS-PCR is a sequence in the GE sequence. If a GE machine in your department, then you ask for 3D FS-PCR. If you have a Siemens, you have to ask for a MP-RAGE sequence, MPRAGE, MP-RAGE sequence. So how? And FOB should contour full body contour. They will give some slices, half small FOBs like brainstem area, up pituitary area. So you cannot fuse properly. So you should. So you can send this slide to them and give them that we need this type of image. So if you are asking for a normal anatomy where even the optic apparatus, brainstem, all these things, ask for the 3D FS-PCR. Pituitary adenoma. If you are asking for a pituitary adenoma patient, you have to ask for a STOR sequence. What is the STOR sequence? Patient having after spinal surgery, they will put some packing material inside. This packing, you have to differentiate this packing material from the pituitary tumor. So you need a fat suppression sequence, that is a STOR sequence. Trigeminal neuralgia, you have to ask for the Fiesta sequence. Cranial nerves, CICS sequence. CP angle tumor, if there is a cerebellopontine angle tumor is there, it may be a meningioma, it may be a schwannoma. If there is a small hemorrhages, small cystic changes inside the tumor, you ask for the GRE sequence, that will, if there is there, that is a schwannoma. In meningioma, you will not get any cystic changes or hemorrhages. Like a glioma, you can ask for the diffusion and perfusion. AVM, you can ask for the angio sequence. Grading of tumor, it is low grade, high grade, you can ask for MRS. Metastasis, you have to ask for double, triple, delayed contrast, and diffusion and perfusion. So what is FS-PCR sequence? You see, you can see this optic chiasm is so nicely it is here. Okay. So as I told, G sequence is FS-PCR, Philips is CFFE sequence, Siemens is MP-RAGE sequence. Okay. Fiesta sequence is another sequence where you can study all cisternus and ventricles properly and cranial nerves so nicely. See, when you want to study, this is the cranial nerve. You can see this, study the cranial nerves here. Internal acoustic meatus, 7th, 8th nerve, you can so nicely. So what is that sequence? Fiesta sequence. Another sequence is called STOR sequence. When the patient has undergone pituitary surgery, they will put the packing material. So if you take a STOR sequence, you can see the packing material and pituitary differentiation. So you can see here how the packing material looks brighter. Then MRS, MRS is nothing to understand the chemical nature of the brain tumor. So mostly it is looks like this: choline, creatinine. So if you see the three things you have to study properly. One is the choline, creatinine, Na and lactate, lipid lactate. So if you see, this is the normal brain. Choline is down, creatinine, and neuronal activity always better in Na. If Na is N-acetyl-aspartate, if it is decreases, means neuronal activity is decreased. And choline is peak, means it is a big malignant tumor. You can see here. So as I told, Na is good for the body, choline is a bad, lipid lactate is the ugly metabolite. What is the lipid lactate? If there is a necrosis, if there is a lymphoma, there will be increase in the lipid lactate level in the chemical structure. So if you see this choline creatinine ratio, you have to determine low grade gliomas. High grade gliomas, it is a choline creatinine ratio is 3.9 and Na has decreased from the 1.36 to 1.2. So this is the things you have to understand properly. MRS, low grade glioma. So if somebody radiologist given MRS, it is a low grade glioma. So ask them, sir, please give the choline creatinine ratio, and they will compare with normal, compare with the malignant lesion. Please give the table. So, MRS meningioma, if there is suspicion of there is a meningioma or schwannoma, you ask for a MRS called MRS alanine, you will get the peak. MRS angio, when MR angio, when DSA is not there, you are treating in the vascular malformations and AVMs, cavernomas, you can ask for the MR angio. MR perfusion, as you know, malignant tumors having more blood flow, new angiogenesis. If you ask for a perfusion, you will get a blood, you have to study the blood flow, regional blood flow. So, if it is increased, it looks the image looks like that area looks like a malignant. So, it is looks like reddish and this thing. So, you can understand either if a patient comes to you, patient having a necrosis, patient having a glioma, whether it is a necrosis or recurrence, you, how do you know? You ask for a perfusion, ask for a MRS, you can understand which is the malignant and is the benign. Gradient echo sequence, as I told before, if you see the schwannomas having the cystic lesions and hemorrhages, schwannomas having cystic lesions, hemorrhages, meningiomas will not have any cystic lesions or unless high grade glioma or high grade meningiomas. So, you can differentiate easily in the gradient echo sequence. So, meningioma you will not find the cystic. MRI brain, basics clear, what sequence whenever requirement is clear, nothing to write, I will give all presentations at the last, take to your home and study. Then MRI spine sequences. So, why MRI is better? You do the CT and you have to understand the MRI soft tissue extension, MRI how resolution is there, where is the thecal sac involvement, where is spinal cord involvement, you have to grading. So, these are the necessary for the GTB, CTB and PTB. Before going that, let us study the anatomy first. This is the vertebral body, this is the spinal canal, this is the pedicle where the anterior and posterior compartment combines together, this is the spinous process, this is the lamina. So, according to the, when people are fond of doing those SRS and SBRT spine mat, you can see they have divided into 6 sectors, sector 1, 2, 3, 4, 5, 6. The vertebral body is the sector 1, like that you go to the clockwise, there is a 6 compartments. So, like that if you can see what is the body, this is the spinal nerve root, here the nerve roots. Why this is important? When you are treating the spinal cord for CSI, you have to contour this area. If you miss that, you will have a problem. So, this is a, see how the, this is the spinal cord and this is the CSF. So, its CSF looks brighter. Which sequence? T2. If you go to the sacrum, this is the spinal canal and these are the sacral, this is the ala and this is the sacral base. This is the iliosacral sacroiliac joint. So, let us see, when you are asking for the study for the thecal sac and spinal cord ends, always ask for the sagittal sequence, where sagittal sequence is the, you can see the spinal cord here, how it ends here. So, you can understand where spinal cord ends. But as you go down, you can see the thecal sac ends where it, you can see in by scrolling the images. So, to understand the end of the thecal sac, to understand the end of the spinal cord, you have to go for the sagittal sequence in T2. So, what are the spine sequences? T1, T2, star, T1 contrast, Dixon, diffusion weighted image, susceptibility weighted image. So, we will go to the basics, I am not going to the complicated ones. So, basic sequence T1, T2, inversion required in post contrast, advanced sequence is the diffusion weighted, susceptibility image, Dixon images and dynamic constant change. So, how to understand these things? What is T1? Again, how to identify all these things? Where is T1? What is T2? And there is star. Again, what thing I told? How to see spinal fluid. So, see the spinal fluid, it is dark. So, it is a T1 undoubtedly. T2 spinal cord is CSF is white, very easy. Another sequence like flare sequence in the brain, it is here is the inversion sequence. How to differentiate? So, it is a very tricky. You can see both CSF is white, T1 and T2 and star. You have to see the abdominal fat or back fat. If you see, the back fat is brighter in T2, CSF is brighter in T2. But here in inversion sequence, back fat looks darker. This is the basic identification differentiation between T1, T2 and inversion sequence in the spine. So, very easy. Remember abdominal or back fat. So, how it differentiates? As you know, any lesion it hypointense in T1. Contrast if you give, you can see the enhancement and dynamic post contrast is to assess the vascularity, and T2 it is brighter. Inversion sequence more brighter because normal fat is getting suppressed. Then diffusion weighted images also you can see how the it is a malignant lesion or something. So, some lesion is there, either it is a lytic or blastic lesion, you want to differentiate. Another sequence called susceptibility weighted image, that is called SWI. And so, how our target volume differentiates? This is the CT, it is a T1 contrast, T2 and inversion recovery. If you combine together the DWI image, whatever the looks brighter, if you contour, it looks more volume. So, if you analyze all images properly, the chances of missing the your target is less. Understood all sequences, MRI sequences, it is hope. The ventricles slowly. So, as you know, we have a lateral ventricle, third ventricle, fourth ventricle and central canal. Lateral ventricle having frontal horn, occipital horn and temporal horn. So, this is lateral ventricle and third ventricle communicate with it by foramen Monro, and third ventricle and fourth ventricle communicate with the aqueduct. So, as you see, this is the third ventricle, this is the fourth ventricle, it communicates with the fourth ventricle, and this is the lateral ventricles. So, third ventricle and fourth lateral ventricle by interventricular foramen, and foramen Monro third ventricle, lateral ventricle, and there is an aqueduct between the third ventricle and fourth ventricle. So, let us see, and again another picture, if you see interventricular foramen or foramen Monro, this is third ventricle narrowest part, and this is the diamond shaped is the fourth ventricle. No problem. Let us see in the CT images how it looks. So, this is the lateral ventricle, no problem. This is called frontal horn, this is called occipital horn, this is the body. So, how MRI it looks like? This is the occipital horn, this is the temporal horn. So, why temporal horn is so important to us? When you are contouring the hippocampus, for the hippocampus evidence whole brain artery, you have to start your contouring from here. Then this is inside the brainstem, you will get a small foramen like structure, this is called aqueduct, it will through which lateral third ventricle and fourth ventricle communicate with each other. So, you can see here, this is the snake hood, this is a snake, the fang is the midbrain, this is the gland, this is the pons, and this is the medulla. Okay. So, in this you will get this is called a aqueduct through which third ventricle and fourth ventricle communicates, and this is the diamond structure, this is the fourth ventricle, then it is thus become the central canal. Okay. Let us see again. This is the narrowest part, third ventricle, it is a straight line, finger straight line, this is a in axial sequence you will like a straight line, this is the third ventricle. So, let us see, this is the midbrain, this is pons and medulla, this is the fourth ventricle. In fourth ventricle, there is a two lateral openings, one central opening. So, two lateral openings also foramen lustra and medial is the foramen magendi. As you see, foramen aperture is called foramen magendi and lateral is the foramen losca. So, this is the foramen magendi, to lateral is the losca. Understood? Any doubt? No problem. Let us study the grey and white matter. Our brain is mixture of grey and white matter. White matters are fibers, grey matters are the nucleuses. So, nucleus communicate with each other by white matter fibers. So, as you know, this is the grey matter nucleuses and white matter. This is the grey matter, this is the white matter. In spinal cord, so outside is the grey matter, inside the white matter. In spinal cord, it is the reverse, as you know. So, if you want to study the proper grey matter, white matter, which sequence you need? T1 sequence. But in CT, the white matters looks darker, grey matter looks brighter. So, as I told, T1 sequence you have to study white matters and grey matters properly. So, this is the table which looks darker and which looks white. You can go ahead. Why grey white junction is so important? Because most of the metastatic lesions stuck there, and we will find the metastatic lesions at grey white junction. Another is that stroke and tumor. If there is a cellular swelling, grey white margin is lost. In tumor, grey white margin is retained. If it grey white margin is retained, it is a tumor. If it lost, it is some other problem. Grey and white in spinal cord, as you told, it is become reverse. Okay. So, grey, you should know these things only. You no need to go and which fiber, white fiber, no need. Unnecessary, don't strain your mind. The meninges, as you know, dura, pia and arachnoid. Dura, arachnoid and pia matter. Pia matter is attached to the brain. Dura, it is attached to the skull. So, as you know, the meninges, dura matter, arachnoid and pia. So, dura, subdura, the dura, then subdural sinuses, that sagittal sinus, sinuses are there, then subarachnoid space, then pia matter, then the pial vasculatures. So, let us see, this is the skull bone, this is the dura, this is the arachnoid, this is the pia and dural vasculatures, pial vasculatures. Again, you can see the dural sinuses here. So, this is the thing, and these are the, even why this important, I am showing this slide, because your CS dural sheaths going to the nerve roots. So, in CSI planning, this is important to interventricular foramens, you have to contour properly. So, this is the dorsal and ventral horn, and this you have to contour properly. So, if you want to study proper durameter, there is called a spino-echo sequence, but no need, don't stress your mind. But if you see normal meninges, they are irregularly enhancing, non-enhancing, enhancing. So, it is irregular enhancing, but if it is metastatic, if you see this pial meninges will enhance, continuous enhancement, here discontinuous enhancement. So, this is a leptomeningeal spread. Understood? Leptomeningeal spread, you will get the continuous enhancements and all things, but in normal you will get patchy enhancement. Here you will get here enhancement, here no enhancement, like that. But here you can see the pial enhancements, how it is going continuous enhancement. Same thing you can see here, this is the leptomeningeal spread in the spinal cord. So, leptomeningeal spinal spread in spinal cord, you have to study in the sagittal picture. You cannot appreciate in the axial and coronal section. Ask up to sagittal picture. Then this is the flux, this is the tentorium. Why it is important? When you are planning for the posterior fossa boost, you have to contour the tentorium properly, then treat the tentorium. Understood? Very simple. Whatever you want to remember as a radiation oncologist or oncologist, I am telling only that. I am not going to the detail, so that it don't strain your mind. Then we have to study sulci and gyri. So gyrus is the swelling and sulcus is the furrow. So you can see this is the sulcus, this is the gyrus. You can see. So how to differentiate, why it is important? When there is a extraaxial mass, when there is a intraaxial mass differentiation, you can see the CSF impingement or CSF cleft sign in meningioma. Meningioma is a extraaxial mass, glioma is a intraaxial mass. So what are the other extraaxial mass? Like schwannomas, pituitary tumors, skull tumors. So all are extraaxial. Gliomas, ependymomas, all other things are intraaxial mass. So you just imagine, this is the intraaxial mass going and compressing the sulci. Suppose one tumor is coming outside and compressing this one, so you will get some CSF inside, that is called CSF cleft sign. I will tell, if I will get an opportunity to tell you how to understand the tumors, I will tell later. So this is the sulci and this is the gyrus. So there are various fissures and sulci we have to remember for our understanding of the brain tumors, and when a neurosurgeon sends to you, you should not fumble where is the tumor actually. So in this, to understand this is a clock presentation. What is the clock? This is a interhemispheric fissure. This is a interhemispheric fissure to divide the two hemispheres. Then it is called frontal, 1 to 3 is the frontal. 4 is the omega sign, it is the central sulcus. Anterior to is the precentral, posterior is the postcentral gyrus. Then bifid sulcus, 5 and 6. So this sulcus you should remember. Not much, no need to see. Why you want to see? Either it is a tumor in the motor cortex, it is a tumor in the sensory cortex, you can identify, you can see properly. So this is interhemispheric, this is the superior frontal sulcus, this is the middle precentral sulcus, this is the postcentral central sulcus, this is the postcentral sulcus, and this is the parieto-occipital, intraparietal sulcus. Okay, let's see in the MRI how it looks. So these are the central sulcus, precentral, postcentral. So this is the interhemispheric fissure. So this is the sigmoid hook, central sulcus. It is easy. You can go slice by slice image in your image, you will get it. Then this pars bracket sign you can remember or not remember, no problem. Then parieto-occipital sulcus, here you can see there is a parietal lobe and occipital lobe differentiation. This is the central sulcus. This is the fish-tail parieto-occipital sulcus. I am not telling about this Muste's sign and all things, you will get confused. So this is, you remember on the omega sign, sigmoid hook and central, precentral. And this is the, if you want to remember small sulcus, it is your choice. Then another sulcus is called callosal sulcus and cingulate sulcus. This is a pars marginalis. So again, frontal lobe has a suprafrontal sulcus, suprafrontal gyrus. You can see suprafrontal, middle frontal, inferior frontal. It is a temporal, supratemporal, inferior, middle temporal, and inferior temporal. So lateral you can see. So suprafrontal gyrus, middle frontal gyrus, inferior frontal gyrus, supratemporal, middle temporal, inferior temporal. So this is the main things you remember. No need to remember many things. Just if you want to so keen in the tumor cranium, you can go ahead with this. Another fissure is called Sylvian fissure. This Sylvian fissure is very important. You have to separate your tumor from the temporal to parieto-temporal, parieto-occipital to temporal. So when you are contouring the temporal lobe, you have to understand this is the superior margin. So this is the frontal lobe, this is the parietal lobe, this is the occipital lobe, this is the Sylvian fissure that will separate the frontal to temporal, parietal to temporal. So this is the lobes, as you know, frontal lobe, medial, how many lobes are there? Can you somebody tell what is the fifth lobe of brain? Insula. So let's see, this is the frontal, temporal, and this is the, if you put a line horizontally, anterior frontal horn and occipital horn, the anterior is the frontal, middle is the parietal, posterior is the occipital. So this is the frontal, parietal. If you go up and up, more is the parietal, less is frontal. So this is the parietal, and you can see the slowly it changes. So you have to follow the central sulcus. So this is the called fifth lobe. This is the called insula. So if you go to the insula is the fifth lobe here. This is the basal ganglial region. So lateral to the basal ganglial region in the near the sylvian fissure, this is the insular tumor. If some insular tumors, they cannot go proper surgery for the tumor, that is insula. So this is the temporoparietal region, this is parieto-occipital region. This is the central sulcus, frontoparietal and frontotemporal and parieto-temporal differentiation. So how to temporal lobe contouring? If you want to add a CT or MR, if you are CT, it is very difficult to contour properly. So this is temporal lobe, lower part is not a big issue, posterior anterior part is not a big issue. When sylvian fissure finishes, your temporal lobe finishes. But posterior is very difficult. So you can go to this article, you divide, you put a line from the here to here, and anterior 2/3 is the temporal lobe, posterior 1/3 is the other lobe. Understood? So before that, sometimes we get confused with some calcifications in the brain, so that it will be a tough decision if you don't know the normal calcification. So there are normal calcifications you will find in adulthood: basal ganglia, choroid classifications, and pineal gland classification. Pineal gland, more than 10 years old, you will get pineal gland calcification. Okay. So these are the choroid calcified corolla calcification. This is the pineal calcification, pineal gland calcification. This is the parts of the brain calcification. This is the basal ganglial calcification. Okay. So parts of the corpus callosum, as you know, this is the genu, this is the splenium, this is the body. So why that is important? Because if you genu, body, these are white matter tracts. When your tumor is in the basal ganglia, you have to include the tracts of the opposite part. You have to contour the tract. If a CTV is coming in the brain stem, you have to include the brain stem in that area, because it is interlinked. If you miss that, you can there is a high chance of missing the tumor. So I will, if possible, if it is a glioma contouring, I will tell in another chapter. So this is called anterior limb, genu, posterior limb. This is called putamen. This is the globus pallidus. This is the area of basal ganglia. So as you know, anterior chamber, posterior anterior limb, posterior limb, star is the genu, and other is the lentiform nucleus, that orange color. Basal ganglia, why it is important? Because the millions of nerves, body movements are important for as you know. So I am just giving the pinch of idea. You don't need to remember how many cells are there, how many fibers are, nothing. We don't need also. Then understand the pituitary fossa. Pituitary fossa, if you see here, this is the pituitary fossa in the sella. Usually, you can differentiate in a normal sagittal picture which is the anterior pituitary, what is the posterior pituitary. Anterior pituitary is the slightly hypodense or isodense. Posterior pituitary is slightly brighter. You can see posterior pituitary is slightly brighter. Let us see, in the normal MRI, you can send differentiation anterior pituitary and posterior pituitary. It is not a one-day practice. If you practice many times, you will be able to differentiate. But if you give contrast, this pituitary differentiation is slightly difficult. Then this is the microadenoma less than 1 centimeter enhancement. Macroadenoma is these are the microadenoma, how more than 1 centimeter, paracellular extension, cellular extension, that is the different class actually. And if your cavernous sinus is involvement or not, how can you know? How, in which sequence I should ask the radiologist? So you have to ask the radiologist to do a T2 sequence. In a T2 sequence, all vessels looks darker, your tumors looks brighter, all vessels looks darker. So if this is your tumor, you can see this cavernous sinus whether involved or not. You cannot have difference in T1. You can differentiate T and T whether cavernous sinus is involved or not. Very nicely, if you are asking for the sequence, ask for the T2 sequence, you can able to differentiate whether cavernous sinus is involved or not. Then pineal gland. Pineal gland, as I know, it is situated here between thalamus posteriorly. This is a calcified. If more than 10 years, you will get a calcification. This is the pineal gland, posterior to the midbrain is the pineal gland. Limbic system, there is all limbic systems, limbic lobe, lots of limbic systems are there. We don't want anything, no need, only need thing to hippocampus. How to control the hippocampus used to understand. So this is the thalamus, amygdala, hippocampus, thalamus, third is the hippocampus. So I am not going to the hippocampus contouring and all, but if you want to remember all this, remember if you are going to the hippocampus, your study, if you are going your thesis, you can have to remember. Then cisternas of the brain. Cisternas is the, what are the cisternas? Cisternas are nothing, it is the dilated CSF cushions for the your brain organs. So these are the cisterns. What are the cisterns you have to know? Is the sylvian, prepontine, ambient, interpeduncular, cerebellopontine, extra quadrigeminal cistern. These cisterns, why you want to know? When you are contouring the hippocampus, again this cisterns is give the importance. And where you are treating the germ cell tumors, where in all whole ventricular radiotherapy you want to give, you have to understand all these cisterns nicely. So let's see, this is anterior to the pons is the prepontine cistern, very easy. Then this is the supracellular cistern above around the pituitary area, no problem. Then if you come to the midbrain level, this is the interpeduncular cistern. This is a interpeduncular cistern. This is the ambient cistern. This lateral is the ambient cistern. This is the quadrigeminal cistern. Posteriorly quadrigeminal cistern. Let's see. Again, this is the supracellular cistern. Supracellular. This is the ambient lateral to the midbrain. Posterior to the midbrain and pons is the quadrigeminal cistern. Why it is important? Again, boundary of the hippocampus. Cerebellum, very easy. Two cerebellums. These are the cerebellar tonsils. These are the tonsil and cerebellar hemisphere. Vermis. Three peduncles connecting to cerebellum: midbrain, pons, and medulla. Middle supracerebellar peduncle is the midbrain, middle cerebellar peduncle is the pons, and inferior cerebellar peduncle from the medulla to cerebellum. So these are the superior cerebellar peduncle to cerebellum, from midbrain to cerebellum. Then superior cerebellum, how it has to see the, you can see here, this is the cerebellar peduncle, middle cerebellar peduncle from pons to the midbrain, pons to cerebellum. This is the only things you want to know. No, not much you should know. Brainstem, you know the midbrain, pons, medulla, together it is called the brainstem. So you can see upper part is the midbrain, it is the pons, and it is the medulla. So as I told, you remember a snake, cobra, this is the midbrain, this is the gland is the pons, and this is the medulla, and continue with the spinal cord. So this is the, if there is a aqueduct, it is a midbrain. If there is a like this structure, it is the pons. Okay, nothing, very simple. Then blood supply. These are the various blood supply: internal carotid artery, posterior communicator. Let's see the way circle of wheels. Study the circle of wheels. Those circle of wheels, if you see, two vertebral arteries go they combine together from the basilar artery. In the basilar artery, and here internal carotid artery comes, and this is the combining with posterior communicating artery, this is a posterior cerebral artery, and this is anterior cerebral artery and anterior communicating artery. So two main things are the formation of circle of Hills. You see the vertebral artery, internal carotid artery, and these things are important. Why this important? When you are studying the trigeminal neuralgia, you see this is the superior cerebellar artery. This artery is the culprit. It goes and hugs the trigeminal nerve. So this will be a trigeminal neuralgia will get. So I will come to later. So these are the parts by anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. So why it is not much important, but is just for the convenient. You can remember as superior convenient. Dural sinuses, you have a transverse, occipital, superior sagittal sinus, and straight sinus. As you know, the dura mater has a two again layers. One is the meningeal layer and a periosteal layer. In between there will be a dural sinuses. So this is called superior sagittal sinus, inferior sagittal sinus. This is straight sinus. This is transverse sinus, sigmoid sinus. Let's see how it looks. So this is the called sigmoid sinus. Around your CP angle is the sigmoid sinus. So this is the transverse sinus, which is transverse. Straight sinus will come like this. So this is the superior sagittal sinus here. This is the straight sinus. This is the transverse sinus. Then what is the functions of the lobes? Why somebody asks what is the brain tumor and how it presents? So how the people will complain? So there are, you have to tell 4 symptoms. One is the irritative symptoms like seizures, focal epilepsy. Compressive symptoms, the compression of the part of the brain. Obstructive symptoms, if the ventricular system is obstructed, and functional symptoms with the functional loss of one part of the brain. So as you know, motor cortex anteriorly precentral is the motor cortex, central postcentral is the sensory cortex. So this is the thing, this is the temporal lobe, this is the, you know, what are the various functionings. I don't want to go details, because why it is important, when your patient comes to, according to the symptom, you can correlate where the tumor is locating. So this is again, this important you have to know the motor cortex and sensory cortex. So these are the which part is the important for the which vision, taste, attention. These are the various organ. Eloquent areas, surgeon told it cannot be surgery done. Whether you have to find out is really surgeon is denying or is a really problem. So these are the what are the speech language areas, vision areas, sensational areas, motor cortexes. These are the various sites where surgeon cannot do the surgery. This is called eloquent. Cranial nerves. Can I have internet inside? Huh? So most of the brain system is finished. I will tell you how to identify the cranial nerves. It is very crucial. When you are studying those trigeminal nerves, when you are trying to schwannomas, where you want to contouring the schwannomas and everything, you will have you have to identify the 7th nerve, 8th nerve, 9th nerve, 10th nerve. You can see. Just 1 minute. Huh? So you want to study MRI anatomies and each by functions, nerves and everything. It is a good radiology system is free, mrimaster.com. You go, you will understand all the anatomies so nicely, and it is given free of cost, nothing to worry. And I will show you how you go. Possible? Just can you Chrome? Just mrimaster.com. .com. Yeah. That one. Slow. Okay, no problem. So let's try itself. Next will be to understand the foraminous skull base lesions. So do we have a skull? I requested to manage system to bring a skull. Is there? Yeah. Not opening. Okay, ठीक है. You can connect to mobile also. Okay, ठीक है, no problem. I will show you later. No problem. Lunch hour, I will make it ready and I will let you know. So nicely the cranial nerves you will see from the 1 to 12th. So nicely it is depreciated. You will enjoy. Okay, go to the PPT. Then click. Go to the go. Click that one. Okay, very slow. Okay, no problem. Close it. Next slide. So this is the study CNS. What do you want to know? What are the sequences? Everything. Nicely I told you. Next topic is mine is the skull base lesions. So why skull base things are important? You can open another PPT. Dr. Kanhu'S Radiology. I am a radiation oncologist practicing in Visakhapatnam. Teaching is one of my hobby. So when I was a student, that time we struggled a lot. That time no Google was there. So we have struggled a lot to understand the radiology, understand the radiotherapy. Apart from that, when you are coming to the contouring guideline, the radiology is the major important things. Today, without much introduction, I am going to teach you the radiologists for the oncologists. Whatever the things we want to know, what is CT MRI correlation, what is the target delineation correlation, okay, target delineation correlation, and identifying the structures, what are the things required in the day-to-day practice. Apart from that, basic principles of the investigations we have to understand. I have 6 modules. You can interrupt any time, ask any questions, but you have to go by this disclaimer. Okay, so but you can ask whatever I answer. If I am not able to answer, I will take forward to in future presentations. One thing. Second thing, I have basic presentations on the what are the normal radiological investigations required in the oncology practice. Second, CNS, then skull base, then abdomen, thorax, and head and neck. Head and neck is a major chunk that will take more time. So I am keeping the head and neck at last, but I will finish all these things. So you can, if it is there, if people are interested, I can have another chapter also called CNS radiology for the stereotactic treatments. So it is your option. I will not. I will try my best to explain you. So see how we can go forward. You can bring this so that it will be comfortable to her. Please come. So if possible, I will finish 4 chapters in the morning session and possible 2 chapters in the afternoon session. I am the whole day with you people, don't worry. We will go slowly as you like. If you want to finish early, I can go, I will finish early also, but it is up to you. So coming to the first presentation in my today topic, it is the normal radiological investigations what we are going to practice day by day. So I will present you X-ray, CT scan, barium studies, mammogram, ultrasound, image storage and transfer, MRI, PET-CT, bone scan. So in radiation exposure, if you see the X-ray, mammogram, CT scan, fluoroscopy, nuclear imaging, PET, bone scan and others are radiation things. But MRI, PET-CT, MRI, Doppler and ultrasound, there is no radiation exposure at all. If you see the energy, if you see the X-ray energy of the, if you see the evolving the energy, you see the in airport security how much X-ray we are getting exposed comparing to the CT and mammogram and the. So this is the good table, you can see it is available in Wikipedia. You can go through this and see the how much energy we see from the simple X-ray. X-ray is 10 keV, mammogram is 100, medical CT is 100, that airport security is 100. So this is the energy, and these are the diagnostic. We are not using in the therapeutic. So again you can see what are the dose exposure. As a radiation oncologist, you can see the how much millisievert is we are further from dental X-ray to gallium scan. So if one chest X-ray is how many CT scans you understood? Sorry, one CT scan is how many chest X-rays? So we write as a radiation oncologist, we write left, right, CT scan, CT scan, CT scan. You can analyze one CT scan is how many X-rays. So in describing the tissues and organs, ultrasound is, as you know, hypoechoic, hyperechoic and isoechoic. Like that, CT scan is the isodense, hyperdense, isodense. In MRI, it is isointense, hyperintense and hypointense. So let's start with X-ray. He is the person who from Germany, as you know, 1895, Konrad Röntgen, he described the, he discovered the X-ray, and he is the first X-ray of his wife. When his wife came to give the lunch box to in the institute, he asked to put the in X-ray. That is the engagement ring, what our wedding ring you can see here. So X-ray production is a sudden deceleration of electron from when they collide interact with the target anode. So from cathode, it is electrons are emerging, and in sudden deceleration in the anode, they will get the X-ray. Very simple, as you know, 1% of energy is converted to X-ray. So this is the thing, you know, this is the cathode. The electrons are moving, and X-ray, we get the X-rays. So this is the X-ray things you can see here. This is the how they take X-rays. Mostly chest X as a common practice, you see chest X-ray, PA view is the common practice you do. In a common practice in oncology, you ask for chest X-ray mostly. Apart from that, spine, epilateral, erect abdomen and skeletal surveys. When you ask for the suspecting the multiple myeloma, in skeletal survey you will get questions if you are a PG student, what are the skeletal surveys. X-rays are like skull, spine, pelvis, extremities and PNS and mandible. So why epilateral is very important, you understand this picture. So always when you are asking for the spine as well as the shoulder and arm, always ask for the epilateral. So fluoroscopy, another is a X-ray based mechanism where you can see the movement of the inside organ with using a contrast. It is also involves the X-ray. So if you see, this is the fluoroscopic machine. Two things I will tell you. When people are using in the orthopedics departments, and when we are students, when that time CT based brachy and MRI based brachy was not there, we used to very comfortable to do the fluoroscopic C-arm. And conventional simulators we have in your institution or old conventional simulators, this is the main X-ray production. So this is the fluoroscopic mechanism where you can see your swallowing structures and everything in this is where it is used. Conventional simulator, as I told, the conventional simulator is the same as a machine without any treatment. Your couch movement, your coordinates, your gantry, your couch, your collimator, everything is there. Only to take the help of when there is a CT based planning, MRI based planning was not there. It is the most useful tool for the conventional 2D planning and 2D plannings. Let's start with the various barium studies. What is barium studies? Barium studies is nothing. We are giving a barium, either liquid is a thin liquid mixing with barium, it is inert substance. After that, we ask the patient to swallow and you take as a fluoroscopic or X-ray as per your requirement. So there are types of barium studies. You are a barium swallow, barium meal, barium follow through, barium small bowel enema and barium enema. So why are not using now? So these are the most structural mucosa, malignancy, and also you can see easily when the people, your teachers, your parents, when they studied in your institution, when that time nothing CT scan was not there. This is the very useful method they use it to study. But why I am telling today? Because when you are going for the head and neck radiation, you ask for a swallowing test. In swallowing test, how patient is swallowing, how you can see the strictures, everything you can analyze it through a barium study. Malignancy, you should do the carcinoma, ulcer, growth, strictures. In benign also you can do that. But now it is not useful. It is mostly replaced by the endoscopy, colonoscopy, CT scan, all the things. So imaging, X-ray, AP, PA, lateral, oblique, supine, prone, serial. After giving barium, take N number with fluoroscopic examination. You can interest also, you can plan for the fluoroscopic method. So fluoroscopy is nothing, as I told, you give the barium and there is a moving X-ray. It will take the X-ray pictures. You no need to write anything, just listen. I will give you the presentations, take and study at home. Nothing to worry, nothing to hide. Okay, just listen. So this is the fluoroscopic mechanism where you can see the swallowing structures, how it is moving and everything you can understand from the picture. After radiation also, the patient comes for the follow-up. When they are studying, you can ask for the swallowing test. You cannot every time, poor people, they cannot go for endoscopy. It is a very, it is easily available in your institution. So what is the double contrast? When you keep some gas or air, inert air, apart with barium, it will go inside, it will lining the mucosa and everything. You can study the mucosa very nicely if you use the double contrast. What is the positive contrast? When you put barium or a barium-like substance, negative contrast is the air. This is called double contrast. So this is the barium sulfate where they use, and thin liquid they use, how it is insoluble and odorless. Sometimes when there is obstruction, patient is not able to swallow, you may get aspiration type of these things and you may put in trouble. So aspiration and constipation, anaphylaxis and impaction, these are the main issues when you have to keep in mind. Contraindications, if you don't have hypersensitivity, obstruction, perforation and fistula is there, don't do that. When tracheoesophageal fistula is there, you don't try it. Barium swallow, nothing. When you are understanding the barium, how the oropharyngeal structures are there, just give the barium and ask to swallow. Either you take and X-ray or fluoroscopy. So as you know, this is the fluoroscopic mechanism. In your PG examinations, they put this picture as they will ask those two conical structures in the upper and two conical structures down. That is the upper structure is vallecula and down structure is the piriform fossa. So this is the picture they will ask in your PG examinations. Barium meal, nothing, just going forward to the lower GI tract. You just give the barium. After putting the barium inside, they will see the esophagus, stomach and duodenum. And before that you need some laxative and empty stomach. So you can study the stomach wall, duodenum and some part of the jejunum. You can see where the pylorus is there, where is the, how is the mucosa, how is the these things you can. It is also helpful when suppose a patient is there, CS stomach, there is some irregularity in the upper stomach mucosa you cannot appreciate in the CT scan. So you can put some barium and you can see the mucosal wall where is the disease or not. Even oral contrast is sufficient also during CT scan you can see like this. Double contrast if you put, you can aid with contrast, you can see the mucosa so nicely seeing here. You can see the mucosa very nicely. Sodium bulb follow through, after you can want to see the follow through, you want to see the motility of the small bowel and motility of the intestine, you can put these structures more after GI fluoroscopic study, you can grossly you can evaluate the motility of the bowel. So this is the small bowel follow through, you can see how the things are there. Another thing, you can see barium meal follow through, if you put in erect position, you can see everything in so nicely, stomach, body, antrum, pylorus, duodenal cave, all things you can see so nicely. Sodium barium enema, here they what they will put, they put the Ryle's tube to the jejunum and they push the barium. So you can see the some strictures how they analyze the jejunum, ileum, all structures. Then barium enema, nothing, same procedure, you give the enema barium towards the through rectum and after that you take the serial x-rays and to understand the so they will give barium enema and after some time they will see, you can see the all rectum, anal canal, rectum, sigmoid, descending colon, transverse colon, ascending colon and cecum. So this is the usual procedure. But how it is obsolete nowadays? Because of CT colonography, endoscopy. So why I taught you today? Because in the future when you don't know something, you may have some confusion when you are correlating your structures. After procedure, patient may have a drink plenty of fluids, abdominal bloating, and patient might have a whitish stool. This is all about the barium studies. Any questions? Okay. Another thing, when we are using, we are doing oophorectomy, we are giving chemo, we are giving radiation. After this all things, our bone density goes down and down. Though it is not much practiced, if you go to the medical oncology people, they ask for the DEXA scan so frequently. What DEXA scan tells you? DEXA scan tells you about the bone density of the person, so that prophylactically you can give vitamin D and calcium so that to prevent all things. So what is the DEXA scan? DEXA scan in full form is dual energy X-ray absorptiometry. So this is the bone density study. If you see, when they go for the DEXA scan, they will ask, this is a different instrument itself. So they will ask the patient to lie down and then flex position. So they will take X-ray of both pelvis, both hip and lumbosacral spine. So this is the thing, what is the thing. So they will measure by two methods, one is T-score and Z-score. How to understand the T-score and Z-score, it is not your headache, but you should understand what is T-score and Z-score. So this is the formula of T-score and Z-score. Don't put your head, just remember it is a T-score and Z-score. But how to interpret? If your T-score is 0, 1, it is normal. If it is -1, it is osteopenia. And -2 to -4, it is a severe osteoporosis. If you don't give some calcium supplementation or bone strengthening agent like bisphosphonates, patient may go through the fractures. Then understood? Then basics of CT scan. CT scan, simple, it is like rapid arc, it is a X-ray arc. So like a CT scan means computed tomography scan, it is use X-ray images. He is the person who received Nobel Prize and he introduced the device by 1972. So if you see, this is the set of lasers, this is the couch, this is the control panel. So this is when all things are taken care, it is called CT console. This is the circular X-ray. The X-ray is absorbed by body and it reflects. After reflection, it is a detection in detection which reflects more, some tissue reflects more, some tissue reflects less, some tissue speedy reflection. So, to understand all these things, they produce the images. So, this is the X-ray source here, this is the detector and this is the couch. So, when patient goes in moving, country moves. Previously, first generation CT, second generation CT scans, only couch moves one circle and move. So, now helical move, spiral CTs 128, 256 slides also there. So, this is the spiral CT. So, how it happens? After the scanning, the image reconstruction, they send the digital image. After digital image, they convert to the analog image. So, to understand better, they give the contrast injection. In contrast injection, there are ionic contrast and non-ionic contrast. Ionic contrast, chances of anaphylaxis is more. Non-ionic contrast, so it is a good, and that is a people mostly using the non-ionic contrast. And if always, even if you are doing the CT scan it in your institution, always put the anaphylaxis kit by the side, so that it will not be a problem when there is a anaphylaxis. Preparation, as you know, 4-hour fasting is required. There should not be no renal issues. Take a consent and give the anaphylaxis kit in our console. So, two things people will ask in your exam: what is bore and what is the FOB. Bore, it is the diameter of the opening, CT opening. Here there is a diameter. Again, this is the total. So, 70 centimeter is required in the normal diagnostic CTs. For the radiation plannings, we need more than 80, 85. So, FOB is the diameter of image. Bore is the diameter of the opening of the CT. So, this is called FOB. So, red cone is the bigger FOB, and yellow cone is the small FOB. So, if you take small FOB, suppose you are studying the spine, if you want to take the whole abdomen, you may not get proper image and proper resolution. So, when you are suspecting some lesion, you call for the small FOBs. Density, as you know, brain is the reference. If it is a looks like brain, it is called isodense. If it is more than darker, it is the hypodense, and if more brighter is the hyperdense. And how to analyze the CT number? Otherwise, you know, the Hounsfield unit. So, different to different tissue related to the composition of tissue. So, what are the things looks darker? The looks darker is the air, spinal fluid, ischemic infarct, edema and white matter. Remember, white matter looks darker in the CT. Same thing, radiodense structure, hyperdense are bone, metal, calcium, blood and grey matter. Grey matter looks whiter in the CT. So, this is the like pH you studied in your group. So, water is the 0 and minus the 1000 is the air and plus 1000 is the bone, that is called windowing. So, I will tell you what. So, according to Hounsfield, so they are giving the Hounsfield units, air is minus 1000, water is the 0 and bone is the 1000. So, if you drag your mouse, click the Hounsfield unit, put in your the various structure, you can see the various Hounsfield units here. So, this is the air, it will be in the minus 758. If it is bone, it is 275, 278. Like that, various structures you can. Why it is important? Again, in a radiation practice, suppose there is a lesion in the chest, it may be a solid lesion or it may be a cystic lesion, which is water or a pleural effusion. You just drag your mouse, click there Hounsfield unit. If it is the water value, it will take as some cystic fluid. If it is a solid, it take as a solid mass. So, window width and window level. So, how can I change the window width and window level to improve the resolution, to improve the quality of the picture, to understand the picture, the brightness and contrast. If you go to the PowerPoint presentation, there is a 2 icons called brightness and contrast. Okay. In this, like this, CT scan also the brightness and contrast. Brightness is the changing of the whole image brightness. Contrast is the changing the brightness inside the image. So, if you see the left side, right side of the image, you see the brightness, whole image looks bright, but here the face is looking brighter. So, it is a contrast changed, this is a brightness changed. How to change this, how to handle this manually things in these situations. So, this is as you know, this is the soft tissue window, this is the lung window, this is the bone window. So, these are the mediastinal window, this is the one is the called contrast and width or window level, window width. So, if you see, if you drag, put your mouse, click the window, drag horizontally. If you drag horizontally, window width will change. If you drag vertically, the brightness will change. If you drag diagonally, that will your brightness and darkness both will change. So, you go, if you have a system in your PAX system, you can see and you can do this practice to understand the window width and the window level. So, this is the typical window width, window levels of various like head and neck, brain, these are there. You can get it very easily in the Wikipedia or Google, no need to remember all things, but very few things you have to remember, like bone window, lung window, skin window, liver window. These 3-4 things you can remember. It is for the mainly for the radiologists. Then is the slicing, either may be axial, coronal and sagittal. Axial from skin from top to bottom, coronal is the anterior to posterior, sagittal from the side to side. So, this is the sagittal picture, this is the coronal picture and this is the axial picture. So, there is no problem, hope you remember all these things. Then coordinates, this is important, x, y, z, coordinates are very important, as well as the imaging, as well as the radiation planning. So, these are the coordinate system. Sometimes we get some artifacts, actually image got distorted, that a distorted image is called the artifact. It may be due to the ring artifact due to the machinery issues, it may be the motion artifact, the patient moves during the treatment scanning, or it is a contrast agent or the dental artifact, if there is a dental material is inside. Then we will go for the mammogram. Any doubt? Shall I go ahead? Mammogram. Mammogram, again it is a study to understand the breast density and breast lesions. So, this is X-ray picture of the breast, low dose X-rays, breast to the understand the breast disease in the woman. Procedure, it is nothing in the inside, they will compress the breast in 2 plates. In these 2 plates, they will take craniocaudal view and oblique view X-rays and they will understand. So, this is the how they you just go to your institution, go to the mammogram radiology department, see the mammogram how they are doing. It is also a clinical experience. Why it is important? When you are planning for the radiation boost to the breast lumpectomy cavities and everything, you can see how it is important these things. So, this is the conventional mammogram. In this conventional mammogram, it looks very hazy. With evolving of the mammogram machine, we have a digital mammogram and that converts X-ray into mammographic picture. It stores inside the system and resolution will be better. So, digital mass mem, either digital mammogram or something, whatever may be the pressure and the discomfort to the mammogram to the patient is the same. So, this is the with the digital mammogram, you can see the some muscles, some density, good resolution with the contrast resolution you can see here. Like that, slowly they developed a 3D mammogram and tomosynthesis. Like that, where X-ray is rotating around this thing, you get a CT scan, they rotate the X-ray around the breast, they will take as a arc and they will form the tomosynthesis. So, this is a reconstructed image and higher doses than the normal mammogram and discomfort is the same. So, this is called, why it is so important? You will get a very good resolution, you will get a, you can go track mammogram tracking biopsy. So, this is also one concept. this is the mammogram tracking biopsy with a clear image and greater accuracy. So, now this is the 3D digital technique. You can see the axillary nodes here also, and this is it is in the mesh the tomosynthesis. So, when you know X-ray, when your teacher is asking, when how can you tell me the what is the mammography picture, always use the magnifying glass, either in form of software or the normal X-ray. If you don't use the mammograph, this thing, they understand that you don't know mammogram. So, always you have to handle the X-ray reading with a by magnifying glass. So, as you know, BIRADS, breast imaging reporting and data system, where you will study the reporting the grade 0 to grade 5. As you know, A, B, C, D also there. You can go and study like BIRADS, lung, liver, lyrads, oriads, ovary, pyrads, tyrads. When you just request your radiologist, when they are giving the reporting, please mention the which this group and BIRAD systems. Then computer aided detection, artificial intelligence slowly coming into the system. Okay. Then I will go to the soon. Yes, sir. C norm. Sonogram. No, sir, I don't know idea. Okay, I will find it. Then ultrasound, nothing. It is a no radiation at all. If there is a, you can want to diagnose the understand the you can possible with ultrasound. So, go with ultrasound where there is no radiation is exposed. So, usually the hearing is a normal hearing frequency is between 20 to 20,000 kilohertz, 20 kilohertz, but this ultrasound uses 2 to 18 megahertz. So, animals they can hear this sound. That sound is used for the ultrasound study. So, again as I told, it may be hyperechoic or hypoechoic or isoechoic. So, this image comes on, they have to going through a transducer. They will palpate with a transducer with some liquid trans agent, and this is called when there you can what is the useful. So, in our practice, because CS cervix is very common, when you are finding some lesion or something, even transvaginal ultrasound, transrectal, or when there is a vaginal stenosis after radiation, you can ask for the transrectal ultrasound, you can study, and transesophageal ultrasounds, endoscopic ultrasounds. These are very useful techniques to understand the procedures. This is the transducer or a probe. This is the transvaginal ultrasound. This is the transesophageal ultrasound, and it is used. This is the another is the Doppler ultrasound. Why it is important? In the Doppler ultrasound, it is always important to understand the blood flow, either vein, either vessel or heart. When heart, it is called 2D echo. When there is a deep veins and the arteries, you can see the when the patient present with the CS cervix, he presents with the DVT. This is the common practice to ask for the color Doppler ultrasound, Doppler of vein bilateral limb. It is so you can see the presence of deep vein thrombosis. You can so this is how they do, how the vessels looks like. So this is the all about basics of the ultrasound. Then we will go for the MRI. MRI, as you know, there is also no radiation, and that is known as magnetic resonance imaging. So parts of MRI, it is a magnetic field, gradient coil, radio frequency coil, and computer system. He is the MRI invention, Raymond Demodian. He died in this August. So he is the legend who invented the MRI, 1977, and before that the nuclear magnetic resonance, the spinning of the molecule inside the magnetic field known as NMR is given by Isaac Rabi. So both have received the Nobel Prize. So as a patient going to the MRI, so there will be magnetic field and gradient coil, and that is a radio frequency. So and this is the radio frequency coil. So this is the computer system. So this is the radio frequency transmitter, the gradient power supply. So when you give radio frequency transmission and gradient power supply, there will be magnetic change, and we withdraw the radio frequency transmission, automatically the some transmission happens, that is called Fourier transmission. We no need to understand all these things because we are not radiologists, just to understand basic. So that Fourier transmission gives the image and receives on the, you will get an image. Let us see again another way. Sequence of events in MRI: patient, then application of magnetic field, application of radio frequency, withdrawal of radio frequency, release of energy, Fourier transmission, and conversion of analog to digital image. So this is the image. So release of energy, like in CT, release of X-rays, in ultrasound, release of sound. So as per our the density of the bone, soft tissue, you will get various softness and hardness of the tissue, you will get the image. There are two things, TR, TE, TF. So based on this TR, TE and EF, you will get various sequences, T1, T2, all these things. So this is the physics of MRI, you can study. So let's what happens really. Our body contains 70% of water. So in hydrogen atom is a magnet. So you can see two hydrogen atoms, all body, all particles contain a hydrogen atom. So they are randomly arranged. This is called Larmor frequency. No need to remember. But when you apply the magnetic field, it becomes alignment. This alignment called parallel or anti-parallel arrangement. When you give radio frequency, it will go to the 90 degree. Again, you frequency, it will be 180 degree. So really stop the radio frequency, it will come to the same position. So after same position, it will some energy will be transmitted. It is called Fourier transmission, and this transmission is going to store in your giving rise to conversion to image. So quickness of release varies as per tissue, gives the differential image. So you may get structural image, got functional image. The sequence, what is the sequence? T sequence, T2. The variance events happens in MRI is called the sequence. So playing with the TR, TE, and this they will play with these three systems to get various sequences in the. Thank you, sir. Yeah. So as you know, hypointense is black, hyperintense bright, isointense is the gray. So this is the all basics of MRI. Then we will go further understanding the bone scan. In bone scan, what is a bone scan? It is a scintigraphy scan or a radio tracer scan of axial skeleton whole body scan. It can help the diagnose a number of bone conditions either from benign or normal or malignant. So we have to use one radiopharmaceutical agent. Then what is a radiopharmaceutical agent? Radioactive agent plus pharmaceutical agent is together known as a radiopharmaceutical agent. So it is a radioactivity and vector molecule, it will go to the target. So these are the various radionuclide scans in day-to-day practice. Some are available, some are not available in every vicinity. You will thyroid, as you know, iodine scan, cardiac, MOGA scan, brain, BB scan, neuroendocrine endotoxin scan. So n number of table is there, you can see here. Like radionuclide therapy, same thing, you can go for the thyroid iodine therapy, bone for samarium therapy, lutetium therapy, prostate lutetium, neuroendocrine lutetium, DOTATOC therapy, medullary MIBs therapy. No need to write, presentations I will give you. So this how they happen? So this is a radionuclide production, there is a hot, that is radioactive precursor or hot precursor. This is the pharmaceutical agent, they combine together, they give the injection. This is radiopharmaceutical agent will go to the specific tissue, then you take the image. So scintigraphy also known as a gamma scan, 3D form is known as a SPECT scan. So he is the radio tracer who invented, he received the Nobel Prize, George Hapsey, and who is to understand receive the gamma emitting by a detector is known as a gamma camera. He is the Hall Langer, he also received the Nobel Prize for the gamma camera. So this is the bone scan machine, patient is to lie down inside the bone scan machine, and this is a radiopharmaceutical agent, they will give injection by technetium 99 and they will take a picture. So how In indications like malignant, unexplained bone pain, suspicion, bone mets, primary tumors, benign osteomyelitis, osteoarthritis, trauma, metabolic bone disorders. So, procedure, after giving the injection, they will ask to wait for 4 hours, and you have to more hydration and go for the evacuation repeatedly. They will take anterior posterior scan. So, how do they explaining the patient, giving 20 millicurie of technetium 99 MDB injection, frequent voiding and hydration, scan after 3 to 4 hours of gamma with gamma camera. So, no preparation required, hydration voiding is required. After procedure, stay away from the children and pregnant lady, at least twice flush after toilet. Technetium has a half life of 6 hours, so 1 day precaution is required. So, this will after injection they will put for the frequent voiding and hydration, then they will take the scan, they will take the planar images APPA. So, you may get osteoblastic lesions like this, extensive bone mets, and what is super scan? Super scan is nothing, because of extensive bone mets, the all precursors are all tracers are occupied by the body, there is nothing to excrete. So, in the kidney, so you can kidney cannot be visualized. So, this is called a super scan. If you see the old picture, so this picture you can see the visualize the kidney here, but in extensive bone mets you can extensive bone you will not able to see. You will not able to see the kidney. So, this is called a super scan. Then normal optics you have to understand properly joints, trauma areas and growth hands, and diagnostic correlation when there is in doubt you do the SPECT CT, PET CT, MRI, CT correlation. So, this is all about the CT scan. Then we will go to the positron emission tomography. Positron emission tomography, as you know, it is the agent emits a positron. So, positive electron. So, it is again using of a radiopharmaceutical agent, we can use most commonly used the F18 FDG. Again radio tracer agent, radiopharmaceutical agent, you have to give injection attached to the specific organ, it emits gamma, there is a detector and that detector converts to the digital image. So, this is the usual procedure. So, as I told, so you are giving a positron, it collides the electron, it will produce 5112 gamma energies, and this energy is detected by the detector and it will convert to the digital image. So, as you know, you can see here this is the so this is the procedure after giving the injection, this collides with electron and this is the 2 energy, these are the detectors. So, and after detection you will have a various PET image, and if fuse with the CT image you will get the PET CT. Even now the PET MR is the new concept, new machine. So, how it is a PET CT, if you compare it to the CT, PET CT is a dual gantry. So, this is the PET CT, then you will do the PET CT fusion. So, front gantry is the CT, back side gantry is the PET, these are the detectors. So, if there is a so you have to after CT scan they will take the PET CT and they will fuse it. So, there is so this you will get the PET CT scan. So, these are the various tracers used in the like fluorodioxin carcinomas, lymphomas, gallium scan, PSMA for the prostate and brain, gallium DOTATOC is the neuroendocrine tumors and meningioma, methionine is the brain, sodium fluoride for bone mets, thyroid tumor hypoxia if you want to study the misonidazole, and like n number of tracers are there and n number of tracers are under evaluation. So, this is the PET. So, when we are studying at a Tata Memorial Hospital, that time there is one unit and like that they will give the images. So, you can always we just find out, okay, this the lesion may be in the lung or maybe bone or something. That time CT was not there, then slowly PET CT came. So, you will got the better resolution, this is the PET CT. So, why it happens? This is the again is the received the Nobel Prize, what is called Warburg effect, where malignant cells have increased glucose utilization. Once in the tumor cells, FDG converted to the FDG 6-phosphate, metabolically trapped in the tumor cell, and you will increase the FDG uptake in the tumors and you will see the uptake. So, for the uptake, FDG preparation and all things, you need a cyclotron. It requires more investment as well as a big area. So every place it is not possible. So they what they do, importing it is through air travel. They brought the some curie of injection and they do in the institution. So there are like Hyderabad, Bangalore, Delhi, Bombay, the same particular centers are there. Though through air travel they will give that. But gallium chambers are there where they can produce, they do PSMA, dotatascan, no need for the cyclotron. This is the FDG molecule, I am not going to detail. Then before studying, you have to study these are the normal uptakes in myocardium, brain, brown tissue, adipose tissue, alimentary tract, genital tract, bone marrow. So these are the main uptakes, normal uptakes. You have, before understanding the abnormal uptake, you have to understand the normal uptake. How to understand the standard uptake value? So how to study, there is a unit is known as a standard uptake value. SUV is the activity region of interest by injected activity. So they will, so why it is important before chemotherapy, after follow-ups. So this is a prognostic importance and diagnostic importance. In oncology, benign from malignant, staging, radiation planning, prognostication, you can identify the necrosis and residue. 1, 2, 3 slides about the tear and test, where tear if they are mostly used in the liver study. So liver HCG treatment, they will give radioactive tracers inside your feeding vessel. So how it will go? So it will they will find out where is the tumor, where is the feeding vessel. They will push the yttrium labeled embolization radio tracer. They will block the artery and that radiation emitting it will go on. So tumor will lies. This is called tear. In TACE, transarterial chemoembolization, where they will push inside the feeding artery with chemo and they embolize. Then it automatically it will block the tumor feeding vessel, and chemo also will kill the tumor tissue. If you want to go on under study econtour.org, you might be knowing all this site. It is very easy, case by case study. It is given, it is freely available. You understand the econtour.org. Then how to the images transfer to your department, to the CT scan, to the MRI scan, to the your planning system. This is called DICOM, Digital Imaging Communication in Medicine, that known as a DICOM images. When you are sending, please send the DICOM images, you are right, to your CT scan or MRI people. So this is the system. Without DICOM, you cannot do the plannings. This is another system where the storage system happens. You are doing lots of CT scans, MRI in your department. You can, somebody brought the CD from the outside, you can store. This is called Picture Archiving Communication System, or called PACS. This is economical storage of all the data, all the slices, and for the future. So the images, format of the image is DICOM, storage transfer is the PACS. So this is called PACS and DICOM system, how it works in your department. Then if you have a heavy file, some of your person is here, he wants to take an opinion in the US MD Anderson MSKCC. So you have to send all files, so much data. There is a system called wetransfer.com. This is free. You upload your all images there, they can download and see. Thank you. This is my chapter 1. Another 5 chapters are there. Hope you understand. Anything you can ask, no problem. Feel free to ask. All presentations are there. I will give you at the end of the day. Hope I cleared most of the diagnostic investigation. Anything? Any criticisms, comments? I will not mind. Please tell me. Okay, just 5 minutes. Relax. If you want to take a cup of tea, by another 5 minutes, I will start the CNS imaging. It's very important in these things. So another 5 minutes, I will start the CNS imaging. Why we should understand the skull-based radiology properly. when you are studying the skull base tumors, and the nasopharyngeal carcinoma one is the important target delineation guideline. So, always remember how to identify the foramens and how to identify the cranial nerves. So, in the what to see? We have to see the foramina, sutures, canals, fissures and fossas. So, if you see, this is the superior view and it is the aerial view. This is the aerial view and the down view of the skull base, where it comprises of frontal bone, sphenoid bone, temporal bone and occipital bone. So, if you see, the sphenoid bone has a anteriorly the lesser wing, posteriorly the greater wing of the sphenoid, and this is the ethmoid plate. So, if you see, this is the optic foramen, this is the superior orbital fissure, this is the foramen lacerum, this is the spinosum, this is the foramen lacerum, this is the foramen magnum. So confusing, so how to identify and how to remember in the CT and how to remember in the MR. Let us see. So, if you go to the skull base, this is the ethmoidal plate anteriorly and magnum posteriorly, no differentiation, nothing to worry, easy to identify. If you see, go to the then middle sella. In sella, there are anterior two projections are there. This is a foramen, optic foramen, where optic canal, where optic nerves are coming. Then you find one lacerated foramen. This is called foramen lacerum, which is sleeping foramen. The foramen is sleeping. I will show you how to looks like. Then this is the small foramen in the foramen magnum side. It is a hypoglossal. This is this foramen, these three foramens are there, 1, 2, 3, 4. This is the internal acoustic meatus, jugular foramen, hypoglossal canal and foramen magnum, these 4. Understood? Now, this is a foramen ovale, which looks like oval, and foramen spinosum. So, it looks like a lady's heel, like I will tell you how it is. So, this is the, I will make you, from going here you will identify all foramens very nicely, do not worry. So, this is the body, this is the sphenoidal body, this is the lesser wing, this is the greater wing. This lesser wing, greater wing is makes they form the superior orbital fissure. Okay. Then these are the pterygoid plates, medial and lateral pterygoids. This is the foramen rotundum and pterygoid canal. Let us see again. So, these are the various nerves going, which nerves are going inside and what is the things, whether you want to remember or choice is yours. So, this is the how the nerve roots exit from the optic nerve, cranial olfactory nerves. This is the hypoglossal nerve. This is the 7th, 8th, 9th for the jugular foramen, 9th, 8th, 9th, 10th, 11th, and facial nerve. This is the for the internal acoustic meatus, where you can find the 7th, 8th nerve, and this is the thickest and biggest is the trigeminal nerve here. Let us see. If you see the some small FOBs, you can see this is the one foramen is called lacerum, foramen lacerum. This is the ovale, this is the spinosum, this is the rotundum. Okay, let us see again. So, this is a forms a diamond or pentagon. This is the optic canal and superior orbital foramen. This is the from the rotundum. This is the Vedian canal. This is the from the sphenoid pentagon. Okay, so let us see. This is the optic canal here, and this is the foramen rotundum. Do not worry. Now you see. If you go to the skull base, so how to understand the skull base? Which window you have to see? This is called, if you go, you have a Monaco system, you go to the otoscreen window, or if a MRI, it is other thing, it is go to bone window. So, you can see the foramens, you have to, if you understand the all foramens, you have to go slice by slice with 1 mm slice cut, and bone window you have to understand properly. So, this is optic foramen, which is coming to the pituitary fossa area. This is called optic foramen, and which is going to the brain, it is superior orbital fissure. Okay, do not worry. So this is, as I told, this is the foramen magnum here, this is the hypoglossal canal, this is jugular, this is the clivus, and this is the bottom area. Now as I told, how to identify the optic foramen and supraorbital fissure. Let's see, this is the T. If from the optic orbital things, if you go inside, it is optic foramen. If you go to lateral, it is the brain, it is the supraorbital fissure. So remember the T. Understood? Going to the sella is the optic foramen. Going to the temporal area is the supraorbital fissure. This is the T. If you remember T, these two foramens are finished. Let's see, as I told, okay, this is ovale, this is a spinosum. This looks like a lady's heel chapel. Okay, remember, any doubt? No. One foramen is there here slipping or lacerated, somebody's laceration, that is a foramen lacerum. So this is called, this is the maxilla and this is the sphenoid wing. There will be a canal. This is called pterygopalatine fossa. Why this pterygopalatine fossa is very important? When treating the buccal mucosa lesions, treating the maxillary sinus lesions, treating the nasopharyngeal lesions, you have to cover all these things. Otherwise, the tumor will go to intracranial extension from this route. This is the pathway where the many tumors go to intracranial extension. Let's see, easily, don't worry. I will go to, this is the sphenopalatine foramen where the intracranial extension happens and goes to the various canals, various foramens. Let's see. So, how to understand? You have to select the called window, bone window. You cannot see in the subtis window or subdural. That is called window width is 2500 and level is 480. This window, if you select, you can able to understand the foramens easily. So the windowing is very important. Then comes to the axial images. So if you see, this is a posterior pterygopalatine fossa, this is foramen lacerum, this is the ovale, this is a spinosum. Okay, understood? Very nicely, this is the pterygopalatine fossa. It goes communicating the all foramens through Vedian canal. This canal, Vedian canal. This is lateral to the Vedian canal is the oval-like structure foramen ovale, then foramen spinosum, and slipping diagonal lacerated foramen is the foramen lacerum. Let's see again. Going up to down, again you see the pterygomaxilla and sphenoid bone. There is a fissure called pterygopalatine fissure or pterygomaxillary fissure. So, and if you see, this is the internal acoustic meatus. Which nerve? 7th and 8th, anteriorly 7th, posteriorly 8th. So, see, as I told, you form the T here. If you T, this is a supraorbital fissure, this is optic nerve. Okay? As I told, this is foramen lacerum, this is the ovale and spinosum, and this is the pterygopalatine fossa. Okay? Maxilla and sphenoid में जो canal है, that is called pterygopalatine fossa. Let's see again very nicely. This is the supraorbital fissure, foramen ovale, oval. Spinosum is the small posterior to spinosum. This is the lacerum, and this is the carotid canal. What happens? There is a carotid nerve, internal carotid is going inside. There is a vertical carotid canal, and it slashes. So this slatting is called lacerum. So going to the intracranially, to form the circle of wheels. So first it will go vertically, then slanting. So this is called carotid canal. So vertical, this is a vertical carotid canal, then diagonal carotid canal. So this is a superior orbital fissure, optic canal T, no problem. This is optic canal. So and this is the foramen rotundum. You will able to find on the superior part foramen rotundum only the coronal section. You cannot able to see in the axial section. So again, superior orbital fissure and optic canal. This is the basics. Now you identify each foramen size by size. Level 1. What is this? Mandible and coronoid process. This is mandible and neck. This is mastoid process. This is occipital condyle. This is pterygomaxillary fissure. See, understood? Then pterygopalatine fossa. Then these are the pterygoid plates. So if you see, these are the pterygoid plates, medial pterygoid and lateral pterygoid. This pterygoid process where your medial pterygoid muscle and lateral pterygoid muscle submastication, it is important. Understood? After that, you just circulate the skull and find out the foramens. Okay. Then this is the which foramen? Which process? Styloid process. Then level 2, this is the mandibular condyle, this is the mastoid, this is the occipital condyle, this is the pterygomaxillary sinus, this is the pterygopalatine fossa. Pterygoid plates again, medial pterygoid plate and lateral pterygoid plate. This is pterygoid process. Pterygoid process, this is the pterygoid process and medial lateral plate. So this is process, and there is a small bony ejection is called pterygoid hamulus. Styloid process. Level 3, see how this styloid process and mastoid coming together slowly. What will form? They will form stylomastoid foramen. Where it is important? When you are contouring the parotid gland, that has to be include the stylomastoid foramen. I am coming to that area. Mastoid process, occipital condyle, occipitomastoid sutures. Why these sutures important? Even nasopharyngeal cancers, they go sutural involvement and go to the intracranially. This is a pterygomaxillary fissure again, pterygopalatine fossa, pterygoid plates, pterygoid process. This is a sphenoid spine. This is a styloid process. This is a zygomatic bone. This is the anteroot of zygomatic arch. Then level 4. You see Baxis, but posterior part of the clivus. Which is clivus bone? This is the clivus bone, sloping bone. This clivus bone is very important when it is important when nasopharynx T3 or T4. Okay, remember I will tell you in the head and neck. Okay, so this clivus bone is very important. Okay, then hypoglossal canal. You will see the foramen magnum. Laterally in the foramen magnum area, there will be a small canal. It is called the hypoglossal canal. You can see this hypoglossal canal here. This is hypoglossal canal. So then pterygopalatine fossa again. So that fossa is very important when treating the maxillary sinus, treating the buccal mucosa, treating the nasopharynx, treating the oropharynx extension, treating the RMT area. So this area has to be contoured properly to prevent the intracranial extension in future. Then pterygoid plates, pterygoid process, then occipitomastoid suture, occipital bone, pterygomaxillary fissure again, sphenoid greater wing, sphenoid spine, sphenopalatine foramen, styloid process base. As I am going down top, then zygomatic arch, zygomacial foramen, level 5. So foramen ovale, bottom you can see foramen ovale, back side there is a small foramen. What is that? Spinosum. This is a hypoglossal canal. Okay, if you see this hypoglossal canal opens to the nasopharynx area. Okay, then infraorbital fissure, inferior fissure. So the pterygomaxillary fissure slowly forms the when intracranial it is infraorbital fissure. Okay, this is common part of the occipital bone, occipitomastoid suture, pterygopalatine fossa, sphenoid wing, greater wing, sphenoid right, then sphenopalatine foramen, sphenomuscomus suture, temporal bone, petrous part, and tympanomastoid suture. Level 6. This is a carotid canal, vertical part. After going vertical part, it will horizontal. So vertical carotid canal. This is a clivus. Then ovale, Ovale spinosum, no problem. Ovale spinosum, lacerum, greater wing of sphenoid, hypoglossal canal, inferior orbital fissure, jugular foramen, occipitomastoid suture, peri suture. These sutures are very important. These sutures, so you are from nasopharyngeal carcinoma, other cancers will go up. Vidian canal, pterygopalatine fossa, sphenoid body, then sphenopalatine foramen, sphenoesquamous suture, petrous part temporal bone with a squamous part, temporal bone with a tympanic part, tympanomastoid suture, level 7, the carotid canal. See, if I go up, the carotid canal become the horizontal. You will see, I will tell you. Clivus, lacerum, okay? How it is vertically slanting on the lacerum, foramen ovale, spinosum, jugular foramen becomes sigmoid sinus, brain, jugular sphenoid sinus, then inferior orbital fissure, jugular tubercle, occipital bone, squamous part, occipital mastoid suture, petrooccipital fissure, petrosphenoidal fissure, pterygopalatine fossa, body of sphenoid, greater wing, sphenoesquamous suture, tympanoscomoid suture, and petrous part, tympanic part of the temporal bone. This is a squamous part of temporal bone. Then level 8, lacerum aa gaya, you will not find in the carotid canal here, vertical carotid canal. Then rotundum. So rotundum, infraorbital fissure, spinopalaris, there are the clumsy area. All things will be there. Jugular tubercle, mandibular fossa, where roof, middle ear. This is the middle ear. Okay? Squamous occiput, occipitomastoid suture, petrooccipital suture, sphenoid body, greater wing, sphenoesquamous suture, sphenozygomatic suture, petrous temporal bone, squamous temporal bone, tympanic temporal part, tympanosquamous fissure, level 9. Basal turn of cochlea. You will see the cochlea here now. Sphenoid bone for internal carotid artery. Okay? How it going to the cavernous sinus now? Understood? Going to the cavernous sinus now. Middle ear, you will see the small bones here. Then squamous part, occipitomastoid suture, space containing superior and inferior orbital fissure. This will connect between superior and orbital fissure. Body of sphenoid, greater wing of sphenoid, sphenoesquamous suture, sphenozygomatic suture, temporal bone, squamous part, level 10. What is that? Cochlea. You no need to contour this one. Only cochlea you have to contour this one. Semicircular canals no need to be contoured in the cochlea. Internal auditory canal. So middle ear with malleus and incus. Okay. Then squamous occiput, occipitomastoid suture, body of sphenoid, greater wing of sphenoid, space connecting superior and inferior orbital fissure, sphenoesquamous suture, petrous temporal bone, level 11. What is this? Internal. So you will get the 7th, 8th nerve. Okay. Malleus, incus, squamous occiput, occipitomastoid suture, body of sphenoid, greater wing sphenoid, sphenoesquamous suture, petrous temporal, superior orbital fissure. As I told, optic canal and superior orbital fissure. Vestibules with the semicircular canal. These are the parts of the semicircular canal. Okay. Level 12. So this is squamous occiput, occipitomastoid suture, posterior semicircular canals, body of sphenoid, greater wing of sphenoid, sphenoesquamous suture, petrous temporal bone. Okay. So this is the skull base in nutshell. No theory, nothing, all pictures. So if you see, these are the various optic. If possible, I will show in the internet how to understand. So as you know, olfactory nerve here. This is the optic nerve, optic foramen. This is the midbrain. Anteriorly, oculomotor nerve, it emerges and goes to the cavernous sinus. This is thickened 3 branches is the trigeminal nerve. Okay. Then abducens is the laterally, pons anteriorly. Remember, midbrain anteriorly 3, pons anteriorly 6. Okay, fourth laterally trochlear. So in midbrain, if you see yellow is the anteriorly, trochlear is the laterally. Pons anteriorly abducens nerve, then vestibulocochlear and facial nerve in the internal acoustic meatus, glossopharyngeal, vagus and spinal in the jugular foramen, then hypoglossal in hypoglossal canal, then for spinal cord in the magnum. So see, this is the ethmoidal plate. Very important when you are planning for the PCI, prophylactic cranial radiation, and CSI, this structure has to be included. Okay, this is the optic canal, this is the supraorbital fissure, this is the foramen rotundum, ovale, spinosum, and this is the lacerum. Now see each nerve nicely. This is the first cranial nerve where ethmoidal plates, it goes to the nose. This is the area of the first cranial nerve. Second cranial nerve, understood, no need, everybody knows. Third cranial nerve, as I told, oculomotor nerves emerges from the anteriorly of the pons, is the midbrain. This is the oculomotor, and this area you see, this is the lateral of the, like this. This is the midbrain se nikal raha hai. This is the fourth nerve. This is the fifth. You see how fifth nerve is so thickened, and when you are irradiating the trigeminal nerve, you have to irradiate this area. So this is called a root entry zone, cisternal component, and this is the called Gasserian ganglion. Then you see internal acoustic meatus, 7th anteriorly, 8th posteriorly. Then vagus, 9th anteriorly. So these three nerves here, 9th, 10th and 11th, and hypoglossal in the hypoglossal canal. So this is the all about the skull base and cranial nerves. I will show you a very good video in the cranial nerve things. No need to worry, very basics. I didn't go theories and all pictures I told you, and all you transfer the skull yourself and try to identify 1 to 10, 12, you just circulate during the other classes. Any doubt, you just ask me, nothing to worry. Okay. After this, we will go to thorax. Okay. If you want to take rest for 10 minutes, take. We have a thorax for 1 hour. What is the time now? Shall we go ahead with thorax radiology? So before lunch, we will finish the thorax and abdomen. After lunch, if you have a time, we will go to head and neck, because head and neck requires at least 1.5 hour. If you are still happy with me, you can continue the radiology for the stereotactic radiotherapy. Okay. So you in between during the classes, you circulate the skull and try to identify the all foramens, and if any doubt you can ask me. So in this thorax radiology class, I will discuss about the various thoracic anatomy as well as vessels, how to identify the heart chambers, how to identify the venous structures, how to identify the lymph node stations, how to identify the various histology classes, and where we need the PET CT. So reading a chest X-ray, how to chest X-ray we should read. So evaluating the chest X-ray. So what is ripe? Ripe is a thing, whether your X-ray is properly ripe or not, you have to understand. If you send somebody X-ray, it should be properly ripe. What is ripe? So rotation. First is R for rotation. If a rotated X-ray, slightly left or right rotated, you will find good mediastinal shadow. You will think there is a mediastinal lymphadenopathy. Okay, let's see. So you have how to understand how it is rotated or not. So you have to find spinous process. You see the spinous process here, and see the distance between the clavicular end. If it is equally placed, it is non-rotated, means good X-ray. Okay. So you have to find the equal distance. If it is, this is rotated to left, you can see the distance is more here. So write R for rotation, then I for inspiration. Usually chest X-ray should be inspiratory film, not expiratory film. If it is in expiratory film, you will find like in haziness, and posterior ribs also you will prominent, basal opacities will find. So this is a expiratory film, this is a inspiratory film. To understand proper X-ray, it should be a inspiratory film. Why I am giving stress to chest X-ray? Many times we ask chest X-ray, ultrasound, chest X-ray, ultrasound. Every patient you write, say cervix follow-up, say breast follow-up. So if you don't understand, you will, what you will ask if you take a X-ray expiratory film? So there is some lesions inside. You will go send for the CT scan. So your hospital will be happy that I am getting more CT scans, but unnecessary you are sending for the CT scan. Morning I told how many X-rays is related to one CT scan. So always ask for the expiratory film. Then P for positioning, AP view or PA view. We are asking for X-ray, it is a chest X-ray is a PA view, and spine for AP view. So in PA view, you will see the periphery of the thorax, projects of the lung above the clavicle. You can see the lungs above the clavicle, and posterior ribs are distinct. In AP view, you will see the clavicles above the lung, and anterior ribs are distinct. This is the AP view. And then E for exposure. If it is overexposure, it will looks very dark. You will think that patient having pneumothorax. So it is a exposure, soft and hard films. So it should be normal exposure. Underexposure hazy, overexposure is black. So always it should properly write to read in a X-ray. So your X-ray is ready. Then how to study? Then ABCDE of the chest X-ray. How to understand what is ABCDE? So if you see this X-ray, this is the spinal structures, bony structures are clavicle, thorax, ribs, scapula, spinous process. These are the bony structures. Vascular markings, these are vascular markings, the bronchial markings. So always a confusion what to see and what not to see. So you should follow. Not happy? So let's be happy. First you have to find A, B, C, D, E. What is A? You should see the airway. One is the trachea, bronchus, lungs, and pleura properly, step by step. You see, this is the trachea centrally placed or not, lungs field is clear or not, pleural costophrenic angle, cardiophrenic angles are clear or not. Above this you have to study, lung and trachea, air. Then B for right main bronchus and left main mucosa carina, you can study here. Okay. This is the upper lobe, middle lobe, lower lobe. You can grossly divide the upper lobe, middle lobe, and lower lobe. Then B for bony structures. What bony structures you see? Scapula, humerus, rib, and spine. So these structures, if you have a radiology online, you can drag your mouse and see the bony structures all properly. You see all there is any fracture, any lytic lesions, or some you can find the bony structure. Then C for the circulation, large vessels and heart. So you can see large vessels. This is the area of superior vena cava. This is area of inferior vena cava. This is area of the aortic knuckle. Knuckle is like aorta, pulmonary artery. Then you can see here aortic arch, pulmonary trunk, left main bronchus, left atrium. So that is the forms the knuckle. That's why I called it is a aortic knuckle. Then so this is the aortic knuckle, where aortic arch, pulmonary trunk, left auricle, left ventricle, like that superior vena cava, right atrium and inferior vena cava. So these vascular structures you have to analyze. If you are finding a mass here, so you may be finding a superior vena cava obstruction. So this is for the aortic knuckle. Then D for diaphragm. Usually because of position of the liver, our right side diaphragm is slightly up, lower side left side diaphragm is the slightly down. E for extra structures like bronchovascular marking and nipple shadows. So bronchovascular marking you see. Why nipple shadow is very important? When most of the patients, breast patients comes to you for the follow-up, you ask for X-ray. If there is in one side there is no nipple shadow, and because of the MRM, other side has the nipple shadow, you will get confused. There is some lesion in the other part of the lung. So be careful. So this is the normal, and this is the left side is the bronchomuscular marking is increased. So as I told, nipple shadow usually like this. You can see here. MRM, you will not find the nipple shadow one side and opposite. So don't. This is the breast shadow. So don't get confused. Small lesion, hurry, go for first. You think of you are going for a MRM patient X-ray. You will find one side nipple shadow, the other will not find the nipple shadow. Then in a CT thorax we will study. We will go for the vascular anatomy, CT correlation, application in radiotherapy, new stagings, radiological pictures, and roll-up PET scan. Okay. Hope you remember structures. So this is the arch of aorta. In arch of aorta, right side, the two arteries, mainly carotid artery and subclavian artery, arises from the brachiocephalic artery. Brachiocephalic artery gives two branches, carotid artery and subclavian artery. But in left side, it directly opens. So three structures, B, C, S from right to left. B for brachiocephalic, C for left carotid, S for subclavian. If you see the heart structures, so this is the three vessels. You remember, don't forget. By the end you will understand. So how it happens? Superior vena cava, inferior vena cava comes to the right atrium, then flows to the right ventricle. From right ventricle goes to the pulmonary artery trunk, then from pulmonary artery to the left lungs, then from lung it comes to the pulmonary vein, then left atrium, then left ventricle, then aorta. So, and you can see this is the left coronary artery and aortic bulb. How it is, the roots of the aorta, you will find the coronary arteries. Okay. So as I told in the morning, CT basics, you know, Hansfeld units, windowing, leveling, planes. So everything morning I have explained, what is the brightness, what is contrast, what is the windowing. Okay. Now let's go to the slice anatomy. Here it is going to subclavian, okay, subclavian artery, okay. Then what is brachiocephalic artery and subclavian artery, right side, okay. Can you find three branches in aortic arch? See, brachiocephalic, common carotid and left subclavian. Then what is this? Contrast artifact. Then three yellow field structures. What is this? Lung, trachea and esophagus. And then right lung apex, trachea and esophagus. This is a incidental finding of patient's lipoma. Okay. So can you find the left brachiocephalic vein in superior vena cava? Then arterial structure I have explained. Three arteries so nicely you seen. Now we will come to the venous structures. Venous structures you will find in the mostly in the right side. Artery structures mostly in the left. So see, brachiocephalic, superior vena cava. See, aortic arch. This is aortic arch. This is two muscles here. What is that? Major is the protecting the minor. Anteriorly pectoralis major, posteriorly minor. Then what is that? right side venous structure SBC. Then go down, how it is going, see, remember here one structure is there diagonally going and mixing with the superior vena cava. Very good. Okay, so don't get confused. Understood? Now bifurcation of trachea, that is carina. Then go down, what is in the red? So anteriorly big vessel is a ascending aorta, posteriorly in between is the pulmonary trunk, in between trunk, otherwise called aortopulmonary window. So this is called left pulmonary artery, this is right pulmonary artery. Okay, okay, this is pulmonary trunk divided to right from left. Understood? Why it is important? When you are contouring the heart, cardium, heart, you should contour 1 centimeter or just below the pulmonary trunk. Remember RTOG guideline. Then thoracic aorta, descending aorta, no doubt, any doubt? Then left atrium, what is coming to the left atrium? Aorta, pulmonary vein. So see, okay, this is superior pulmonary vein, superior pulmonary vein. Then left main coronary artery, root of the aorta, you see how it is opening. If you want to contour the coronary arteries, you can see the left main coronary artery. Understood? Then coronary artery is divided into left circumflexor, left anterior and descending. That is going for circumflex and descending. Any problem? Understood? Now see, going down, see, what is that? Aortic valve. Okay? I am going up again, sorry. If you follow this aortic valve, aorta will open to ventricle, right ventricle, left ventricle. See, going I am down, going, so how it emerges in the left ventricle. So this is your left ventricle. Now going up, sorry. Now you follow the superior vena cava, that you follow this one. Okay, where it will open? Right atrium. See, follow. This is right atrium. Okay, you can, if somebody asks you, show me the right atrium, you don't go single tendentially DC right, no, you follow the vessel. If you follow the vessel, you will reach your target. Okay, now what is this structure? Pulmonary trunk, that is where it opens? Right ventricle, pulmonary trunk. Okay, follow that. I am not, you have to follow this vessel. Okay, follow. I am going. Now you find this is the right ventricle. Listen, understood? In between right ventricle and left ventricle, there is a called thick interventricular septum. Okay, this is the thickened wall of the right ventricle, left ventricle. Understood? So you have identified right atrium, right ventricle, left ventricle. Now another structure is left atrium. So this is called pulmonary vein. Okay, from lung it comes to drains to the left atrium. So what do you have to follow now? This pulmonary vein, left and right. Okay, now this posterior line you have to follow. Okay, now follow it. Okay, this is
this back side is the left atrium. Okay, understood? So if you see, if follow the left atrium, from left atrium it goes to the left ventricle. Follow, I am going up again, how it is left atrium and merges with the left ventricle. See, okay. Okay, understood? Very nice, nothing to worry. This is the filling of the right ventricle. This is the pericardial sac. Okay, so when you are contouring pericardium and cardiac contouring, when you are contouring the heart for the cardiac sparing, breast cancers and everything, you never contour the pericardium. You have to contour the heart only. So if you see, this is the pericardium, this hypodense area in between the heart, it is called the pericardial sac. So if you contour that area, definitely your cardiac dose will increase. So you will have the problem. Understood? So you can see the pericardial sac. If you contour you contour this area, you should not contour. Understood? Any doubt? I will go back. Anything anybody wants to know? Just let me know so that I can go back. Okay. Shall I go forward? Okay. So I will you understood the vascular structures, you understand the ventricles, you understand the cardiac structures, you understood the everything. Now we will go to the nodal stations. How many nodal stations are there? 14. 14 nodal stations are there. Okay. Remember, very tricky answer question. If number 2 to number 9 involved, it is N2. 11 to 10 to 14 is involved, it is a N1. Contralateral N3. Finish. There is no need to remember anything. Okay. So nodal stations. So there are many nodal stations along the tracheobronchial and vascular tree of the lung. You see many stations. How to remember all these things? Is it difficult? Don't worry. So you have to remember some borders. Upper part of aortic arch, lower part of the aortic arch, trachea, corona, carina. You see, this is the aorta, this is the carina, and upper border of aortic arch, lower border of aortic arch, aorta pulmonary window. Okay? Any problem? No. If somebody don't mind, can I close the door? So you see, this is the upper paratracheal. Number 2 is upper paratracheal. Above the aortic arch and below between the aorta area, it is the 4th number. It is the lower paratracheal. Left, right. Then aortopulmonary window node. This is aortopulmonary window. This is the 5th. Then 6th is the para-aortic node, lateral to the aorta is the para-aortic node. Then this is the perivascular nodes. Okay, perihilar nodes 11 to 14. 7th is the carinal, subcarinal node. Because below carina, what is the remember? 8th is the para-esophageal and 9th is the pulmonary ligament. Understood? Remember? Let's see by another way. So this is a supraclavicular and upper paratracheal. Above the clavicle is the supraclavicular, inferior to clavicle is infraclavicular or paratracheal. Okay. Then another thing we missed is the third. Posterior to the vascular structures, anterior to the vertebral body is the prevertebral. Anterior to the vascular structures is the prevascular. Around the aortic arch is the 4th. Above the aortic arch 2, lateral to the aortic arch 6th, between the aortic arch and pulmonary trunk 5. Very clear. Then this is the aortopulmonary window where you will find the 5th station. Then 7th is the subcarinal, 8th is the paraesophageal. Then we will go to the CT scan to see. You have seen in the X-ray view. Now see, group third node is the pre-vertebral. Then upper paratracheal and around the vasculature anteriorly it is the prevascular nodes. Your radiologist is given the prevascular nodes. Understood? This is the para-aortic node, sixth one, and 4R lower paratracheal nodes. Okay? You will find one important thing here along the internal mammary artery. It is the IMN node. IMN, if you get IMN nodes, then this is the aortopulmonary window or subaortic nodes. This is 10th. The 7th is the subcarinal, below carina. This is the paraesophageal, and sometimes you will get paravertebral nodes also. Then 8th is, this is the paracardiac node. This is the pulmonary ligament node along the pyramidal 9th, and 8th is the paraesophageal node. Okay? So this is the all stations left right. Hope you will never forget in lifetime. Okay? Then how to understand it is a malignant looking or benign looking. So this is very important. Usually not accurately, mostly less than 1 centimeter nodes we are thinking as a sub-centimeter nodes. More than 1 centimeter nodes we are thinking is a malignant usually, but it is different from the different stations. It is thorax is different, abdomen is different, inguinal is different, everything is different. If you have 2 centimeter node, inguinal may be benign, so it is different. Remember, if your thickness in the lymph node in the all are similar, you can come front. If similar, cortex and medulla is similar, mostly it is benign. If it is cortical thickness increased in the malignant. Okay? Mostly lymph nodes are elliptical, but if it is rounded, mostly looks like a enema. So I will tell about the magic things in the head and neck chapter. So you have to make a long axis and short axis. You have to measure. So if it is long axis, which station, there is a big chart. I am not able to remember and I cannot explain also. Let's see. So you can axis, you cannot tell that it is malignant or benign. If there is a 2 centimeter node, necrotic node, conglomerate node, definitely it is malignant. Even there is a suspicious, you have to use PET CT, endobronchial ultrasound, fine needle aspiration bronchoscopy, everything you can do and do that. Then bronchial tree. This bronchial tree, right main bronchos, left main bronchos. After if you follow this main bronchos tree, after giving the upper lobe bronchos, the lower and middle lobe bronchos together is called bronchos intermedius. Remember? Bronchos intermedius. Here 2 lobes only, upper lobe, lower lobe. Only this is, what is this? Bronchos medius. So A is the primary bronchos, this is the secondary bronchos, this is bronchos intermedius. So proximal bronchial tree can be contoured. Even you are contouring for the SBRT long, the proximal bronchial tree can be contoured using mediastinal windows, cartilage rings, airway channels associated with these structures. Inferior 2 cm of distal trachea and the proximal airway, both sides should be contoured, and immediately at the level of segmental branch. Let's see. So you have to contour like proximal bronchial tree contour starts from 2 cm above the carina. Dekho, you contour. Okay, contour is going. You stop here. Understood? Now vessels I have already told. Sorry. You stop here. Understood? Now Vessels I have already told. This is the aortic arch, this is the superior vena cava, this is the esophagus, aortic arch, esophagus, this is the cord area. Okay, so this is all about the anatomies. Anatomy finish: bronchial tree, vessel, heart, lung, and pericardium, all things substance. Now we will go to the pathology. What are the staging? 7th, 8th staging is the difference. 7th is easy, 8th is slightly difficult. So why? So this is the 2015 given. Who is giving the staging? In the mostly by International Association of Study on Lung Cancer. They, as a CC, they adopt. So they have a group of lung centers to understand the lung staging. Then they will, as a CC has to adopt. So these are the various previously T1 lesion, T1A, B, C. These are not there in 7th, 8th. It is started. So what is the difference between the 8th and 9th? 7th and 8th. 8th is T1A is A, B, C to A, B is there, but here no T1 7th was not there. So nodal stations I told already. 1 to 2 to 9 is the N2, 10 to 14 is the N1, contralateral is the N3. When the concept of oligometastasis is coming, because single mets they have a different A1, B, C. Another thing, good clue idea I have to give. T3 different nodule in the same lobe is a T3. Different nodule in the different lobe same lung is the T4. Different nodule in the opposite lung is the M1A. Very good. M1B is the single organ mets, M1C is the multiple mets. Okay? Then see how the staging happens. T1, it is at less than 3 centimeter, not too close to the proximal bronchus. Then it is clearly surrounded by the lung. This is T1. Then T2, more than 3 and away from the main bronchus more than 2 centimeter from carina, and there is a visceral pleura invasion or some sort of atelectasis. Then T2, it will not close, no? So this is the T2 where you can see the partial collapse. Then T3, when the any size, chest wall, mediastinal pleura, pericardium, and within 2 centimeter of carina, and atelectasis and consolidation is there, entire lung, then it is a T3. So when the chest wall invasion is there, you have to should tell as a T3. When there is a chest wall invasion, always ask for the MRI of the chest to see the proper muscle and cut rib involvement. T3, you can see where there is pericardium or pleura involvement. Imaging for T4, you can come front. So imaging structures T4 is the mediastinum, heart, great vessels, esophagus, vertebral body, carina, and T1, then the other lobe. So you can see this is the other vascular structures, all things are involved, you can take as a T4. And group is this is the hilar group in N1, this is group 10 number N1, this is N2 is the mediastinal node, N2 is the mediastinal node, same side, N3 it is the opposite and supraclavicular node involvement. Lung lesion is here, but opposite mediastinal, it is a N3. Okay, so this is the histology. Then this is the normal staging. Then please we will come to the histology. So this is a solitary pleuroluminant nodule. Sometimes you are getting confusion, patient has to go repeated biopsy, regular follow-ups. So there is various guidelines to understand the solitary defined what is the SIP line, less than or equal to 3 centimeter, not touching to the hilum and mediastinum, not associated with adenopathy or atelectasis, and well nodule. So how to understand? There is a various guidelines. I am not going to properly. So there are low risk, high risk, intermediate risk. I am not going to theory. Okay, malignant. Because we are interested in the malignant. So you can see this is speculated margins. This is called a corona radiata sign or speculated margins. Apart from that, you will get like normal brain calcifications. You will get many calcifications in the lungs also. This is called a diffuse calcification, central calcification, popcorn calcification, laminated calcification, stippled calcification, and eccentric calcification. Mostly the stippled and eccentric calcification are taken as the malignant. So malignant calcification 7% on CT, usually eccentric or finely stippled. Pre-existing calcium can be engulfed. Patient having all calcification is there. New tumor come, that can be also done. Dystrophic calcification, when you can find in the tumor necrosis. Calcium deposits, if there is a mucinous adenocarcinoma, you can get the secretory function. So tumor calcification, you can see large bronchial carcinoma invading the mediastinum demonstrates the coarse cloud like calcification. Previously one calcification is there, now tumor invaded. Another histology, bronchoalveolar carcinoma is no part of the adenocarcinoma. Remember, when tracheobronchial tree is lined by the squamous epithelium. As you go to periphery, automatically at the end of the alveoli there is the glands. So it is adenocarcinoma. So squamous carcinomas are more common in the central part. Adenocarcinomas are common in the peripheral part. So clear. So may be associated with pulmonary fibrosis or pulmonary scars. See, this is called ground glass. Hope everybody understand after COVID what is ground glass. So there is nothing. Ground glass, more the solid pattern, more the malignant. Okay. So ground glass. So ground glass says early stage, bubble like hyperlucency, pseudocavitation, airway dilatations. These are the called ground glass edge. So this is a ground glass alveolar cell carcinoma. These are mostly EGFR positive. Bronchoalveolar carcinoma, mostly EGFR positive. Okay. This is a, because of the obstruction, there is a local hyperaeration. You can see the hyperaeration. Air stuck inside. So this is called local hyperaeration. CT angiogram sign refers to vessel appearing prominent in the tumor. Okay. Why it is important? When the any lung lesion, when involving the pulmonary vessels, there is a poor outcome. So in that time, you can do the cell CT angiogram. Small cell carcinoma, central, speculated nodule, lymphadenopathy. Large cell carcinoma, large peripheral mass with irregular margin, necrosis, rapid growth. You can see. Adenocarcinomas, peripheral location. Sometimes it is impossible to radiographically distinguish between the other histological lung cancer types. Adenocarcinoma, peripheral location. Squamous cell carcinoma. Remember, those having the old scars, bronchial scars, lung scars, you will able to find the squamous cell carcinomas are more common. So you will find golden sign, cavitation, pleural effusion, abscess-like lesions, usually mostly common in the squamous histologies. You can see this is called bronchial cutoff sign. In that, if you see this area, there is a bronchial cutoff ho gaya because of the tumor. This is a cavitary lesion, abscess-like squamous cell. If you find like this, you think that it is a squamous. Golden S sign because of the bronchial obstruction collapsed. This is squamous. Red tail sign, bronchial obstruction ho, bronchial obstruction. So there is a collapse of the lung. So this is called a red tail sign. This is a feeding vessel sign. If you see metastatic lung lesions, lesions, you have to find the vessels. End of the vessels, there will be a deposit. So this is called a feeding vessel sign. T in broad appearance, post radiation changes, T in broad appearance. Nodular radiation changes, old scars. These are the breast cancer you have treated, lung cancer you have treated. There will be nodular radiation pneumonitis. Ground glass haziness, post RT. So my sister having breast cancer. What happened? She was in a different place. She is not with me. What happened? He has some type of cough. I asked her to go to do a chest CT because some sort of dyspnea happened. then the doctor seen that before 2-3 months she has received the radiation. After seeing this, she has taken Corad 5. So we started the periphery, they started the COVID treatment. Then I told, you send the CD, I want to see. Then we gone through it. It is a fibrosis. So why I am telling you, never ask a CT scan patient if he is the asymptomatic in 3 months or 6 months. You will get a hazy sign and it will get confused with breast cancer irradiation treatment. Unnecessary, it will investigate many things. Radiation fibrosis, you will find old radiation fibrosis, scar like sign like old esophagus, you will get the square sign. Doubtful conditions, when you doubtful everything, when things are suspicious, PET CT is auspicious. So nodule in other lobe, where is the doubtful conditions? Nodules in other lobe. How to understand? How to understand what is it, that other nodule, is it the correct or not, or granuloma? When there is atelectasis and consolidation, how will you differentiate? It is a tumor or the collapse lung or that thing. Then rib and chest wall invasion, how will you do these things? Suspicious node, how will you find out? So when it is not clear, you have to go. It is now clear that it is unclear. So when it is unclear, think of nuclear. So you have to do the PET CT. Okay. So why PET? It is a pulmonary nodule, tumor versus atelectasis, nodal staging, screening and radiotherapy planning. So where is the target? As I told, if you take extra, you will have a side effect. If you take less, you will have a recurrence. So you have to do the suspicious satellite nodules, differentiating between the tumor and atelectasis collapse, suspicious chest wall invasion, you can differentiate properly. Suspicious node, there in the CT and PET CT, it is a positive. Suspicious paravertebral node, it is there, you did a PET CT, it is a positive. Okay. So in advantage, several tumors, whole body imaging, functional anatomy, high resolution, high sensitivity, high accuracy. But sometimes because we are the tuberculosis area, sometimes we are getting non-specific of the tumor type, can be false positive, unnecessary upstaging. So what is the T stage? If it is upstaging, prevents tumor missing. If it is downstaging, you can dose de-escalation is possible. If it is upstaging, prevents from the tissue missing. Upstaging, it is with treatment policy will change. If you have a M stage, curative to palliative, upstaging. Downstaging, you can become the palliative to curative. So our eyes should be like a eagle's eye, not a bird's eye. Thank you. డోర్ క్లోజ్ చేస్తున్నాను. We will start abdomen because I am not willing to put you in a hungry state because hungry makes person angry. Okay. Imaging of abdomen and pelvis also very important from day to day practice. Though many GI structures we are not acquainted to CT contouring, but pelvic structures, prostate, these are the very important structures to understand. So abdomen pelvic imaging with clinical correlation. Again, where is the target? It's the same thing I told, you have to proper imaging resolution things, it will be helpful to you. So morning to evening we are just pushing the target forward or backward. So this is our target. So if you are doing a contouring error, once you do contouring error, it is a systematic error. Once everything goes wrong, if you do some positional error or something, it is a random error. During simulation, during contouring, during planning, all things are, if you do some errors, it is a going whole the planning system, it is known as a systematic error. So, how to study a cross sectional image? Either you can study by slice, go by multiple windows or organ wise. In abdomen, if you study by organ wise, it is very easy. So, as I know, I told window width, window level, I am not going to tell you about again. So in what to read? In abdomen, we have to study organs, OAR, GTV, stomas, muscles, bone, vessels and nodal regions. So, as you know, which is anterior, what is posterior, what is lateral, by right and left. So, this is a multiplanar, axial, coronal and sagittal. So, let us study stomach. First, let us study the stomach. Stomach, it is the G junction here. If you see slowly it is G junction, before G junction comes, you feel part of the stomach, it is already in the there. That is the fundus. Why it is important? When you are planning for the esophagus G junction tongue, fundus sparing IMRT, it is another concept where you have to spare the fundus. Why you want to spare the fundus? After the cross protocol, you have to anastomatize the stomach into the esophagus. So, there will be radiation leak. So, you have to control the fundus, then body fundus. So, let us see, this is the fundus, this is pylorus, this is field. So, here it is very important when you are going for the radiation, if you are going for the empty stomach, if you are going for the empty stomach, hold the stomach treatment. If you are treating a pancreas, if you are treating in empty stomach, what will happen? All stomach collapsed. It will around the pancreas, it will be there. If it is a full stomach, part of the stomach will touch and most of the stomach is outside. So, it is always a problematic. So, how many? So, you cannot tell always a partial stomach you have to treat. So, what you have to treat is a collapsed, empty stomach. So, you see the PTV here. So, if you collapse it long, so you can analyze what is the problem. So, always treat with an empty stomach. Then small intestine. Small intestine, what are the parts? Duodenum, jejunum and ileum. After the pylorus, you will find the part is the duodenum. Along the head of the pancreas is the second part, then it is the third part and fourth part. You can see here. So, this is a jejunum. How to find the easy identify of the jejunum and duodenum? So, this is a ileum. I will tell you. So, how to identify the jejunum so easily? What is the jejunum part? Jejunum is staying in the left side of the abdominal organ, and hope you have seen this video, seen this snake crackers in your childhood memory. So, if you see, it looks like a snake cracker. Okay, so jejunum looks like a snake crackers. So, it is very easy to identify, go and practice in your CT scan. Then ileocecal valve, after ileum you will get the ileocecal valve, then colon, this is the cecum, thickened part, cecum, then cecum, ascending colon, see the ascending colon, then hepatic flexor colon, the colon around the hepatic area, then transverse colon, around the stomach also, transverse colon, then splenic flexor, then is descending, then is sigmoid, and this is the rectum. Finished? No, this is anal canal. So, how to differentiate a small bowel and large bowel? Again, it is a very thing. So don't eat your scalp. So, remember this scalp. Okay. So, how to remember? They have a specific character. The plica circularis in jejunum, hostration marking in the large bowel. Caliber is small in the small intestine, large in the large bowel. Appearance with oral contrast, you will find it is faded with oral contrast in the jejunum ileum, but transverse colons addition of mottled appearance with fecal matters, gas. Location usually central, large bowel is the peripheral location, patency is mostly collapsed and a dilated large bowels. Okay, let us see one by one. So, it is a small version, it is a peripheral, large bowel is mostly peripheral. So, if you see, this is the peripheral location, small bowel is the central location. Then this is a small caliber, large caliber, as you know, seen with good with contrast. These are small calibers and these are the large calibers and mostly collapsed. And if you see the large intestine, there will be hostration markings peripherally located, feet with what fluid material, gas and fecal matter. So, always large intestines are mixed and this is the peripheral location, mostly large intestine. Understood? Very easy to understand, just you have to apply your thinkings. Understood? Then CT imaging of the liver. Liver, because why it is important? When you are study hepatopancreaticobiliary tree, you have to understand the proper the liver anatomy. So, in this study, we have to study the three phases: arterial phase, venous phase and delayed phase. So, how to understand, how to study? It is all software based. You take to your patient, ask your radiology technician, tell that I want a triple phase CT scan, they will click the switch, all triple phases will come differently, different images. So, you no need to be worried, but reading is important for you. So, how to read? Non-contrast, everything looks hazy. Arterial phase, in arterial phase, aorta, celiac artery, supramesenteric artery, all arteries looks brighter. So, it is a arterial phase. Then what structure to see in arterial phase? Aorta and its branches. Then portal venous phase, in this structure liver parenchyma, portal vein, splenic vein, portosplenic confluences, IVC, these are looks brighter. Okay, understood? And solid organs like kidney, spleen, liver, they looks brighter. Okay, so what you will to see in the portal venous phase? Aorta, inferior vena cava, portal vein and solid organ parenchyma. Then delayed phase, what will, so if you given contrast, where it will go? Through kidney. You will see calyces, ureters, bladder, all these things you can see nicely. Renal collecting system, urinary bladder and ureter. So, blood supply of that, why it is again important? Suppose you are planning for a SBRT liver and pancreas, you are treating the patient within breath hold position. So, this triple phase CT takes 40 to 50 seconds. Patient can withhold breath hold with only 20 seconds or 30 seconds. But how will you do that? So, what you have to do? You go analyze previous images, you see your lesion is clearly visible in arterial phase or venous phase or delayed phase. Suppose your first is the arterial phase, middle is the venous phase and last is the delayed phase. If your image lesion is more accurately seen in the venous phase, give injection. After 10 seconds, ask to the breath hold. So, your system is synchronized. Suppose your image is best visible in the delayed phase, then after 20-30 seconds, ask the patient to the breath hold. So, that time you will get a breath hold phase. Understood? This is called synchronization. If I get a time, I will tell you about the motion management system, I will tell you. So, this is important how the so this is the mostly supply by portal vein and hepatic artery, major supply by portal vein. So, lobar anatomy, left lobe and right lobe. Okay. So, these are the segmental anatomy. How many lobes? 8 lobes. 2 lobes, 8 segments. Each segment have a all triads. Okay. So, this is the 8 segments of the liver, 1 to 8. How to remember all segments? Let us make it easier. So, This is the clockwise, left lobe is 2, 3, 4, and this is side, right side is 5, 6, 7, 8. Again confusing, how to remember? Let's see. These are the liver segment by hepatic vein, left lobe, right lobe, and center is the caudate lobe. So again it says different names. If you want to remember, no need. All segment 8, segment 7 lesion, you can identify segment 7, segment 8, segment 5, 4, like that. So where is the caudate lobe? So I am here. So caudate lobe is in the central or always hiding. So this is the segmental anatomy. This is the segmental one. Segment 1, what is the around the portovenous system or portal triad. So to make the very simplification, I have adopted this thing from various presentations. Here, if the center segment 1 around portal triad, segment 2 under the heart, because it's 2, 3 in the liver, left lobe, 3 adjacent to the stomach. Anything is the stomach is the segment 3. Right to the falciparum ligament is the 4th. Right to the falciparum ligament is the 4th. 5th is the adjacent to the gallbladder. 6th is to the adjacent to the right kidney. 7th is the underneath of the diaphragm. 8th is the adjacent to the chest wall and chest wall. So any chest wall, it is 8th. It is very easy to remember, and you cannot differentiate by every time you should not go and open the book which segment. Okay. So this is about the liver segments. Then gallbladder and bile ducts. So this is the cystic duct and common hepatic duct. Two common hepatic, they combine together the common bile duct. Then they comes to the pancreatic duct and they forms the opened in the duodenum second part known as the ampulla of Vater. Understood? Any doubt? No doubt. So this is the biliary tree, pancreas, how it opens, cystic duct, right hepatic, common bile duct, open into the duodenum. So if you see, this is the fundus, gallbladder, corresponding body. So what happens, how to delineate the CBD, common bile duct? It is very important, and if you understand the common bile duct, you have to, if a patient is, gallbladder is distended, you can able to find out. So to distend gallbladder, what do you do? Now you have to take CT scan now in this position when you are feeling hungry. So you will find there is a dilated CBD inside there. Okay. So this CBD is goes posteriorly to the duodenum and opens into the joins with the pancreas inside the pancreas. So common bile duct contours should start at the first bifurcation or its entry to the portal triad, inferior to the first part of the duodenum. It passes posterior medial to the duodenum and joins to the pancreas. In irradiation of caudate lobe liver causes stenosis of the CBD. So this is the how you the portal triad, you can go, you can see how it is going backside, sorry. It goes and so combines with the accessory pancreatic duct. Okay. So this is how CBD contour should be done. It needs some extra practice. Even I cannot do properly CBD contouring. It is so not so easy. Then we have to do the spleen. Spleen. There will be a accessory spleen. If there is a sometimes you people see the small spleen here. This is called accessory spleen. Don't confuse with the splenic node or some at the metastasis. Okay. So to understand this accessory spleen, you have to understand properly. Adrenal glands, inverted Y. How to identify the adrenal glands? See, this is the medial lobe, body, and lower lateral limb. So if you see, this is placed not above the kidney. It is the medially to the kidney. So this is the inverted Y structure presented to the structure is the adrenal gland. Then pancreas. If you see the pancreas, you will find the tail is first, then you will find the, if you go from up and down slice by slice, you will find the tail first. Splenopancreatic junction, you will find the first, then you will get the head last. Understood? So this is the pancreas, tail, body, head and uncinate process. Then again, if you are planning for the pancreatic SBRT, if you give contrast, you will have a very high monitor units and always a erratic planning. Always you have to use water for the stomach or something, so that it will take as a negative contrast. So if you want to study the imaging of the pancreas, you can part 1, part 2 studies there, you can study. So you have to use neutral oral contrast, means water. It is called negative contrast. When you want to study the pancreas, you have to go for the negative contrast. Pancreatic protocol, use water rather than contrast. Pancreatic phase instead of arterial phase. Pancreatic phase refers to the late arterial phase. That is I told, when the parenchyma you will see better in the venous phase or late arterial phase. So intraperitoneal, all organs lined by the visceral peritoneum. Another structures are the extraperitoneum. There is lined by red. So these are the structures extraperitoneum, by retroperitoneum, suprarenal, aorta, duodenum, pancreas, ureters, colon, kidney, esophagus and rectum. Okay. When you are feeling hungry, let me know. Don't force your mind to listen. We have till 7 o'clock. I am here. So abdominal vasculature. So this is the abdominal vasculature aorta. Abdominal vasculature aorta. So why 3 branches are very important? 3 branches are very important. One is the celiac plexus, another is the supramesenteric artery, another is the inframesenteric artery. So how to identify so easily in the vessels, and you will understand properly. So this is the pelvic vasculature. I will come one by one. So let's see. This is the called portovenous anastomosis complex. This is supramesenteric vein and splenic vein. They combine together forms the portal vein. Okay, always you have to trace supramesenteric vein and splenic vein. They will go to confluence. Then you will go to the portal vein. So this is the bifurcation of portal venous branches, right portal vein and left portal vein. So this is the abdominal wall. So these branches you have to see. One is celiac trunk, supramesenteric, renal artery, inframesenteric, iliac artery. So how to identify? Elongated structure above the pancreas, along the structure above the pancreas or superior border of the pancreas is a celiac artery. Okay, how elongated structure from aorta? You see, this is a celiac artery. Okay, now just below is the supramesenteric artery behind the head of the pancreas. This structure, vascular structure, has to be properly identified when you are staging the resectable, unresectable, borderline resectable pancreas. If you don't understand then which is resectable, which is unresectable, then it is a very difficult. Then if you see, this is the renal arteries. You see the renal arteries here going to the kidney. Then mid aorta, then you will find very small artery. I think battery khatam ho gaya. Laser not working. So so you will find small arterial bulb, small artery. That is this small artery. Laser is not working. I think battery finished. So small artery is the inferior mesenteric artery. Why it is important? Inferior mesenteric artery, very small artery. Why should we remember all these things? When we are contouring the major rectum, you are contouring the major rectum. If you have to trace the inferior mesenteric artery slowly, so it will happen the pointer. No, slide changes. They give me slide changes. No problem. Not working. Slide change is working. No, slide changes sir is working. Only laser is not working. Give me. No problem. So this if you see, this is the inferior mesenteric artery here. So this is, you have to trace down and down to find the branches of superior rectal artery and colonic artery. That is the superior border of the your major rectum. When contouring the C rectum, that is very important. Remember. Then it is the divide aortic bifurcation, left common iliac and right common iliac. Then common iliacs, internal iliac and external iliac. No problem. Then femoral arteries. Then femoral vein. Medial to the femoral artery is the femoral vein. Now I am going up. Artery I came down, vein I am going up now. So femoral vein, if you go, this is iliac veins, then right common iliac vein, then inferior vena cava, iliac veins, then renal veins, then inferior vena cava. Here I want one thing I want to tell about. Inferior vena cava has a two parts, extrahepatic inferior vena cava and intrahepatic inferior vena cava. So don't get confused. Superior mesenteric vein here, mesenteric vein is more diameter and medial to the right, towards the right to the superior mesenteric artery. Okay. Then portosplenic confluence, where splenic vein and think confluence happens. Then portosplenic proton and splenic veins, and then this is the portal vein. Okay. This is the vasculature, so nicely you can see in the CT scans, MRI, go and slice by slice, you try, it will happen. Then what are the anastomosis? Anastomosis is another thing important. When you have a patient, surgeon sent to you for after gastrectomy or after pancreatectomy, you have to find the anastomosis, because if you don't contour that, you will have a anastomotic recurrences. So how to identify anastomosis? It is a tricky job. So in Whipple's surgery, they do three anastomosis. What in Whipple's surgery, what they do? They will do the pancreatectomy part of the, they will do the biliary structure, they will do the gallbladder. All structures they will finish. So how to the bile will drainage from the liver? So they will do hepatico-jejunostomy. They will do hepatico-jejunostomy to drain the pancreatic juice. They will perform the pancreatico-jejunostomy. They, to form the food passage, they will do the gastrico-jejunostomy. So these stomas you have to identify properly for the pancreatic biliary tree anastomosis, pancreatico-biliary tree contouring. So gastrojejunostomy, hepatico-jejunostomy, pancreatico-jejunostomy and cholecystectomy they will do. So this is which stoma? Pancreatico-jejunostomy. So you have to find out the remnant pancreas and there will you find the anastomosis. This is the pancreatico-jejunostomy. Okay. Now this is the pancreatico-jejunostomy, remnant pancreas. Then you will find the pancreatico-gastrostomy. Okay. Then in this area you will find hepatico-jejunostomy. These three stomas very important when you are contouring for the post-operative pancreatic cancer if there is a indication. Now tell me, in which stoma you will not include in your contouring? Pancreatico-jejunostomy you have to include because pancreas is there. Hepatico-jejunostomy you have to include because biliary tree is there. You should not include gastrojejunostomy. There is no tumor inside, not in the jejunum, not in the gastric. So that stoma has not be included. Now in stomach surgery, again there are two surgeries done, Billroth 1 and Billroth 2, where gastrojejunostomy or gastrojejunostomy they will do. So that is also important. You can see here gastrojejunostomy. So if you this thing thickened wall, you have to slice by slice by slice, you have to study. So gastrojejunostomy, if you are able to find, very good. If you are not able to find, call your surgeon or call a radiologist, study properly to understand the anastomosis. Then abdominal musculature. This is the right abdomen rectus and left rectus. This is the linea alba. So this is the two oblique muscles, external oblique, internal oblique and transverse abdominis. This is transverse abdominis. Why I am telling about the muscles here? Is it important? Yes. When you are going for the abdominal surgery, soft tissue sarcomas, if you don't know the muscle layers and these things, you can do the brachytherapy properly. You can do the brachytherapy properly. Then these are the Schwann muscles. Why this is important? Schwann muscles is important. Iliopsoas muscle, this contouring for the lymph nodal structures important, because in this patient, if a patient having flexion deformity patient comes to you, think that there is a mass or lymph nodal mass, it is in the Schwann. Ask the patient to lie down. If it is a flexion deformity, definitely see a cervix mostly, and there will be a Schwann attaching to the Schwann. These are the erector spinae. These are the Schwann muscles. This is called iliopsoas complex. No, it is not working. Give me that laser. No? So this is iliopsoas complex. This is Schwann. So this is obturator foramen, where you have to stop your contouring of the obturator node here, and this is the obturator internus. This is the levator ani muscle. This is a good muscle. This is levator ani muscle. It is important when you are doing anorectal contouring. Then this is important. These are the gluteal muscles, obturator externus, obturator internus, and these three muscles are important. Why? When you are contouring the inguinal nodes, three muscles are very important. So you have to pectineus muscle, tensor fascia lata, and this I am coming there. So this is the three muscles here again: gluteus minimus, intermedius, and maximus. Okay, and iliopsoas. Then female pelvic structure, it is very easy: uterus, cervix, and vagina. Major rectum, as I told, eros, major rectum, you will find there is a density change. You scroll your mouse and adjust the window, you will find the major rectum here. So major rectum boundaries are here. I am not going to detail because it will take more time. And this is the major rectum, how major rectal cancer goes to the major rectum. I am not going to tell about this. Urinary system, you know, kidney, ureter, bladder. This is the kidney, calyceal systems, ureter. Ureter is very important. So sometimes you are confusing with the delayed phase ureter, you confuse with the some artery or something. You have to trace from the calyceal system, and it goes and opens posteriorly, not laterally. It opens posterior obliquely. You see just, so it is open posteriorly. This is ureter. So if you want to take the trace the your ureter, always take the delayed phase CT. Then seminal vesicles and prostate. This is the seminal vesicles. Looks like, in MRI looks like grapes, bunch of grapes. So let's see, this is the bunch of grapes. So if grapes are wrong, seminal vesicle is involved. Okay. So these grapes are looks nicely, and so this grapes are looks good, means seminal vesicle looks good. But if seminal is grapes are kharab ho gaya, तो it is think that seminal vesicle is involved. Okay. If I get a chance, I will go to prostate contouring, I will tell that. Okay. Then this is the your seminal vesicle. Then so after prostate, lower part is the apex. In between apex there is the urogenital diaphragm. After urogenital diaphragm, this is the penile bulb. So A union B, you can remember like this: A U B, apex, urogenital diaphragm, and penile bulb. So these three structures you have to differentiate properly. Two things remember: if you are able to identify the apex properly, okay. If you are not able to identify, you go to the histoacrop guideline of the prostate cancer contouring. You just contour your penile bulb. After that penile bulb, give 1 cm or 0.7 cm margin up. That is your apex ends there. If you are, but your remember, your PTB should not overlap with the penile bulb. So as I told, you contour the penile bulb. After that, give 1 cm margin. This is the prostate. This is the seminal vesicle. So this is the urogenital diaphragm. Okay, that is 0.7 to 1 cm. Remember, Sometimes they will tell how much seminal vesicles to be contoured, either full, 2/3, 1/3. If there is involved, you have to treat all seminal vesicle. If it is high risk or low risk, intermediate risk, you have to treat part of the. So how to contour? Give the prostate contouring, give 1 centimeter or 2 centimeter margin, then crop. You can measure in the coronal section, sagittal section. Okay. So this is the how to measure. Then it is good to search, good meaning genitoureteral diaphragm. If you are able to find out the genitoureteral diaphragm, it is very good. So how it looks? This is the genitoureteral. It is a rectangular structure. So this is the, it has a 3 parts again. Genitoureteral diaphragm is a triangular structure, oval structure, oval structure. So this is the levator ani. You can see this is levator ani. You cannot differentiate properly in the levator ani in CT. You have to do a T to MRI to understand properly. So another part is the neurovascular bundles. These are located posterolaterally. Prostate cup, neurovascular bundles. These are the neurovascular bundles. So even if you go for MRS study like brain, you can go for the MRS brain in the prostate cancer. Okay, this is called urogenital triangle of the perineum. I am not going to the. Another last thing is the parametrium. How to parametrium also important than the contouring. So these are the various boundaries, anteriorly bladder, posteriorly anterior part of the rectum. These things, all boundaries are there. I am not going detail. Just one slide I am going. Suppose if you have a contouring the post of CS cervix or post of endometrium, how to understand what is the upper level, where is the, so you put a slight marker inside or gauze piece, or you can able to find out what is the upper border of the vault. Lymph nodal stations, see the continuity, see the contour, see the location, follow the vessel. So let's see. This as I told, what is the magic C? If you see what is the exactly, it is a malignant or benign. How to differentiate properly? So you have to follow these C structures. What is clinically? You have to find clinical. If there is a clinical node, you find contrast. If it is a contrast enhancement, see the contrast enhancement. You see. Then continuity. Lymph node will not continue for long. If it is a vessel, it will continue. If slice by slice, you go ahead. Node will never continue. Contour. Usually, vessel usually have a smooth contour. Nodes having not smooth contour. Contralaterality. Vessel always bilateral. Node will not be bilateral. So if there is enlarged node, it cannot be bilateral. Then conglomeration. If there is a conglomeration is there, definitely it is a node. Cystic component is there, maybe necrotic or some cystic vessel. Vessels have not a cystic component, and circular shape. So these magic C you have to analyze. What are those magic C, 8C, so that it will differentiate the vessels to node. These are the Japanese classification, what they have given 16 groups of lymph nodes in the abdominal vasculature. So these are various structures and organs. So these are the, it is the based upon the site, based upon the organ wise, it is differentiated like splenic, gastroduodenal, hepatic, left gastric according to the positioning. So I will, these things I am just here I will tell you. So this is a crural because of the diaphragm crura. Around the colon, it is middle colic. This is anterior diaphragmatic. This is the gastroesophageal name. This is the left gastric. This is the phrenic. This is a greater curvature nodes. This is a hepatic group of lymph nodes. This is a pyloric. This is celiac. This is a supramesenteric area. This is a gastroduodenal group of lymph nodes. Then supramesenteric. Then periportal. Then pancreaticoduodenal. This is a pancreaticoduodenal. Then renal hilar nodes. Then aortocaval. So para-aortic nodes again divides into pre-aortic, para-aortic, retroaortic, like that. Precaval, retrocaval and paracaval. And between there is the aortocaval. This is aortocaval. This is a renal hilar node. This is a para-aortic node. This is para-aortic. This is inferior mesenteric, around the inferior mesenteric artery. You can appreciate here. Then common iliac. Then these are the iliac group of lymph nodes. This is the external iliac and internal iliac. Then abdominal gastrohepatic. This is portocaval. This is aortocaval. This is left para-aortic. This is mesenteric. Then these are the along the vessels. You can see this is the external iliac and internal group of iliac. Okay, I will see. So lymphatic drainage, previous various organs you have to remember during for exam and what the proper. This is the aortic bifurcation node. Then common iliac. Then internal iliac. Then external iliac. Then inguinal. So this is inguinal. So this is which node? Perisacral. Then perisacral group of lymph nodes. Then perisacral. This is obturator. So how another good thing is that when you are contouring the guideline for the inguinal nodes, this is good article actually. So you have to inguinal vessels. You have to 4 boundaries like that. You can this is the pectineus muscle. This is the no muscle here. This is the tensor fascia lata and sartorius muscle here. Let's see. So when you are doing clinically, you don't know 2D planning you are doing. So always your inguinal group lymph nodes you have to give 2 cm margin below the lesser trochanter. Your lower border should be here. You cannot stop here. That is for the 2D planning when you are treating the inguinal group of lymph nodes like C, anal, canal and all things. So summary of inguinal nodes, cranial, these are the various boundaries you can remember. Then bony landmarks. So this is the which muscle? Piriformis muscle. When piriformis go down, when piriformis muscle appears, you stop the perisacral group of lymph node. That is corresponds to S2. This is piriformis muscle, 34 number. This is stop external iliac when you are contouring here. Stop here the obturator nodes. Then this is the anorectal junction. You have to, this is contoured anorectal junction. This is corresponds to the anorectal junction. OARs, bowel bag, you can do bowel bag or individual OARs. But remember, you are contouring OAR for the bowel bag and taking the individual bowel constraints. It is not like that. If you are contouring the one thing, take that same OAR constraints. And rectum, you have to use sagittal view to make the you are following the contour of the rectum. So where is the when you are contouring the anorectum, it is very difficult to differentiate between the prostate and this margin. Understood? It's very difficult. How to do? You contour slice by slice here. In between, you interpolate. Roughly, you will. It is a guideline from ISTRO guideline. So you will able to contour the anorectum somehow better. So this is a rectum contour, this is the levator ani and this is the levator ani muscle. Liver contouring, there is an important thing. If your inferior, if segment 1 is primarily posterior to portal vein, so liver contour should exclude the portal vein. If you go to the RTH guideline, segment 1 is primarily posterior to the portal vein, here, segment 1. So liver contour should exclude the portal vein. But if it is one left to the portal vein, then you have to contour the, include the portal vein. This is the tricky. Penile valve, as you know, it is often teardrop shaped located opposite to the base of the penis, and you can penile valve contour, you can take the help of the MRI and there two crura of the penis, when it comes you stop there. Then femoral head, again it is important. Femoral head, people stops when the femoral head stops. You should not. You have to go to contour till the lesser trochanter. You have to contour till lesser trochanter. Then primary imaging model for the abdomen pelvis should go for the plain film contrast abdomen. Basic anatomic knowledge improve the diagnostic accuracy and contouring accuracy. Communication between referring clinicians, if you tell this group of lymph node, this gastrohepatic lymph node, you tell, there is a lymph node. It does not mean anything. If it is a communication better way, you slice by slice you have to study. So thank you very much for the, it is abdominal. Then we have a single head and neck. If you are interested, I can go for the liver prostate contouring. I can go for the stereotaxy contouring after head and neck, or you can finish as per your convenient. Then apart from the slice by slice anatomy in the this class, it is a long class, because as you know, head and neck contains many structures. As I told, where does a radiation oncologist want? It is a clear identification of organ or AOR. That is the main importance. So hope with this good resolution also important. So what are the contents? Mostly muscles, vessels, sides, subsides, bones, cartilages, sinuses, nerves, external auditory canal, orbital and nose. These all subsets are there. So that's why it is very difficult. If you see the bones, what are the bones are important for us is mandible, hyoid, hard palate and styloid process. These 4 bony structures are important. Then muscles, if you see tongue muscles, floor of mouth, pharynx, pharyngeal constrictors and face muscles like platysma, buccinator, temporalis, masseter, medial pterygoid, lateral pterygoid, digastric muscle. What is, how it is very important, how it to go understand and all things will go ahead. Then vessels, external carotid, internal carotid, facial, lingual, retromandibular vein, common facial vein and internal jugular veins. Cartilages again, hyoid, thyroid, cricoid, arytenoid, corniculate and cuneiform. These are sinuses, palate, pharynx, larynx, buccal mucosa, floramma, tongue and neck spaces. So many structures, so complicated anatomy. Hope I will make you understand within a stipulated time. So first you go for the neck node. I think some people are coming, we'll wait. So first we will go from neck node. I will just give the boundarical outlines. No need, as you know, all things you understand properly. You do the in India practicing head and neck cancer, everybody knows the nodal contouring. So these are evolving guidelines from the RTOG guideline. Vincent Grieger is the pioneer in the neck nodal contouring guidelines. So as you see, how many nodes are there? Hundreds, 200, 300, many nodes are there. If you go to a good institution, good surgeon, they can dissect out hundreds, 40, 50. So don't happy with a small, somebody dissected 10 nodes. And this is the level, you can see level 1A, 1B, 2A, 2B, 3, 4A, 4B, 5A, 5B. So this is a grossly nodal neck node. And if you see, the main muscles is the trapezius muscle and sternocleidomastoid muscle and anterior strap muscles. These are the boundaries various for the lymph nodal levels. So according to the level 1 is submental, submandibular, level submandibular, jugular, cervical nodes, supraclavicular node, pharyngeal, paratracheal nodes, retropharyngeal nodes, parotid nodes, buccal nodes, retroauricular and occipital. So these are the 12 groups. Abdomen 16, lungs 14, neck 12 group of lymph nodes. So modified, this is the new classification by Grieger group, and this is the mostly they divide into new terminologies like XA, XB, buccofacial, posterior skull groups. So these are the all varied, that 12 groups in defined in remodified to 10 groups. So identifying the hidden node, that is very important. Sometimes you are confusing. If you are suspecting any node, you are giving extra dose. If you are missing it, you will get a nodal recurrence. So for these things, how to understand the magic C, as I know, how to understand these C structures. Let's see one by one. So you have to palpate the node properly. If you palpating one node here and not palpating, think that there is a node. So clinical examination is very, very important to understand the nodal structures. Then clinical examination is very important. Then you see the contralaterality. If you see, this is the submandibular gland. Anterior to the submandibular gland there is a node. You may not get there a node. So always compare with your, if there is a doubt, always compare with your contralateral. Then contrast enhancement. You see this is a conglomerate node which is contrast enhanced. Vessels will full enhance, it is a homogeneous enhancement, it is will be heterogeneous enhancement. Then cystic node, if there is a necrosis or you will get a cystic nodes. You vessels you will not give us any cystic areas unless there is a thrombus. Then contour, if you see vessels are a regular contour, here some irregular contours, so thickened, anteriorly thickened, posteriorly thin, like that irregular contours. Then capsular breach, that is called a perinodal extension. If there is a mostly 3 cm above, it is a perinodal extension, but you can see the capsular breach. Vessels have not a capsular breach. Then cortex to hilum, we have to find the loss of fatty hilum is the significance of the lymphatic node. You see the central hilum, it is preserved here. So, it not be a node, benign node. Like that continuity, if you see the continuity, vessels continue from the top to bottom. Nodes it will obstruct, it will finish there. So, always differentiate from the vessels to the nodes. Then conglomeration, this is the possibly here conglomeration, again another C, conglomerate of some nodes. Then circularity, it is a mostly circular, but proper node is elliptical. Then clot or thrombus, you will find in the vessel. So, you do not think that it is a node, it is a thrombus or thing. Then criteria, size criteria. So, you see as usually sub-centimeter nodes we do not take as a significant, it will with, but many things you have to see, size, shapes, central hilum and all things. After that we will find the a long axis diagonal more than 10 mm plus a long to short axis ratio of less than 1 point is suggesting a metastatic node. Lots of rules are there, but see, if you are in doubt, treat it, because if you head and neck, if recurrence comes, you cannot do anything. Whatever you do, it is bad disease. So, if you treat, let patient stay without recurrence rather than toxic. So, these are the OR guidelines for the Green Journal publication. So, how to identifying the nodes? So, to identify the nodal levels, you have to identify the muscles. What muscles you have to identify is the digastric, mylohyoid, trapezius, sternomastoid, levator scapulae, scalene, strap muscle, platysma, vessels, carotid, jugular veins, bones, transversus fossa of C1, mandible, hyoid, cricoid, clavicle and skull base. These things you have to keep in mind. Then if you identify these structures, nodal contour is finished. So, what muscles you have? You can see this is the genioglossus and lateral is the mylohyoid muscle. In between the hyoglossus, these 3 muscles, trio muscles, genioglossus, hyoglossus, mylohyoid. So, this is the genioglossus, medial is the genioglossus. Genioglossus means genu of the genital tubercle of the mandible plus tongue, the genioglossus. Mylohyoid line of the mandible is the mylohyoid. Then in between there is a small thin muscle is the hyoglossus. Okay. Then you have to know this big muscle. Nobody, not everybody is the favorite muscle is the sternocleidomastoid. Then internal jugular vein and external jugular vein. Bigger ones are vein and smaller ones is the artery. Okay. External carotid artery anteriorly, external carotid artery and internal carotid artery. So, again geniohyoid, these muscles. So, if you see, these are the vessels, lateral to the sternocleidomastoid, this is the scalene. In between 2S, scalene and sternocleidomastoid, you will find the vessels. This is the levator scapulae and these are the trapezius muscle. This is the posterior is the trapezius muscle. This is the hyoid bone, this is the submandibular gland, and division of the internal posterior to the internal jugular vein is the 2B, anterior to this is the 2A. So, this is the boundary between the 2A and 2B. So how to contour? Very simple. Identify the muscle, identify the vessel, identify the cartilage, identify the bone, contour the fat space around vessels and between muscles, avoid muscles and bone. This is very simple. But remember, when there is you are suspecting extracapsular extension, always include 1 centimeter of muscle down to up lateral. So I have to find, so what are the lower levels roughly from the skull base to caudal process term? This is the retropharyngeal group of lymph nodes or retrostyloid group of lymph nodes. From the caudal process of transverse process to hyoid is the 2, hyoid to cricoid is 3, cricoid to manubrium is the 4 roughly. Then this is the boundary of the various group of lymph nodes, submental, submandibular and upper jugular. Though I am not going to details, you can have slice by slice, it is very nicely given to everything. So this is the submental group of lymph nodes, where you are treating the lip cancer and some anterior buccal mucosa tongue, you have to include all these things. Then posterior to the if you see this area, anterior to the this area is the mostly submandibular gland, and posterior to the submandibular gland to till the posterior group of the posterior border of the sternocleidomastoid is the 2, and this is the 5 group of lymph nodes. Again same thing here, this is the level 5, level 2 and anterior the VA 6A. Same thing, these are the various Vore, 4B and lateral supraclavicular nodes. When you are, these are important where you are treating about the nasopharynx cancers and all things in the posterior part. Then though in recent classification where you will find the retroauricular, pre-occipital, buccofacial group of lymph nodes, you can see here this is the retropharyngeal group of lymph nodes. Then this is the retrostyloid, this is the parotid group of lymph nodes. So you can see this is the retropharyngeal, this is the retrostyloid and this is the parotid group of lymph node. Remember, when level 2 lymph node is positive, always include the same side retrostyloid node in your subclinical level. Then this is buccofacial. So you see buccofacial group of lymph nodes, that is between the parotid duct and anterior to the masseter and lateral to the maxilla. So this is the buccofacial group of lymph nodes. Then retroauricular, it is the name itself defines posterior to the external auditory meatus, and there is a boundary then occipital group of lymph nodes. So if you see anterior posterior edge of sternocleidomastoid and posterior to the lateral edge of trapezius. So this is the, these things are important when you are contouring for the scalp lesions, external auditory meatus canal tumors. Then this is the buccofacial, retroauricular and occipital. Then these are the, or roughly I told about the lymph node groups. You can study, it is not a big deal, and every time you will listen and contouring, and I think tomorrow it is a contouring class is there. I think they will going to teach you about the lymph node. Let's see the radiology of floor of mouth, floor of mouth lesions. So if you see the radiology of floor of mouth, this is the platysma muscle, digastric belly. These are the mylohyoid muscle. Mylohyoid muscle is the continuity, this arch muscle. Then genioglossus, geniohyoid, you can see, let's see one by one. So this is the frenulum, deep lingual vein, photographs showing the superficial under floor of mouth. Then boundary, these are the sublingual space where your sublingual gland is opening to the floor of mouth about the your secretions. And what is this? This is the parotid duct. Opens in the upper alveolar level second molar tooth, and this is the submandibular gland, and sublingual gland and submandibular glands are adjacent to each other. Then you see sublingual space in the axon, as I told, this is a geniohyoid, then hyoglossus, then mylohyoid. This is the three muscles, and the fatty space, that is the sublingual space, it looks hyperintense in the MRI. Then this is the, you can see again in MRI picture, all muscles, genioglossus, hyoglossus, mylohyoid. These three muscles you remember. One muscle here, genio, hyoglossus and mylohyoid. Again genioglossus and hyoglossus, you see genioglossus, hyoglossus and mylohyoid, this arch. So again in the different form, red is pink is the genioglossus, yellow is the hyoglossus and this green is the mylohyoid. So this is the all about the floor of mouth muscles. Why it is important? When you are doing for the floor of mouth brachytherapy and all, always know the vessels level and you have to go suprahyoid needle applications. Radiology of cancer buccal mucosa. You see the left side, here the lesion is there. You don't know whether bone is involved or not. How will you understand? Then you have to study about the puffed cheek technique. This is puffed cheek technique. When you are taking a head buccal mucosa cancers, ask your radiologist to take the puffed cheek technique. In the puffed cheek technique, you can see this this is buccal muscle, you can see lesion, it is a clear margin. Here this is the lesion. So this is the puffed cheek technique. If you do the puffed cheek technique, you can understand the extension, ulceration, involvement of bone, everything in the buccal mucosa cancers. So this is the lesion here. This is the parotid duct. Buccomacety denoted by the zygomatic major arrowhead. This is zygomatic major. Masseter muscle is the M. This is the masseter muscle. Buccinator is the, this is the buccinator, plus sign, and boundaries of oris orbicularis, that is oris orbicularis and angulus oris. This is for the oral lip and oral cavity muscles. So if you do the puffed cheek technique, it is also very beneficial. You take a coronal section, you see this GBS and this GBS whether really involved or not. You compare with other boundary, this boundary to this boundary, you can able to understand properly. So this is a puffed cheek technique where you can see the lesion. You cannot appreciate properly bone is involved or not. You can see here nicely. Then you can, here you see this gingiobuccal sulcus is free. This is the normal thing. Here gingiobuccal mucosa is involved. Then you see retromoral trigon area mass, and this is the retromolar trigon, as you know, posterior to the last molar, and it is a area from the tendons originating from the pterygoid humulus. So this is the retromolar trigon area. You can so this area is very important. As I told, these lesions can go to the intracranially very easily. Then spread of retromoral lesions in the RMT areas, you can spread to the buccal mucosa anteriorly, posteriorly to go to the muscles here, it is go to the tongue. So it is a junctional area where base of tongue, flora, mouth, masticator space, everything can be involved easily. So again you see this RMT cancers, how it is going up, how it is going to the maxilla and that pterygoid plate area, how it is going inside and how it is involving. Then you can see cranially there is a intracranial, this is intracranial extension, how it happens. You see it is a, if it is a lesion, if you don't take the proper CT scan, you will find that lesion in the buccal mucosa. But if you take a puffed cheek technique, you can see the lesion is from the gingiva. So here you can see the bony erosion. This is a mandibular erosion. There is a pterygopalatine fossa extension, you see, infratemporal fossa extension. You see this is the involvement of the which muscle? medial pterygoid and lateral pterygoid and pterygoid plates. So this is the left buccal mucosa cancer involving the masseter, loss of fat planes with masseter, and left mucosa with RMT involvement. This retromoral area is free, this retromoral area is the involvement. Then mucoepidermid carcinoma, when you find a lesion in the buccal mucosa with no ulceration, it is a sublingual. Mucosa is free, but there is a nodular lesion. Think that it is a minor salivary gland tumor. So minor salivary gland tumors usually never ulcerates, they have a nodular lesions. So these are nodular regions. There will be, you see the buccal mucosa skin is, a buccal mucosa is totally unbreached. Here you can see the buccal mucosa lesion is the ulcerated, there is orocutaneous fistula. Here the lesion is the in the lower alveolus, left lower alveolus. So this is the just grossly about the tumors of the hard palate, buccal mucosa, RMT and all things, so that you can identify very easily. Now I have to go to the hard palate. So appreciating the lesions in the hard palate in axial section is very tough. You cannot find the lesion in the axial section. So what the things you have to do? You have to take a sagittal section. You can see this is the proliferative lesion. If you always take the you want to see the appreciate the hard palate lesion, you have to take a picture in the sagittal view. If you take in the sagittal view, it will be easier to the appreciate the ulceration. When you are contouring the sagittal view and contouring the hard palate cancers and soft palate cancers, always take in the sagittal view, so you can appreciate properly. You can take in the bone window, you can see there is a bony erosion here. So we cannot appreciate in the axial view. In axial it is only you will find in one slice. In one slice you cannot appreciate everything. Then tonsil, pharyngoepiglottic fold and grossoepiglottic fold. This is the tonsillar lesion here. Though there are two anterior tonsil pillar and posterior tonsil pillar and anterior tonsillar pillar. So you will find the normal tonsil, glossoepiglottic and pharyngo, I think there will be palatoglossous muscle where palatoglossal arch and palatopharyngeus, you will find the lesions, tonsil area. So this is the, you can find here tonsillar lesions here. You can see here no tonsillar lesions. So if you want to study proper imaging in oral cancers, you can go to by Dr. Suprita Arya's madam's lecture article. It is very nicely given, and imaging in oral cancers. Then we will go to the larynx. As you know, larynx has three parts: supraglottis, subglottis and subglottis. So these three structures has a different importance in their structures. So you see, this is the glottis how looks nicely. This is the epiglottis, this is the E fold, this is the piriform fossa. Let's see. So supraglottis extends tip of epiglottis to laryngeal ventricle, and glottis is from laryngeal ventricle to imaginal line 1 centimeter below this level. Subglottis is the under surface of true cord to inferior surface of cricoid cartilage. So gross anatomy, supraglottis is what are the plants? Epiglottis, preepiglottic space, arytenoid cartilage, aryepiglottic fold, false cord and paraglottic space. In glottis, true vocal cord, anterior commissure, posterior commissure and subglottis. So this is the trachea. This is the thyroid cartilage. This is thyroid cartilage. This is cricoid cartilage. These are tracheal rings. This is thyrohyoid membrane. This is hyoid. This is thyrohyoid membrane. This is cricothyroid membrane. Remember. So this is the epiglottis, thyrohyoid membrane, thyroid cartilage, cricothyroid membrane, cricoid and tracheal rings. So this is your epiglottis. anterior to the epiglottis, this is called pre-epiglottic space. So, most of the times the lesions in the supraglottic or vallecular lesions, when you are contouring, always include the pre-epiglottic space, otherwise pre-epiglottic space recurrence is more. Let us see one by one. This is paraglottic space, again very important, this is paraglottic space. So, this is the paraglottic space, you can remember. So, this is the thin arrow is the epiglottis, false chord elbow arrow, this is the false chord, and laryngeal ventricle is the thick arrow, this is laryngeal ventricles, and paraglottic space is the, this is the paraglottic space. So, you can compare with the and this is the nothing but your epiglottis. This is to anteriorly, what is that? Vallecula. So, anterior openings are the vallecula, posterior openings are piriform fossa. So, this is the median glossoepiglottic fold and lateral glossoepiglottic fold. So, in this there you will get the vallecula. Then this is the star is the pre-epiglottic space. So, this epiglottic space is to be included in your CTB even if it is not involved, and you can see here this is the A fold and this is the piriform sinus. Again you can see this is the A fold, this is the A fold and this is piriform sinus. This is the midline thin is the thyroid cartilage. The IOE fold is the thick bent and piriform sinus notched arrows, and the paraglottic spaces are the curved arrows. So, again normal under if you see false chord small arrows, this is small arrows, false chords, paraglottic space curved arrow below, these are the paraglottic space actually, this is paraglottic space. Again this is the anterior commissure, this is a vocal cord, this is the anterior commissure, this is a posterior commissure. So, this normal larynx and the, what is this cartilage? Cricoid. So, you can see in the coronal section, a sagittal section, the pre-epiglottic space. Then pharynx, pharynx is three parts as you know, nasopharynx, oropharynx and hypopharynx, very simple. So, nasopharynx, this is the oropharynx, hypopharynx, this is the glottis and trachea. So, this is the pharyngeal mucosal space. So, if you see this is the hard palate, this is the soft palate and this is the epiglottis, this is the piriform fossa and these are the vocal cords. Why I am telling the boundaries. So, till the lower border of soft palate is the nasopharynx, then this is the oropharynx, this is the hypopharynx. So, if you go to the nasopharynx side, there are two, one is the torus tibialis and in the lateral pharyngeal recess, this is the otherwise known as Rosenmuller fossa. So, if you see this is the internal carotid artery or internal jugular vein, this is maxillary sinus, this is two muscles, medial pterygoid and lateral pterygoid, this is masseter muscle, this is a temporalis muscle, this is the total masticator space. And two this prevertebral muscles is known as longus colli. Again you go to this area, this is the oropharynx, tongue, mandibular ramus, digastric muscle. Why this muscle is very important? When you are contouring the parotid, always contour properly here. If you include this muscle, your PTB should in the muscle. If PTB can, PTB should in the, if PTB goes to the parotid, you cannot set the parotid. So, parotid contouring is very important, you should not cross the digastric muscle. This is a sternocleidomastoid muscle, this is the lingual tonsils, not palatine tonsil, and this is the floor of mouth. This is a sublingual gland, looks hyperintense in the MRI, and floor of mouth muscles as genioglossus, hyoglossus and mylohyoid. So, this is submandibular gland, this is the hyoid bone, again it is a submandibular gland here. This is a sternocleidomastoid muscle. This is a glossoepiglottic fold, and this is a glossoepiglottic. This is a pharyngoepiglottic fold. This is a AE fold. This is ariepiglottic fold, and this is a piriform sinus. This is preepiglottic fat. This is a false cord. Lateral to the false cord is the paraglottic space, and this is the thyroid cartilage, and this is the arytenoid cartilage, and this is the glottic space. This is cricoid cartilage, infraglottic space. This is the sternocleidomastoid and trachea. This is the thyroid isthmus. Always remember, when you are contouring, if you are contouring the level 4, level 3 group of lymph nodes, if you just crop at the medial edge of the carotid artery, if you go inside, you cannot save the post cricoid area, you cannot able to save the constrictors. So unnecessarily you are irradiating this area. So patient will have a stricture. So this is the important thing you have to remember. Unless there is involvement, you don't go and treat the post cricoid area. So your just contour should crop here. Nasopharynx. So as you know, nasopharynx is the structure which is very important. It will be very high lymphatic drainage, high chance of intracranial extension and everything. So this is the nasopharynx area. So this is the Eustachian tube opening, and this is the torus tibialis, and this is the Rosenmuller fossa. So for nasopharynx study, we have ammunitions like CT, MR, PET-CT, and nasopharyngoscopy. So these 4 things we have to understand properly. I am going to detail with nasopharynx anatomy. So why MRI is needed? These are the structures. Only we people tell that soft tissue delineation is sufficient. No. So for soft tissue delineation, for the marrow involvement, you can tell that there is no erosion in the clivus, but if there is a marrow involvement, you can see in the MRI. If there is a parapharyngeal extension, you can see in MRI properly. Optic chiasma you want to contour, you want to spare. So how can you do in the CT? Then optic chiasma contouring is very important. Then hippocampus, if you are a boy, it is a bimodal distribution. If you are a boy, you want to spare the hippocampus, you can contour on the CT, very difficult. So you need an MRI. Differentiating retropharyngeal group of lymph node. Sometimes the retropharyngeal group lymph node you cannot appreciate properly in the CT. And perineural spread, any perineural spread or foraminal spread, you can spread the intracranial spread, this is the important thing. So this is a mucosal involvement, you cannot appreciate in the CT properly, small lesion. So you may be a big node with a small lesion like that. So why PET? Because sub-centimeter node, carcinoma of unknown primary, suspicious soft tissue involvement when there is there, we need also PET. So we need PET, we need MR, we need CT. So this is the imaging GTV. You can see here with MRI, you PET, and actually PET is this one. So these are the all mucosal lesions, that edema. So always MRI, PET, CT, all are, you can see here, this is the MRI, it is showing there is a lesion, but actually it is no FDG uptake here. So this is the unknown primary, when there is a node, but you are not able to find the primary. PET is definitely, it is an important thing. So sub-centimeter node is there in, either it is sometimes sub-centimeter node also hyperactive. You can tell that, so you can do the super sub-centimeter node in PET. So always MRI, PET, CT we should take together, and what are the good things with them, we should go ahead. So first important thing with nasopharyngeal examination is the nasopharyngoscopy. So if you see, first the torus tibialis here, then fossa of Rosenmuller, you go from the nose, the Eustachian tube opening, torus tibialis, and this is the fossa of Rosenmuller. So this is the nasopharynx area, this is the Eustachian tube opening, this is the torus tibialis, this is the Rosenmuller fossa. So in this structure you see this is the pterygoid plates, pterygoid process, this is the torus tibialis, this is the rajonulnar fossa, this is the clivus bone, this is the prevertebral muscles, this is the masseter muscle, this is the temporalis muscle, this is medial pterygoid, lateral pterygoid. Each structure is more important in their things. So this is the masticator space, this is the parapharyngeal space, this is the parotid space, and this is the yellow is the carotid space. So these spaces are very important. So parapharyngeal space, again it is a space, fatty space anterior to the vessels, the superiorly skull base, inferiorly hyoid bone, anteriorly pterygomandibular fossa, posteriorly prevertebral fossa, medially pharyngobasilar fossa, and ramus of the mandible. So you can see here, this is the fatty anterior to the lateral to the nasopharyngeal area, you will get the fatty space, and it is a conical structure going down. So you can see here, see the pharyngobasilar fossa. I am not, it is not understanding very difficult, forget it. So this is the parapharyngeal, this is the tensor veli palatini and levator veli patent, two muscles here. So to understand, I have already morning I have explained the all foraminus. You have to understand all foraminus before going to the nasopharynx treatment. And this is your structures like maxillary sinus, pterygopalatine fossa, pterygoid plates, carotid canal, everything has to be understood properly. This is the thing, as morning also I shown. This is the pterygopalatine fossa, this is the Vidian canal, foramen ovale, foramen spinosum, foramen lacerum. All these are very important. So endosetting foramen is, you know, bone window you should do. You can, without doing the bone window, you can not able to understand how the clivus is involved, pterygoid fossa involved. You cannot able to understand properly. Then all are the cranial nerves with foramens. You can remember what is going and it giving rise to which syndrome. That is the very important. So there are 10 syndromes are there in nasopharynx. Go ahead with and see. So boundary of nasopharynx, posterior nares and posterior margin of nasal septum, inferiorly soft palate, superiorly basis sphenoid and basis foot, posteriorly C1, C2, laterally the pharyngeal opening of stancho is located in the center of the lateral wall, lymphoid aggregates, tonsil, tubular tonsil and rosenmuller. So this is the nasopharynx boundary here. You can see this is the area where this is the clivus, C1, C2, this is the soft palate, this is the posterior nares. So this is the pterygopalatine fossa, this is the clivus, how the tumor is going posteriorly to involve the clivus here. So in this space, you can see nasopharyngeal space going to foramen lacerum oval, giving ophthalmic symptoms and facial pain. If it is going to the histogenitube, gives otitis media. If you go to nose and orbit, gives the epistaxis and proptosis. Go to bone and lung and liver, cervical nodes, retropharyngeal group of nodes, and parapharyngeal group of nodes, and gives the trismus. And pterygoid muscles also give the trismus. So if you see the superior spread, it goes, clivus bone has eroded. This clivus bone, sleeping bone, the clivus bone is eroded and it is going to the intracranial. Lateral spread, if you see, it can go parapharyngeal space, parapharyngeal fatty space, as well as the goes to the spreading the lateral pterygoid and medial pterygoid. Inferior spread goes to the soft palate, and even sometimes I have seen the lesions in going to the oropharynx and laryngopharynx. Anterior spread go to the nasal cavity, posterior nares, even sometimes I have seen goes to the nose also. Posterior spread, it goes to the longosculi muscles and vertebra. So this is the, you can see the posterior spread. You can see the muscles, even sometimes lesion is going infiltrating the clivus and even brainstem, very aggressive lesions. Then lymphatic innervations, as you know, because of lymphatic drainage, lymphatic innervation, it is very important to understand. So if you change the staging of this T category, parapharyngeal extension is T2, but parapharyngeal extension soft tissue involvement, medial pterygoid, here there is some difference. I will tell you in next thing. Bilateral lymph nodes less than 6 above supraclavicular fossa, but they didn't give the proper boundary. In 8th edition, they were given is the lower border of cricoid cartilage. This is the important. Let's see. So in 7th edition, if it is the involvement of lateral pterygoid and medial pterygoid, it is a T4. In 8th edition, medial lateral pterygoid, it is a T2. Understood? This is very important. Then this is the T1 nasopharynx, where the Rosenmuller fossa is involved. T1, very early lesion, diagnosed. You cannot diagnose if there is some lymph node, some people will present, then you can go for the diagnosis. Then T1 nasopharynx, in the Rosenmuller fossa, tumor confined and a small metastatic left retropharyngeal node. As I told, if there is a retropharyngeal group of lymph node, you cannot identify in the CT, you have to go for a MRI. Then prevertebral extension, prevertebral muscle extension, it is a T2. Then T2 nasopharynx parapharyngeal extension, parapharyngeal space involvement, this is a fatty space. If the parapharyngeal extension is there, it is a T2. Then T3 nasopharynx, straight arrows with extensive spread posterior to the longus scoli and a clivus. So T3 involvement is the clivus. Nasopharynx, it is involving the clivus. You can see here the destruction of the clivus bone and the marrow changes. T3 pterygopalatine fossa involvement, it is a T3. Anterior spread, it is going to the ethmoid. This is the lamina paparia, which is separating the orbit to the nasal cavity. This is the posterior nares. T4 nasopharynx, it is going to the foramens. If you go to the bone window, it goes to the foramens. Then cavernous sinus involvement, again T4, all muscles. So according to the involvement of cranial nerves, vessels, you will get the symptoms. T4 foramen is the lacerum involvement. So this is the foramen lacerum involvement. So change in the nodal staging, as you know, lower body of cricoid cartilage is supraclavicular fossa is taken out, and lower body of cricoid cartilage is the. So this is the supraclavicular fossa. Previously, what they given the boundary, now it is not there. It is below caudal border. So this is the. If this, why I am telling you, this group of lymph node is very common in the. So you have to treat, if there is there, you have to go to 70 gray. If it is not there, at least you have to give to 50 to 60 gray in that area. Nasopharynx N1, as I told, you cannot tell that it is a T1 lesion or a retropharyngeal node. So you need an MRI for the proper identification of the node here. Nasopharynx N1, again two bilateral retropharyngeal group of lymph nodes are there, N1. This is again patient in shows metastatic node in the left upper internal zone, which common site for the metastatic node. N2, this is the N2 bilateral node. N2 bilateral node. N3 below caudal border of the cricoid cartilage and more than 6 centimeter. So when you are contouring the nasopharynx area, so always confusion what to include and what not to include. So this is nasopharynx areas. You remember scope. This structures has to be in your CTV. Sinuses, sphenoid, maxillary posterior 1/3. To prevent the recurrence intracranial extension this area, we have to go to 0.5 centimeter or posterior 1/3 of the inside the maxilla. So skull base, subpalate, clivus. Clivus, cavity, nasal posterior 1/3, cavernous sinus, Meckel's cave, oval foramen ovale, pterygoid palatine fossa, pterygoid fossa, parapharyngeal space, petroclival fissure, proper nasopharynx and ethmoid posterior. So these structures you have to remember one by one. You have to contour according to the stage. And if you want to go through this article, non-syllabus articles, you can go and study. So, if your partner is the radiologist, it is very easy to identify, call and torture him or her, so that you can get a proper therapeutic index. Okay. So, this is the all about the nasopharynx. Then we will study about the nasal cavity and paranasal sinus. This is the nasal cavity, this is the maxillary sinus. So, this is the maxillary sinus, nothing to worry. See, there are two foramina here, greater palatine foramen. If you very thin slice if you take, you will get the palate. If my skull may be there, you see the palate, posteriorly there will get the two foramens, one is the greater palatine foramen. So, greater palatine foramen anteriorly, lesser palatine foramen posteriorly. Skull is there, huh? Okay. So, this is the superior turbinate, middle turbinate and inferior turbinate. Inferior turbinate is the largest, superior is the smallest, middle is the middle. So, this is the superior concha, so, this is the superior meatus inside the cavity. So, this is the meatus, superior meatus, middle meatus and inferior meatus. So, this is the ethmoidal group. See, this is the anterior ethmoid, posterior ethmoid, there is no middle ethmoid, and this is the sphenoid sinus. So, between that is called sphenoethmoidal recess. So, this is the this area is very important, as I told, and this is the posterior boundary of maxilla, and this is the frontal sinus here, two frontal sinuses. Then here is called nasopharyngeal ducts, nasolacrimal ducts, that is opening anteriorly. Sphenoid bone, as you know, this is the sphenoid bone is precellar, cellar and postcellar. This is the three parts sphenoid sinus. And nasal septum is anteriorly cartilage, posteriorly the bone. Superiorly, bony septum has a perpendicular ethmoid and inferiorly vomer bone. You can see ethmoid plate, anteriorly cartilage, posteriorly bone, anteriorly superiorly ethmoid, and down is the vomero. Nasal cavity, as you know, these are the various boundaries you can study. This is the maxillary sinus, nose, nasal septum. So, this is in short, this is the maxillary sinus and nasal septum. Then parotid gland. Parotid gland also important, as you know. Without parotid gland contouring, if you don't contour properly, it is you cannot spare properly. So, there is a contents called external carotid artery, parotid duct, retromandibular vein and facial nerve. So, you see this is mandible, anteriorly two vessels, retromandibular vein and external carotid artery, and posteriorly it goes from anterior to posterior the facial nerve. So, that is why this stylomastoid foramen, which is important for the contouring. Then masseter muscle. So, again this retromandibular vein, this is the two important veins. This is the retromandibular vein, this is the external jugular vein, and this is the internal jugular vein. They combine the brachiocephalic vein. Then let us see. This is the parotid gland, how it opens in the behind the molar tooth. So, this is the parotid duct opening inside the teeth. So, here you can see Stenson's duct, that parotid duct, Stenson's duct, and this is the masseter muscle. Anterior to this thing, the Stenson's duct. So, this is the course of facial vein here, and you can see the anteriorly the retromandibular vein and external carotid artery, and this is the facial vein, facial nerve. So, I am going from up and down. You see the parotid how it's, you remember you have to differentiate your parotid contour from the digastric muscle. If you contour the digastric muscle inside the parotid, you will not able to spare, so it will give the pulse. So, if you see, the parotid some parotid goes anteriorly. Understood? So you should not stop here the parotid contouring. You have to go till anterior masseter muscle, till the anterior border. It is written. So you have to do contouring properly. So how the vessels inside, and you have to go till here. CT scan. The course of facial nerve is like that, a river flow. Then how to anterior buccal mucosa, oral cavity and hypoporopharynx, how to differentiate? You draw a line between the hard palate and the hyoid. 2H join, anterior to the oral cavity, posterior is the. So this is the scalene muscles. This is the clavicle, internal jugular vein, carotid artery. Carotid artery is the medial. Next spaces, as you know, it is the masticator space. This is parapharyngeal space. Blue one, this is parapharyngeal space. Fatty space in MRI. This is a red is the carotid space. This is the buccal space where buccal mucosal lesions will be found. This is a prevertebral space. This is the masticator space. Last is the slice anatomy. Nothing. Just you can. I am just going down. I will show you only one artery. So you follow this artery. This is the common carotid artery. You just follow this. You go. I am going up. You see, just going up. Here it divides. External carotid, internal carotid. Okay. So it divides at the upper border of hyoid cutting. Thyroid, upper border thyroid. So this is the internal carotid, and as you know, this is the sternocleidomastoid muscle, this is the trapezius muscle, this is the parotid space, this are the all, this is the submandibular gland. Slice anatomy as you, if you want. This is the anterior neck muscles also there. Then as I told, muscular walls of the abdomen. These are the muscles of the calf area. When you are treating the soft tissue tumors of the muscles, you have to understand these muscles properly. I have given in PPT just to go through it. And at last, our great teacher Google, and I am finishing my talk further today. If you are interested, anybody is interested, I can go for the stereotactic radiation imaging and prostate contouring or other thing, or we can close here. Close. Continue. We will continue. You are okay? Just go for 10 minutes. We will. So imaging in cranial stereotaxy, when you are planning for the SRS in the brain tumors or brain functional tumor, non-functional lesions, there is a specific protocol. You cannot just ask go for the MRI brain. You may having trouble. So in this juncture, I am going to tell about the how to what is the things, when which situations you will go for the cranial stereotaxy. In this, you have a metastasis, schwannoma, meningioma, AVM, pituitary, reirradiation, trigeminal neuralgia, glomerulus, cavernomas, hamartomas, cyst, and spine. This is the all lesions can be treated with SRS and SBRT. SRS and SBRT. So let's see what are the ammunitions we have. We have a plain contrast cysternography, CT angio, MRI plain contrast, double contrast, triple contrast cysternography, MR angio, MRS, and other functional sequences, nuclear imaging, and we have a DSA, digital subtraction angiogram. So as you know, I am not going to the details about the slicing, windowing and everything. Mornings I have told already. So this is also I told. This is also told. Hounsfield units, everything I told already. So just going to the before, as I told, some people are there or not there. How to differentiate T1, T2, I am just going to tell about. So this is a T1 sequence, easy to identify, all fluids are black. It is helpful for the contouring of the hippocampus, contouring of the optic chiasm. white matter looks white and gray matter looks gray. This if you give contrast, it is a vessel looks hyperintense. Then T1 sequence flip side of the T2 sequence flip side of the T1, where you can see all ventricular fluids looks white, even aqueous humor, vitreous humor also looks white. All cisternous, everything looks white, and all vessels, if you see these vessels in a T2 looks black. So remember, all fluids except vascular fluid is looking white. Now if you see flare sequence, it is a plain flare sequence. The ventricular walls you will find the oozings. If you have a oozing, think that it is a T2 flare. So very even T2 flare, if you do T2, you cannot differentiate which is a tumor fluid or ventricular fluid. If you flare, you can see ventricular fluid is black and this is the pathological fluid is the white. So identify yourself. T1 weighted, ventricles all black, ventricles white is T2, ventricular oozing is the flare. This is the very basic sequence, understand, easy, nicely, you can go ahead and remember in your lifetime. Diffusion weighted image, as I told, when there is a high in a tumor, there is a hypercellularity. If because of hypercellularity, there will be a fluid restriction and that will look hyper intense. This is called ghost image or diffusion weighted image. Then ADC map to measure the how much restriction is there. Full restriction, more malignant, less restriction, less malignant, normal restriction is normal. So to understand this, we have a apparent diffusion coefficient. So those are in the diffusion weighted image looks brighter, it is looks darker. So ADC value if you want to measure, if low ADC value it is more malignant, high ADC value looks goes to more benign. So if you grade 2 grade 1 glioma, high ADC value, low grade 4 glioma, low ADC value. So this is the ADC value. Then planning MRI, as I told, you have to MRI brain, contrast, double contrast, T1, T2 flare, 3D FSPGR, no gap, no tilt, neutral neck, 1 mm slice and 512 matrix. These things, this slide has to go to the radiology. Okay, sir, I want this structure and I have to take full FOB, I should include the body contour, I should take. Without this, if you ask for the people, they will not give and you will not able to match your with a CT. If you want to for normal anatomy, 3D FSPGR, pituitary adenoma star, trigeminal neuralgia fiesta, cranial nerve C sequence, CP angle tumor GRE sequence, glioma diffusion perfusion, AVM angio, grading MRS, metastasis double, triple diffusion perfusion and delayed contrast. So this is FSPGR sequence. It is a very good sequence to understand the optic apparatus, where you want to contour the hippocampus as well as the optic apparatus like optic chiasm. You can see how nicely seeing the optic chiasm. You will not find any sequence this, but the only problem is the G sequence is this sequence. Empiriage sequence is in the Siemens and Philips is the FFE sequence. So a Fiesta sequence, you can see the cisternous very nicely. Fluids, why cisternous? You have to see the cranial nerves so nicely. So when you want to see the Fiesta sequence, cranial nerves, you have to go for the Fiesta sequence. So see how the 7th, 8th nerves seen so nicely in the CSF tracking. Even if you want to CSI or PCI, you want to include the cranial nerves, you just have to take the Fiesta sequence to understand the CSF pathway. When there is a star sequence, you can see normal T1, T2, you cannot help out the pituitary from the packing material. When they do sphenoid sinus surgery, they will take out to prevent leak, they will put fat, they will put mesh. So how will you differentiate which is pituitary and sub? So if you take a star sequence, you will find out differentiate between the fat and normal pituitary. So this is a MRS, where you understand the chemical property of the brain. So in the MRS, you can see the normal MRS is the choline, creatinine and NNA. So, NNA is a good, N-acetyl aspartate is the very good chemical which will help for the neuronal growth, but choline is a bad and lactate is the ugly. So, good, bad and ugly metabolites are there. So, if you see, you have to arrange the choline creatinine ratio. If it is low grade gliomas and high grade gliomas, you see high grade gliomas choline creatinine ratios are more and low grade glioma choline creatinine is less. But same time NA also decreased in low grade glioma and more decreased in the high grade gliomas. Meningiomas, if you have any doubt, you go for the MRS alanine. MR angio is required for the AVM, aneurysms, cavernomas, vascular malformations. Then perfusion scan, when you want to study the how much blood flow to the tumor. How to study? This is called perfusion. In perfusion, you see the blood flow and what is the amount of blood flow you can measure by relative blood flow, blood volume. So, because tumors have a new angiogenesis, so this is called MR perfusion. When your tumor having your suspicion of tumor recurrence versus necrosis or other thing progression, you always ask a perfusion, MRS, diffusion. So, these three things will help you whether it is a necrosis. Necrosis means lactate will increase, tumor means there are various types of MR perfusion. It is not our headache to listen, beyond our scope. Okay. So, gradient echo sequence, as I told morning, you see this is the cystic lesions, hemorrhagic lesions inside the lesion, CP angle tumor. It is a site for the meningiomas and schwannomas. If it is a schwannoma, there will be cyst lesions and hemorrhagic lesions, you will find it. So, you have to find out gradient echo sequence, and if you see this meningioma, there is no cystic lesions and hemorrhagic lesions. Then planning MRI for metastasis, MRI, T1, T2 flare, FS-Pgr sequence, no gap, no tilt, neutral neck. This is the all, this slide has to go to your radiologist. Double contrast, you see, if you are suspecting a brain mets, when you are writing letter to the radiologist, write, I need double dose contrast and triple dose contrast if possible, because cost is very high. And apart from that, I need a delayed contrast. So, three things will important here. Number will increase, resolution will increase, size will increase. See, if you see the double dose contrast, the resolution increased. So, resolution increase, size increase, your PTB volume will increase. You are able to spare the unnecessary, spare the tumor. So, this is very important. If you see, there is a delayed contrast. You see, this is the single dose, this is the 15 minutes delay, this is the triple dose. You can see the resolution is increased as well as the size is increased, number is increased. So, these three is very important when suspecting the metastatic lesion. Always write double dose, triple dose and delayed contrast according to the patient convenience. I don't force the triple dose, meaning they will take another 10,000 rupees and even more Tesla. So, 1.5 Tesla or 3 Tesla, you can get more resolution. Okay. Delayed contrast, if you see, here no lesion, 10 minutes here, 15 minutes here. So, delayed contrast also very important, you can find the lesion. Different contrast agents, there are some other contrast agents also, where you can see gadolinium, gadopentate, this is the and gadobutyral. This can also, if you give these lesions, you can see more resolution. So, planning MR for trigeminal neuralgia, planning MR is the same, and you have to see the Fiesta sequence. Why Fiesta sequence and T2 sequence? You have to see to the cochlea. And so, trigeminal neuralgia, what happens? Your trigeminal nerve is there, superior cerebral artery is crossing. So, you have to identify superior cerebral artery, you have to identify the nerve, and you have to identify cochlea and brainstem. So, to differentiate all these things, you need all sequences. Fiesta sequence for the cranial nerve, cisterna, and
MR angio for the vessel identification, cysternography for the more accuracy. So see, cysternography is again MR cysternography, CT cysternography you can do. You can put some contrast agent in the lumbar puncture and that will go to the intracranially and you can see the cysternography. Let us see CT cysternography, you can see the trigeminal nerve here easily. MRI trigeminal, this is the gastrin ganglion, this is the trigeminal nerve, this is the cisterna. This is called prepontine cistern, this is the trigeminal nerve. MR cysternography, if you do the MR, you can also identify the proper brain stem nerves. This nerves you can see nicely, you can see. So this is the conflict. You can see this is the area where you have to give 80 gray single fraction. 80 gray single fraction. That is the very important and usually everybody cannot practice. It needs more accurate mind, accurate machine, accurate percent. So this is the thing. Then AVM also same thing. Extra thing is required. MR angio and 3D DSA. What is the DSA? Digital subtraction angiogram, where they will take after giving the contrast they will take an X-ray like thing. After they will subtract the bony structures and will get the only vascular structures. But DSA not available every time. So you can go with the MR angio. So digital subtraction also, it is a 3D volume is also there. See, this is the machine for the DSA. They give the contrast agent mask. So this is if arteriovenous malformation, this is called nidus. So this is called DSA. This is a DSA image. So 2D DSA, 3D DSA, 4D DSA, how can you can see the movements. So this is you cannot do it every time, DSA is not available. So you can go for the MR angio. So this is the MR angio. You can see the vessels here. You cannot see the CT properly angio, but so MR angio you can see and fuse it and contour it. Then left basal ganglia AVM, you can do the CT scan here, MRI. So this is the AVM in various MRI sequence, T1, T2, there is a vascular structure, then T2 flare, then then T2 T1 contrast, this is MR angio, you can see, and T1 contrast. So MR angio you will able to find the nidus here. So MRI vestibular schwannoma again for the fiesta sequence and T2 for cochlea. So if you see, this is the ice cream cone tumor. Here you can find the properly here the T1 sequence. So cochlea is not seen properly here. Okay, I will show you some place. Then planning of the pituitary adenoma, as I told, star sequence. So the two here one sequence I am going to tell you properly is the T2 sequence. If you see all T2 sequences, vessels looks black. So if there is a cavernous sinus involvement, you can pituitary gland, if it is encroaching the vascular cavernous sinus, you will able to differentiate properly whether vascular cavernous sinus involvement is there or not. Remember, pituitary gland we are treating how much gray? 50 gray or 45 gray, 50.4 gray. So all lesions beyond optic chiasm, optic nerve is beyond, less than our tolerance. If you miss something, it will come recurrence, and that time you cannot do SRS, not do surgery, nothing. So treat relaxedly. If there is a doubt, if you go to the London cancer guideline, you will tell you include both cavernous sinus, you go for the total pituitary area, relaxedly you treat. What you are going to miss? If you miss something, nobody is going to touch. No neurosurgeon will touch, no you will touch, because re-radiation problems will come. So 50 gray, what is the big deal? Let patient is not going to die, patient will live 20-30 years after his diagnosis. Why something there is a doubt? I have to do the cavernous sinus involvement is there, I have to spare this cavernous sinus, that cavernous sinus. If there is a hormonal issues, patient will survive with hormone.
but if there is a involvement residual is there, you will not re-irradiate, neurosurgeon will not go for the surgery. So pituitary, don't think that I will do SRS. If you do SRS, my optic chiasma dose is getting less, I will get less, so you will take a less margin. So SRS single fraction I don't practice and should not be practiced, because you are trying to save the optic chiasm. What you will do? You will give less margin. Less margin means high chance of recurrence. So if pituitary is there, if there is a high chance of recurrence, what will happen? Patient in the optical problems, neurosurgeon will not do surgery, you will not do re-irradiation. So avoid single fraction radiations to the pituitary. Either at least if you want to do SRS, go for 5 fraction schedule. So as I told, packing material differentiation, it is required. So if you don't able to differentiate packing material and everything, treat packing material, what will happen? But if you were there, never call the patient for treatment again. Treating re-irradiation, you have a headache, severe headache, more than patient. How to spare the optic chiasm in re-irradiation, optic nerve. You are giving 50 gray. What? You are nothing doing blunder. Like that, you will have a meningioma. Meningioma also, one sequence is called nuclear scan, DOTA scan. So you can see here frontal meningioma. Then DOTA scan strongly expresses somatostatin receptor. If you DOTA scan skull-based tumors, the tumors, meningiomas of the cellular origin, meningiomas of the mostly frontal bone erosion origin, you will hardly able to differentiate between the bony lesions and meningiomas. So in that juncture, you can ask for the DOTA scan. DOTA scan will help you to delineate again. Remember, if you are going for 50 gray, relaxedly treat anything, either glioma, either meningioma or optica. If you are going 54 gray, what you are nothing doing blunder. Remember, one person asked me, why brainstem lesion, how can I go 60 gray in a glioblastoma, how you are doing? I told, when the recurrence will come, it will come after 2 years, necrosis will come 2 years, 3 years. Whether your patient is going to survive till 2 years, 3 years in GBM, then why you are getting worried? Give 60 gray. If you give 54 gray and want to spare the brainstem, what is going to benefit? So in low grade glioma, you are giving 54 gray. What is the problem? So if you are high grade glioma, you no need to spare. In low grade glioma, no need to spare. So if you are going optic chiasm more than 60 gray, low grade glioma, you have to be careful. High grade glioma, patient, it will come after TD 5 by 5, how much? 50 by 5, 5 years is 50 by 5. So it will, that time patient comes to you, patient will not be there. High grade glioma. So why you are getting worried? Then this is skull-based meningiomas. We have to do the DOTA scan, MRI, CT combined together. So this is the very good site where to do skull-based meningiomas and frontal ethmoidal meningiomas. Here you can see properly, you can differentiate by DOTA scan. Re-irradiation, PNR status. Even you are doing a PNR status called pseudoprogression, necrosis and recurrence, that is called PNR status. What PNR status you have to do? Any patient comes to you after glioma radiation, you will have a confusion about the recurrence, pseudoprogression or necrosis. So how to do? You have to do 3 scans as I told, a perfusion, diffusion and MRS. Apart from that, you can do the PSMA scan. So this is the glioma, how to do these things. So progression, new enhancing lesion, increase choline peak, decrease Na, increase perfusion, correct? Necrosis, lipid lactate will increase, choline peak will not increase, and decrease perfusion. Perfusion will be more here in progression and necrosis. So 3 scans will differentiate your from other things, is diffusion, perfusion and MRS. If you are asking for the patient for the MRI, ask the patient to go to write, sir please do MRI, perfusion, diffusion and MRS. PSMA scan, another nuclear scan where we can do PSMA scan for the local recurrence. That is for the patients with glioma recurrence. Other rare glossopharyngeal schwannomas, jugular schwannomas, hypothalamic hamartomas and cavernomas. Response assessment, you have to ask for the same sequences, and again MRI spine and sequences. As I morning I have told already, this is the anatomy, this is the various sectors from the clockwise 1 to 6 to 3 sectors. When you are going for the spinal cord SBRT, you have to do these sequences. As we know, this is the dorsal nerve roots, these are the thecal sac, and this is the T2 image. You can see CSF is white, and this is the sacral foramina, sacral base, sacroiliac joints. So as I told in the morning, you have to cord, you know where cord ends, and you have to take a sagittal and where to see the thecal sac ends in the CSI. So spine sequences, again T1 basic sequences, T1, T2 inversion post contrast, advanced sequence diffusion, susceptibility and Dixon sequences. So here you have to identify properly. T1 there is no CSF is black, T2 CSF is white, but the only tricky to differentiate between star sequence and T2 is abdominal fat. If you see, this is the abdominal fat, it is a white, means T2. If it is T2 star, CSF is white and abdominal fat is white, this is T2. If it is CSF is white and fat is black, it is a inversion sequence. So why these things sequence are important? All T1 lesions, metastatic lesions require hypointense. Then T1 contrast if you give it will enhance. T2 more big, again more, if you give the inversion sequence, it more bright. So it will able to differentiate, and even diffusion sequence also important to decide in the lesion. See, as I told, CT, inversion recovery, T2 and diffusion. So how your GTV is changes with all sequences. Summary, CTMR should be in same thickness, flat curves, discuss with radiology, fuse properly, delineate with radiology, get the result. Thank you. So this is all about the cranial stereotaxy. Will finish or stop or anything? Even if you don't get the presentations here in your pen drive, don't worry. Slide share में जाओ. All 240 presentations are there. You can download freely, nothing to worry. All presentations are freely available. Okay. It is not target delineation SBRT prostate, because the SBRT presentation was that I written SBRT, but it is a total target delineation cancer prostate. It is a very good, this presentation I have made it very effortfully and nicely. Hope you will enjoy. So again, where is the target? Same thing. Morning what do we do? Morning what do you do? We do washroom you go, you have to hot water, cold water matching. Evening what do we do? Daytime OR target matching. Evening what do you go? We have to balance between our mother and wife. So all things we are struggling. So target contouring, as you know, it is a systemic error. So don't give the tense to your partner. Always they are stressed with target OR at hospital, and don't stress your partner at home also. So whatever mother tells, accept. So imaging, plain, contrast, oral, contrast, IV contrast, arterial phase, venous phase and delayed phase. So what schedule, dose, target and protocol? There are various protocols, energy protocol, phase A, phase B, hypo-RT, prime study is an Indian study. So as a Make in India procedure, I am mostly confined into the prime protocol. So this is the ISTRO and ECROP consensus guideline for CTMR based prostate contouring guideline. So diagnostic, you need a CCT pelvis, multiparametric MRI and PSMA. But in
target delineation, all things are not required. You just T2 MRI and CT is sufficient. Target, what are the target? Prostate, seminal vesicle and nodes if needed. Next, we have to, if you have a backlog, you don't need a, remember, you don't need a SBRT board for the treating SBRT liver, lung, we just to treat with backlog. Unnecessary, the vendors will come, sir, you take the 35 lakhs, 45 lakhs, don't need any the extra SBRT board. Okay, so supine, backlog, or if you have a SBRT board, with or without needles, hands above head. This is the simulation procedure. So imaging protocol, supine with knee rest, desirable with full comfortable bladder, empty rectum. Enema should be must. If you are going for a 20 fraction radiation or 35 fraction, 36 radiation, everyday enema is not possible. You give laxative, but if you are going for SBRT, always you have to 5 fraction schedule, you give the enema every day. So axial CCT, T2 MRI, T2 2 to 3 mm slice, upper border of the kidney to mid thigh to know, understand the paraotic nodes also, and anal verge marker. What are the ORs? Bothering bowel. Why it is bothering? Sometimes swollen, sometimes collapsed. So this is bothering bowel. Farly placed femoral head, bubbling bladder. Sometimes is more, sometimes is empty. Irritating anal rectum and unknown urethra. Nobody about the unknown urethra. So prostate, if you are planning for prostate SBRT, 36 into 25 in prime and phase B protocol. If you are negative nodes, you can, high risk you want to treat the node 25 in 5 fraction. Positive nodes, you have to give this one. So what are the steps for contouring? Always screen the scan. Don't directly jump to the contouring. From whatever the slices you have taken, you think that it is a blessings. So from the lung, upper border of the slice to the lower border of slice, screen, find new things. Sometimes you will cancel the procedure. Fuse T2 with CT, review anatomy, draw the ORs, draw the prostate, separate it from the A, B, C, D, E, F. What is A, B, C, D, E, F? I will tell you. Draw seminal vesicle, measure in sagittal, draw GTV node, draw CTV node, draw prophylactic nodal volume, Boolean all, prostate and SP volume, gross nodal volume, prophylactic nodal volume, and PTV 7.7. Keep the posterior, it is a 0.5. This is the steps. So take MRI in same position in CT, fuse with area of interest, not pelvis to pelvis. Why? MRI is our limb structures. Sometimes I put like this, external rotation. You've taken the MRI in external rotation. You are taking CT in the internal rotation. So it never matches. So how to handle these things? So contour the pubic symphysis and contour the ischium. Understood? And limited matching. You make a box, limited match that pubic symphysis and ischium matching only. Not match the whole organ. Whole pelvis you will never match in lifetime. Okay? So screen the scan. Pre-NHT, pre-hormonal therapy, PSM scan, CT scan, multiple scan, pre-RT, T2 and CT. What we have to see? Prostate, capsule, external, extracapsular extension, node, seminal vesicle, urethra and vessels. These structures you have to screen the scan. Then quick review, as you know, this is the rectum, this is the prostate, this is the penile bulb, this is the pubic symphysis, this is bladder. What is the structure in between here? Genitourinary and diaphragm. A union B. A apex union is the urogenital diaphragm, B is the penile bulb. So you remember A, U, B. So how to differentiate? I will tell you. So when you go for the T2 MRI, this is called a central zone. This is called peripheral zone. Peripheral zone is more prominent. Okay, more hyperintense. Then this is what is this structure? Neurovascular bundle. Okay, so this is the stromal and glandular tissue. This is the anterior fibromuscular stroma, and this is the peripheral zone. This is the peripheral zone. So central stroma, central zone gland is much more. So this is the prostate gland. So if you see the prostate gland, always T2 there is a darker area or low signal intensity. I am telling about how to identify the MRI things. I am not going to the for contouring directly. I'll understand the imaging first. Then, as you know, what are the structures where miss the structures? Where this is the bladder base, this is the rectal area, white circle the anterior base, middle base and posterior base, arrow mid prostate and dark at the apex. These areas they have shown that people mostly fumble, mostly miss take extra. So, you have to take the help of all views for better visualization, a cranial, sagittal, oblique, whatever the views, anything you want to do. So, MRI is not there with me. Can I go ahead to do the SBRT or not, contour or not? So, there is a CT and MRI based comparison. It is there in ISTRO-ACROP guideline. If you are not MRI, don't worry. This is the CT guidelines how to do. Okay. So, what are the A, B, C, D, E, F of prostate contouring? Remember, this is the lifetime learning. A for you, prostate contouring is very easy. Contour the prostate. It takes hardly 1 minute. But separating from the A to F structures is the, if you are really want to do contouring, you have to spare this A to F structure. What are the A to F structures? A for levator ani, B for bladder base and penile valve, C for anorectal canal, D for diaphragm, genitourinary diaphragm and different duct, E for neurovascular bundle, urethra, venous plexus, F for fibromuscular stoma. So, this is the A to F structures. How to differentiate? I will tell you one by one. So, levator ani. Remember, prostate, this is the levator ani muscle. You can see this levator ani muscle. This is levator ani muscle. You can easily see in the MRI as a black structure. So, this is a T2 image. We no need to T1 image, you no need to analyze anything. Contouring time only T2. So, this is the levator ani. Then, so this is the levator ani. At the note that transition from the concave, the levator ani is sometimes concave and sometimes convex. So, convex of levator ani, note the transition of convex levator at the apex versus convex at below the apex. Convex below apex it is convex and above apex it is the concave. So, this is the things you have to differentiate. Understood? First thing, structure to differentiate from the contour is the levator ani. Then bladder base and penile valve. B, bladder base. So, how to contour the bladder base? So, your prostate gland is touching to the bladder base here. So, it is a you will fumble here. How to differentiate? Let us see. So, what you do? You do the contrast CT, ask the patient to wait for the half an hour and go for another CT. What will happen? You will able to, the contrast will come and put in the bladder. Okay. So, you will able to differentiate which is bladder wall and which is the prostate. Understood? It very easy. Understood? So, bladder protocol, follow bladder protocol, take CT, empty the bladder, again bladder protocol, take another CT. Okay. Then anorectal canal. So, another fumbling area is the this anoprostate margin. In anoprostate margin, again you have to fumble because the rectum contouring is very easy to contouring, but when it is you will fumble between the anorectal and prostate contouring. So, what you do? You do contouring one slice above, one slice don't do, and bullion it. So, automatically it is a very crude method of delineating the anorectum. Another is the diaphragm, D for diaphragm. How to separate the diaphragm? Diaphragm, urogenital diaphragm is a muscular structure. So, all muscular structure in the T2 MRI looks like a black fibers. So, this is the see here, this is the prostate, this is the urogenital diaphragm. Okay. Then your penile valve. So, you see this is the rectum,
These are the all muscle, pivococcygeal muscle, iliococcygeal muscle, this is urethra. So these muscle fibers, if you see, it looks very darker. So you have to remember, this is the apex, this is the diaphragm, this is the penile bulb. So if genitourinary diaphragm, again it is a 3 parts: triangle, hourglass, oval. Okay. So from the top to bottom, a bottom superior genitourinary is a hourglass structure. Okay. This is hourglass structure, superior good. Mid good is the circular, inferior good is the triangular. So so this is the summary of hourglass, oval and things. So you just, so this is the cranial is the hourglass, middle is the oval and caudal is the triangular. So why this is important? If you are not able to, if you only prostate practicing, those are practicing genitourinary, they are able to practice. But if you are not able to practice, try to get it. Over the years, you will be able to understand. D for duct or vas deferens. So these structures, vas deferens also you have to exclude. The yellow arrow indicates the vas ducts. The different duct consists of thin tubular structures that we recognize cranial and medial to each seminal, should not be included in the delineation. Extra structures, one is the neurovascular bundle. So neurovascular bundle contouring, sometimes people say don't take it, some people say take it. Choice is yours and you go through the guideline. Neurovascular bundle and urethra. So this is the urethra. How to identify? It is a very again tough job. If you are able to do not. So how? Urethra in MRI, what happens? You have to MRI. You are going to contour after the delayed contrast. So you will find there is a track. You have to find the bladder wall, you will track that contour urethra. If you practice 2-3 times, it will happen. Then venous flex of Santorini, here sometimes we contour these vessels. So you have to exclude that. If you no need to include that. So how to do? You have to take in a patient from the arterial phase. If you get good arteries and venous plexus, you see, you can discuss, or if you want to take the MRI fusion. Fibromuscular stroma. Anteriorly, behind PV symphysis, there is a fibromuscular stroma. That helps to be also excluded. So, A to F structure, so nicely I told you. Hope you will remember. Easy. Go and practice. Delineating the seminal vesicles. Patients without seminal vesicle, only 1.5 centimeter of seminal to be included. Entire seminal vesicle included if it is involved. Take the sagittal plane. So you have to take the sagittal plane. So these are T2 seminal vesicles and vas deferens. So as I told, if grapes are looking good, this is good seminal vesicle, and grapes are rotten, then it is a seminal vesicle involvement is there. So these grapes are good, these grapes are gone. So it is a hypointense lesion that involving the seminal vesicle. So you have to go by thin slice, 1 to 3 mm slice. You just practice. Even though contour is not there, if you get some MRI, you just contour like that. Then, what you do, delineating seminal vesicle, you contour prostate. You contour 1.5 centimeter margin. So this 1.5 centimeter is your seminal vesicle. So you can contour this seminal vesicle. This is another extracapsular extension. So if you see, this is the prostate and thin darker area is the capsule. This is the capsule. And MRI you see, if there is extracapsular extension, you can see this is the extracapsular interaction. So you have to, in extracapsular interaction, you have to see the circumferential extension and radial extension. So this is the how you will find how much that capsule has involved. See, this capsule is involved. Then this is the thin capsule, black capsule around the prostate. Compensating extravascular extension. If you have a tumor is there, if there is extravascular capsular extension, give 3 mm margin. in that area at least. So CT only recommend 3 mm extension of the prostate contour need to be applied. Expansion of prostate contour to 3 mm in inferior, lateral, anterior, posterior direction, exclusion around the rectum. So extraclavicular extension you can give 3 mm margin except in the rectum side. Then handling the prostatic apex is CT based. If you don't avoid the CT, MRI, you just contour the penile bell, opal border and prostate. At least there should be 1 centimeter gap. That 1 centimeter gap is the your urogenital diaphragm. If you know MRI. Then delineating anorectum, as I told, contours irregularly, Boolean. Then femoral head contouring also you should not do like this, you have to contour till the lesser trochanter. Then delineating the penile valve, so this is the penile valve, easy to identify, and this is the MR. Delineating the penile valve is important, this is the penile valve structure, this is the penile valve. So penile valve also is a wire, you can take the boundaries, and this is a triangular teardrop structure. Remember. So delineating the bladder, as I told, you have to take delayed scan, you can contour the posterior wall of the bladder so nicely. Delineating urethra, as I told, this is the urethra, hyperintense T2. So you can track the urethra contour as much as possible. Practice. Delineating the bowel bag, as a full bowel bag has to be contoured. Nodal volume, as you know, contour like pelvic nodes and exclude from the bone muscles. 5 mm for the PTV, and CTV is the at least 98%, PTV 95% should get. These are the OIR constraints for the SBRT arm by prime study. Follow guideline, T2MR is the best. If MRI not there, you can plan with CT based. Avoid A, B, C, D, E, F structures. That is the total about the prostate contouring guideline. Thank you. Understand?